request all of you to, bring in your opinion, your questions to make it more and more interactive. In the end, before, after basic approaches, we'll go in detail about the facial nerve reanimation and reconstruction and many more concepts of the facial nerve. Facial nerve science is one which still, in infancy in our country, and many of the people or the junior colleagues are not opting as a career. In Western countries and many centers, many universities, facial nerve is a different department. Facial nerve rehabilitation is a huge subject, and there are many, many ways to rehabilitate the patients with facial nerve, right from primary decompression anastomosis to the, bigger and bigger reanimations for long-standing facial nerve palsies. And we'll discuss all these along with the anatomy of the facial nerve, all the options what we can offer to our patients in different situations. Then finally, before ending the lateral skull base, we'll go into the one of the most complex thing, which again is not being adequately addressed, everywhere, is the temporal bone malignancies. Temporal bone malignancies, we know, temporal bone itself is a very, very complex bone situated between the middle and the postcranial fossa with a lot of critical structures, tigers running through it, a lot of neurovascular structures running through it, including carotid artery, sigmoid sinus, jugular bulb, all cranial nerves, all middle lower cranial nerves are running through the temporal bone. So, looking at the complexity of the anatomy and the relationship with the critical neurovascular structure, excising temporal bone in toto is a huge task. And that's why majority of the people are doing, at the end when they are operating, a piecemeal resection. In oncology, piecemeal resection can never be a sound operation, but by default, because of this problem of complexity of the surgery, we are forced to do piecemeal resection. So this science, again, we have been propagating for years after one of the Japanese guy who, promoted and published this series of subtotal and block temporal bone resection, which is amazing, amazing surgery to give a cure to these patients. So in that, the entire temporal bone resection is disconnected from its all surrounding connections. Temporal bone is, situated at such a critical area with connections all around with the sphenoid bone, with the parietal bone, with the occipital bone, and inside is the entire lateral skull base and the, cerebellopontine angle and other critical areas. So excising the entire temporal bone and block with minimal morbidity is the, need of the time to cure, give, adequate treatment to these poor patients having temporal bone malignancies. Otherwise, they have been by default subjected either to the piecemeal resection or radiation therapy, which is never adequate. So like for any cancer, the oncologically sound operation is a en bloc resection with negative margin, and this is the need of time in the temporal bone, more in the temporal bone, because in piecemeal resections, we cannot ensure, in spite of a visibly good surrounding area you have left, you cannot ensure a complete removal because temporal bone has a lot of avenues for the tumor to spread out of the temporal bone. A lot of neurovascular foramens, fissures, windows are there in the temporal bone through which the tumor can spread outside. Beyond the surgeon's visibility, and this resection and block can ensure a good surgical clearance with all around, removal of under vision, removal of any extratemporal structure which is involved. Like, for example, once there is a temporal bone malignancy, advanced malignancy, the parotid is always included in the specimen because the first echelon lymph nodes are to the parotid. TM joint is very, very close to the external auditory canal, and the lesions from the external auditory canal in no time can easily spread to the TM joint through the fissures of Santorini and all that. So TM joint, parotid, infratemporal fossa, everything can be excised to whatever level you want to under vision in this approach. So this is one of the, finest skull-based surgery, most extensive though, but it is something which is a boon to the patients with the temporal bone cancers to give them a cure. So we'll start with the basics and then move on to the more advanced things and then to the endoscopy part. So This cadaver, it's a fresh frozen cadaver, and the preparation, you can see the dyes injected into the venous and arterial system to identify the veins and the arteries separately, you can see. So this is something amazing as a learning tool for everybody. This this is the lowest one. Can you bring the external camera here behind? So I am on the right side. We'll use both the sides ultimately to show all the
Morning,
approaches. I
morning,
hope the picture
Satish
is
sir.
good there.
Hello, Satish sir.
Sir, picture is good.
Picture is good.
Yeah. Right.
Is Deepak sir there in the auditorium?
Just to come, sir.
This is the lowest.
Very much. I am here.
Thank you, sir. Thank you once again
Yes,
for
boss.
everything.
Yes, boss.
So once we approach the temporal bone, in this era of extensive resection, we always look for the tissue for the reconstruction. Rather than the free tissue for reconstruction, vascularized tissue is the ideal tissue for the reconstruction to prevent necrosis, give ready vascularity, and a better reconstruction overall. So around the temporal bone is a lot of tissue, vascularized tissue, which can be used differently in the different situations. Can you bring the external camera? So I will show with the external camera to begin with. इधर इधर आ जाओ, क्या चलता है? या इधर और इधर आ जाओ. Can you bring the external camera picture bigger? Here. So I will, before going to the temporal bone, quickly I will just touch upon the various, tissues which can be used as a vascularized flap for the reconstruction when needed. This is very, very important in different situations. Even when you do a canal down mastectomy, in order to give a dry ear, you need a variety of tissues according to the size of cavity and the situation to reconstruct to give a dry ear. So we need to know variety of tissues available around, and this has been very well understood now with the understanding of the vascularity to this area. The neurovascular innervation has been better understood now, so we can utilize that information to develop variety of flaps. Yeah, can you can either say or either say. Yes, and focus here. Right. ये center रखो. This is in the center. Zoom out. Zoom out. Yes, zoom out. This is too bright. Boss, Vishwas, that light is too bright.
Good morning, Satish sir.
Yes, sir. Yeah, this is
So
better.
this is Dr. Uday from the Taj. We are just coordinating, sir, moderating, along with Dr. Dandi Manjunath, sir, and Dr. K.C. Prasad, sir.
Super. Welcome.
Thank you, sir. We're waiting for your dissection, sir.
So,
Eagerly waiting.
before moving on to the temporal bone, as I said, we'll just discuss a couple of things about the flaps available in this region. We know this area of the temporal bone is richly supplied by vessels all around. The principal vessel supplying this region, principal vessel, is from below or the external carotid branches. So one of the posterior branch of the external carotid which supply this region of the posterior part of the temporal bone and the pinna is the occipital artery. So occipital artery, I'll show once I go in the depth how deep it is. It runs deep to the digastric, then make a groove over the mastoid, over the temporal bone, and then go towards the superior nuchal line. So this occipital artery gives blood supply to this entire region through various branches. Then above this, is another branch from the external carotid will show that origin of that posterior auricular artery to supply the pinna all around. Then another branch, this external carotid divides into two branches, terminal branches. The maxillary artery goes underneath the mandible will show. We'll see all these, all finer anatomy today, which is very, very important for the, surgical exercise. And then the superficial temporal artery, which is very, very superficial as the name implies, crosses the zygoma and then supply by dividing into various branches, supply the entire temporal region. There's a principal vessel in the entire temporal region. So if I make, one of the flap, which is very commonly used for various regions, is the temporoparietal flap. Temporoparietal flap is a huge flap in the entire temporoparietal region, just underneath the skin. Just under, see in this layer is the layers of tissues. Just underneath the skin is the temporoparietal fascia. Just underneath the hair follicles, and we can raise this entire temporoparietal fascia based on the superficial temporal artery, making the incision and the flap very, very superficial. You can, make the entire temporoparietal fascia flap. This is quite, a strong flap, very, very robust flap. It has a bulk as well can be used for the lining as well. So after the temporal bone, like partial resection, after the lateral temporal bone resection, after the huge mastectomy defect, one can bring in, based on this vessel here, you can rotate the entire flap into the temporal bone very easily. This flap many a times we use after the endoscopic skull base resection. You know, in the endoscopic skull base, there are lots of flap in the nose. When the time permits, we'll show you. Right from the hadar to the lateral wall flap to the, pericranial flap and many other palatal flaps and sometimes because of the previous resection, you fall short of flap. Again, this flap, you can rotate from underneath the zygomatic arch and through the infratemporal fossa, you can easily rotate at the skull base. This is a very, very robust flap, very, very vascularized flap on a terminal branch of the external carotid, and you can take it inside. So that is the temporoparietal fascia flap. Underneath the temporoparietal fascia is the true temporalis fascia. True temporalis fascia is what we use simply for the tympanoplasty. A thin flap. Let me show you. Let me show you, Pakanda. Let me show you. See, I'm making a wider incision so I can use it for the other skull base approaches as well. So I'm making my incision right from the superior temporal line. Right from the superior temporal line, going a couple of inches behind the pinna. So the same incision I'll be using for the other skull base approaches. See this? I can elevate this flap. From here, I will show you the various tissue planes which can be developed into flap. This is very, very important even for the regular otologists who are not doing skull base, because such tissue is needed many a times for the better reconstruction of the mastoid cavities. See, such a huge tissue around. This entire tissue, musculoperiosteal tissue, can be used in various layers for the various purposes.
The elevation is just under the skin, sir.
Pardon?
The elevation of this flap.
No, I am through the temporoparietal fascia plane.
Okay.
See, this entire tissue which is coming along the skin. Can you see the thick tissue?
Yes, sir. Yes.
This is all temporoparietal fascia.
Okay.
All temporoparietal fascia is a thick one and can be used to cover or to obliterate the various defects. Can be used as a lining. You can line the entire temporal bone defect after the huge mastectomy and can apply the fascia over it, over the vascularized tissue for the better uptake of the fascia. So can be used by various ways, the different tissues. So I'm elevating the entire thing to show you better.
For the sake of the audience, this is the type of the incision we make for infratemporal fossa type B approach.
Pardon?
I was just saying that this is the incision. So even for infratemporal fossa type B, we take like this.
See now what plane I am in. This is the
Yes, sir.
temporalis fascia plane.
Yes, sir. Yes.
This is the temporalis fascia plane.
Yeah.
So some of us, we identify the temporalis fascia first and then keep that as a landmark and go in that plane.
Yeah, one can easily identify the temporalis fascia. We are so used to, you know, harvest this for the tympanoplasty purpose. The same fascia it is. See this?
Yes, sir. Yes.
Same fascia. It's a huge area, more than you can say 20 centimeter area can be converted into a flap.
Okay.
So even for cochlear implant, can we go in the same plane for the flaps?
For the,
Implantation, cochlear implantation, when you raise the flap, is it the same plane we need to go?
you can use this for the primary implant,
Yeah.
but for the primary implant, the common flap which we use, you
Yeah.
don't have to go so high up.
Okay.
In that situation, let me show you. See this whole temporoparietal region,
Yes, sir. Yes.
and I will show you couple of, like you asked for the cochlear implant, couple of useful flaps for regular purpose. See, I told you this is the sternemastoid muscle.
Yes, sir.
Yes, sir.
This is the mastoid process.
Yeah.
In a regular mastoid surgery, whether we have planned a canal wall up or down, the final decision is intraoperative. The regular post-auricular musculoperiosteal flap we use is the simplest manner. We make the incision here at the inferior temporal line,
Yes, sir.
then just behind the canal,
Yeah.
and raise this entire flap as a routine, whether needed or not. Whether needed or not,
Yeah.
this flap is elevated. See this?
Yes, sir. Yes. Yes.
And if not needed, you can replace it back at the end of the surgery.
Yeah.
Never an issue. But if needed, if you have done a good canal down, then at the end, remove the tip and you can place this entire flap in the cavity.
Yes,
This
sir.
is richly vascularized by the occipital artery. See, you get such a huge tissue
Yeah.
for the reconstruction, partial obliteration of the cavity, and additionally, this is a vascularized one. The beauty is you can never damage the vascularity. The vascularity comes from the deep,
Yes, sir.
from
Yes.
the depth. The occipital artery, I will show you exactly where the occipital artery comes.
Yes, sir.
Vascularity comes from the depth, one can never damage. If you don't need this flap at the end of the mastoid surgery, you can replace it back like this.
Yeah.
If needed, if you have done a canal down, remove the mastoid tip for this flap to go inside easily,
Yeah.
and you can partially obliterate the entire cavity till tegmen. And if you apply the temporalis fascia further, to line, the fascia can be laid over this vascularized flap for the
Yes, sir.
better take-up of the fascia.
Yeah.
Rather than a dry bone, if you place the fascia on a vascular tissue, the take is very good. So this is occipital artery-based flap.
Okay.
For cochlear implant, for regular cochlear implant, if we raise the inverted flap, then we don't make a cut over here, we make a cut at the lower end of the mastoid tip and raise the flap above, keeping superiorly based, so that your implant, your array, everything remains hidden underneath the flap.
Okay.
That's my point?
Yes,
Yes,
Then
sir.
it is superiorly based. So it respects all the principle of vascularity in this region. Then this is temporalis fascia. We all know we harvest in our clinical practice this temporalis fascia. Now
Yes,
I'll
sir.
use the microscope to show you
Yeah.
better anatomy in this region. Can you change the microscopic picture, please?
Sir, you said this is inferiorly based on occipital artery flap, that one.
Yes.
Which one you advise, sir? Is it inferiorly based, based on occipital artery, or posteriorly based musculoperiosteal flap for obliteration of the cavity?
Yeah, this inferiorly based is a better alternative.
Okay.
In the sense, it is a very, very robust because it is based on the main vessel, occipital artery, not on any branch.
Okay, sir. Okay.
Number one. Number two, it can be replaced if unused
Okay.
without giving any morbidity.
Yeah.
And third is, it can be taken right up to the tegment to cover the entire cavity. See this?
Yes, sir.
It's a
Yes.
huge tissue.
Yeah. Yeah.
So this can be a very, very useful flap. Now see, above is the temporalis fascia. See
Yeah.
this?
Yes, sir.
Entire temporalis fascia we use as a free graft.
Can
But
we
here
little
if you
bit
want
zoom out, sir? Zoom out
to
little.
line the cavity, again to line the cavity, this temporalis fascia, see this?
Yes, sir. Yes.
Entire temporalis fascia can be raised as a flap.
Okay.
This is the
It
minimum.
is only fascia, sir. Only temporal fascia.
Only temporalis fascia.
Okay.
This is probably the minimum. This is minimum.
Yeah. Thank you, sir. Thank you. Fine.
Yeah, very similar. See that this is only temporalis fascia.
Yeah.
किधर करूं? How to do white balance?
Yeah. Now it's clear.
Better?
There is
Better? Hello?
little bit focus, sir. Fine focus, if possible.
Okay.
Earlier, sir. Earlier one.
Earlier one was
First
better.
Now, so just this temporalis fascia can
Yeah,
be
yeah.
used
This is better.
Yes,
as
sir.
a vascularized flap or lining again.
Okay.
This fascia is not based on the superficial temporal artery.
Yeah.
This is based further anteriorly on the deep temporal vessels,
Yeah.
which comes from the depth from the muscle. See this muscle, temporalis muscle below?
Yes, sir.
And can you see the vessels in the temporalis fascia?
Oh, yeah, yeah.
Number
Yeah.
of
Here.
arcade of vessels. See all over.
Yes, yes.
Arcade of vessels. See what a great injected cadaver.
Yes,
Once
sir.
again, thanks to Deepak sir. See this?
Yes, sir. Yes.
Arcade of vessels in this fascia. Huge fascia. Can you see?
Yeah, yeah.
This can be used as a vascularized flap. If you really want to line the cavity good, if you have a good huge cavity, you can lay down the, this occipital artery flap first. And if you really want to line with a vascularized flap again, you can
Sir.
use
Yeah.
this entire temporalis fascia, huge one. Again, almost 20 centimeters. See this?
Yes, sir. Yes.
And based on the vessel here down, you can bring in from anteriorly and rotate the entire thing in the temporal bone. See, this entire thing can be rotated. That will be vascularized temporalis fascia. We have tried in certain patients tympanoplasty with a vascularized temporalis fascia graft, and the results are amazing. It cannot fail. It cannot necrose. This is a vascularized tissue. It cannot necrose like a free graft. You know? So this is amazing, but the only thing is you need to do a lot of dissection. You need to go high up, far anteriorly. Scar is an issue, though scar is hidden, but still it's a great option in lining the cavity for many regions. See this?
Yes, sir. Yes.
You can rotate, the vessel is here, the deep temporal vessels are here, and you can rotate this entire flap. You can, double breast this flap to lengthen it. See this? Because this is a segmental vascularity. I can enlarge the length of the flap to make it bigger, To make it bigger, I can make it bigger and bigger by making it bipedical. See this?
Yes, sir. Yes.
This is vascularized temporalis fascia flap.
Yeah.
One can use for many purposes. Okay?
Yes, sir. Yes.
Now, this is supplied by the deep temporal vessels here. Now, below that is amazing, huge. See temporalis muscle. Can you see?
Yes, sir. See.
Right from the superior temporal line. See, this is a huge muscle. Initially, Palwa described a single flap of this muscle. This muscle is again has a segmental blood supply. This is unique, and this understanding is very important to plan various flaps for various purposes. From anterior to posterior, this anterior 25% of the muscle is supplied by the anterior deep temporal vessels, branches of internal maxillary. The beauty of this vascularity is the vessels come from below. Vessels come from the depth, enter into the muscle through the thickness superficially, from deep to superficial,
Okay.
and make an arcade of various, capillaries and various branches. to run through the muscle as a network everywhere. So anterior 25% is supplied by majority by the anterior deep temporal arteries. Middle 50% or so is supplied by posterior deep temporal arteries. You can use separate flaps or you can use entire flap as a combo. You can use a bipartite flap, you can use a tripartite flap, and the posterior, 20 to 30% area, this is supplied by the posterior deep temporal, superficial temporal, and the middle temporal vessels. So
Yes, sir.
this only sole posteriorly can be rotated to the temporal bone. Posterior 2/3 can be rotated. Anterior 1/3 can be used for, lining the orbital defect, lining the oral cavity defect, and
Yes.
for many more purposes. And we'll show later how to use this as a temporalis lengthening myoplasty for facial palsy as a facial palsy. This is one of the procedures described and modified by the Lebe, the temporalis lengthening myoplasty, in which the entire temporalis muscle is elevated, only left anteriorly attached, posteriorly elevated, and it goes down to insert on the coronoid process. Separated from the coronoid process, the muscle elevated from the posterior attachment, lengthen and suture to the modulus of the lip for the facial palsy, for the ipsilateral facial palsy, to give dynamic rehabilitation. That is lengthening myoplasty of the temporalis muscle. So we should know the beauty of these flaps God has given us. Now this is temporalis. Let me elevate a little bit from the posterior surface.
Sir, just in what I want to know, see this huge rotation of these flaps for obliteration of the cavity. Is it for a routine canal wall down or in the temporal bone resection or in subtotal petrosectomy?
For all purposes, you have now variety of tissue. It depends upon how much tissue you need, how much bulk you need, how much lining you need.
Yes, sir. Yes.
There are flaps for the lining like temporalis fascia. Flaps for the bulk like, this occipital base, this temporalis muscle, temporoparietal fascia. All these can be used for the bulk as well as lining.
Yes, sir.
So depending upon the defect, site of defect. Now see what I'm doing. I'm dividing this temporalis at the posterior edge. Can you see?
Yes, sir. Yes.
I'm dividing the muscle.
Yeah.
Dividing the muscle here posteriorly to show you something. Underneath the muscle, this is a distinct layer of periosteum, pericranium. Can you see there underneath? This is.
Yes, sir. Yes.
So this is the pericranium. This is amazing. This is amazing layer, can be used as a vascularized layer, and we have been using, this is pericranium, and see the various vessels running through the pericranium. See, this is entire pericranium which is intact.
Yes. Yes.
So the entire region pericranium. Where is the pericranium? Let me elevate and show you. This is pericranium.
Okay, sir. Okay. It's close.
Okay. This is pericranium.
Yes, sir.
This is another thin vascularized layer for the lining. And we have done couple of tympanoplasties also with this vascularized pericranium. Huge. This is based on the middle temporal vessels here, coming from the superficial temporal artery. Thin layer, be careful, elevate the entire thing and rotate towards the canal. This can be used, sometimes you have a bare extraordinary canal with no skin.
Sir, you said you have done tympanoplasty with this flap.
Pardon?
You said you have done some cases of tympanoplasty with this flap.
Yes.
Pericranium. But what was the indication, sir, for this?
Sir,
what are the results?
Yeah, what was the indication? Why you use this?
Indication was to try this vascularized flap for tympanoplasty. We are thriving for the better results. What we are using presently is a free graft.
Yes, sir.
Free graft has to acquire the vascularity.
Yeah.
And can get necros. And there is a certain percent of failure rates in everybody's hands.
Yeah.
If the vascularity is not achieved, because it's a free graft, can get necros.
Okay.
So vascularized tissue is something with certainty it is not going to necrose. So
Yeah.
this is a vascularized flap. See this?
Yes, sir.
Vascularized flap. So from the entire region, this periosteum can again be, pushed inside the canal, like I showed you the fascia, and this can be used as a vascularized flap. We are not using, regularly for the tympanoplasty.
Yes,
Still
sir.
sticking to the, age-old technique
Yes,
of
sir.
using the fascia graft. But yes, this is option. See, there's a pericranium everywhere
Yes,
and
sir.
a huge blood supply, and
Yeah.
these are the middle temporal arteries running as a railway track appearance coming from below,
Yeah. Yeah.
So
which is
especially
supplying
in
this entire.
sir, especially in this revision canal wall down surgery, sir, I've used
Yeah, so
couple of
this can be
times.
used to line the
Very,
canal.
yeah, pericranial flap, and it takes up very well. Revision
Yeah.
canal wall when there is no fascia available.
The
Uh,
beauty where we are always using is to line the canal defects.
Yes, sir.
Sometimes you are left with a situation where the external artery canal is left completely bare. And
Okay.
lining, secondary healing of the canal is a tough task, difficult task, and it may take months and months and invite infections. In that situation, you can line the canal with this vascularized flap, thin flap. This is very thin. And you can put split skin graft over this, which can be easily, taken up later on over this vascularized bed. This works as a vascularized bed for the split skin graft to take up. See this?
Yes, sir. Yes.
So can be used as a vascularized flap for the split skin graft. This is very useful in the canal. Sometimes you're left with a bare canal and it suppurates, it invites infection, it doesn't heal so easily. And this flap is amazing. This is, see, another layer. This is pericranial layer.
flap.
Okay. So we have number of layers of tissues in this region. What I wanted to show is we have variety of tissues available, and we have to take the advantage of this, understanding of neurovascular anatomy to use it appropriately for various indications. Okay?
Hello, sir.
Hello?
Basic question. When we
Yes,
give
please.
post-oral incision too anteriorly to obtain a graft for the exposure or anything, so we are likely to damage the branch of one of the branch of the superficial temporal artery, which actually bleeds torrentially most of the times when we go the upper incision too much anteriorly. Can you just show
For the graft.
No, yes, sir. For in the revision cases, and when we want the incision to be more anteriorly, the
Yeah.
branch of the
Yeah.
superficial temporal artery cut
Yeah.
gets
This temporoparietal region is richly vascularized, as I said.
yes, sir.
So
Can you
if
just
you make indiscriminate incision anywhere, this is going to bleed. This is richly vascularized everywhere.
yes,
See
sir.
this? This is temporoparietal flap above. See this? This is
Okay.
temporoparietal flap, and this is a branch of superficial temporal. See,
Yes,
dividing into two.
yes,
Can you
sir.
see?
Yes, sir. That's what.
Entire temporoparietal region is so richly vascularized. So, making incision in this region, you must have the understanding of the vascularity. Otherwise, one can directly damage though these are not end arteries, but why to unnecessarily damage them to, invite problems. So be careful. Now see what I'm doing. I have divided the canal. Can you see? Can you see the exotic canal?
Yes, sir.
Now, better? This is the exotic canal I have divided. Can you see this?
Yes, sir. Yes. Yes.
And we must know nowadays the blind sac closure is a
Sir,
common surgical
there's a-
procedure for
can
various
we,
indications,
sir, can we go a little bit to zoom out, sir? I mean, it looks magnified.
Zoom
Can we
out.
go zoom out?
Boss, in this microscope, this is the minimum, magnification.
Okay. This is the
What I
minimum,
see.
sir? This is the lowest one?
Yeah, this is the lowest one.
Okay, sir. Okay, fine. Yeah.
Hmm.
Yes, focus. Thank you.
Better?
Yes, sir. Yes.
Okay. See this. This is the exotic canal which I have divided.
Yes,
This
sir.
is the
Yes.
exotic canal.
Yeah.
In our surgical practice nowadays, when you do blind sac closure,
Yeah.
you need to do you need to close this canal by everting the canal out.
Yes, sir.
That what we do, see this, I will show you. This is the canal.
Yeah.
For better understanding, yes. This is the canal. This is the
Yes.
canal.
Yeah.
This is the canal cartilage. So what you need to do is you have to elevate this skin. See this?
Yes, sir. Yes, sir. Yes.
From the underlying cartilage
Yeah.
with a knife in the live surgical situation,
Yeah.
like this.
All around, sir.
Elevate this skin
Okay.
as a sleeve all around and bring it out.
Yes.
See this? Like this.
Yes,
This
sir.
is the
Yes.
canal. You
Yeah.
have to elevate as a sleeve
Sleep.
and bring it out to do a cul-de-sac closure. And underneath, after elevating this skin, see this?
Yeah. Yes, sir.
I'm
Yes.
showing with a cautery here,
Okay.
which is not to be done in live surgery. Once you're brought out, you
Yeah.
can suture. This is what? This is what tragal cartilage here.
Yes, sir.
Suture to the conchal cartilage here. This is the conchal cartilage here. You can suture these both cartilages underneath as a second layer of
Okay.
reinforcement. Got my
Yes.
point?
Yes, sir. Yes. As a
Bring this
second.
skin out and suture tragal to the conchal cartilage so that it doesn't break inside again like this.
Yes.
So
Yes.
that will be the perfect cul-de-sac closure. Okay?
Yes, sir.
We can even reimpose with the third layer, sir, taking a flap required. I think two layer is more often enough.
Hello?
Yes,
So
sir.
this is for the cul-de-sac closure. Okay?
Yes. Yes, sir.
So one must know about the cul-de-sac closure. Nowadays subtotal petrojectomy blind sac closure is one important procedure I believe everybody should know for various indications. This is, opened up new avenues, to address various complex things which were not being addressed earlier. Subtotal petrojectomy and obliteration remove the disease from the air cell tracts of the temporal bone everywhere.
Yes.
Entire air cell tracts from the temporal bone is removed, preserving the labyrinth.
Okay.
And then obliterated with the fat, and this blind sac closure is done after obliterating the eustachian tube. So practically, you block off all incoming sources of connections and infections to the temporal bone. From outside by obliterating this canal,
Yes, sir.
from inside by,
Eustachian.
by blocking the eustachian tube.
Yes.
So this way, you block off all connections to the temporal bone to prevent infections reaching to the temporal bone later on.
Yes.
And this is a very popular, indication nowadays for all difficult to consider cochlear implantation. You know what happens in cochlear implant? You put the implant, which is a foreign body.
Yeah.
Imagine with a foreign body in place and the patient or the child, whoever, develops infection later on in the temporal bone. What is going to happen?
Yes.
Controlling that infection is most difficult than with a foreign body in place. And many a times, with the infection around the foreign body which acquire biofilms, ultimately you end up explanting. And
Yeah.
that's a disaster. So, our policy for all patients, all cochlear implant candidates, wherever there is a possibility of infection in the future by means of some or other pathology going on, by means of, nasal pathology, ongoing CRS, allergy, whatever, eustachian tube malfunction, any single otitis media, suppurative otitis media can ruin everything after the implant. So those patients who have a high likelihood of developing infection, we better, do a subtotal petrojectomy and obliterate, because the middle ear, after the implantation, middle ear anyway is not going to participate in the hearing scenario. But at least you block off all connections.
Yes.
And put an implant and obliterate with a fat to create a sterile zone all around to prevent future infection, to prevent such disasters.
Yes, sir. Yes.
Guys, भी use हो रहा है, हो जाए तब दे देना once it is over. Okay, so the subtotal petrojectomy is an amazing procedure. Patients having chronic suppurative otitis media, having profound deafness, how can you rehabilitate with a cochlear implant? You do a canal down mastectomy, a good cavity, and if you do an implant, the cavity we know can get infected any point of time. How is the picture?
Fine, sir.
So cavity can get infected any point of time.
Yeah.
With this subtotal petrojectomy and obliteration, you create a sterile zone and block of all external connections. The infection cannot enter. And then your implantation is very safe. So it has opened avenues to rehabilitate all those, profound deaf patients which are not, being rehabilitated with a regular implantation because of future infections.
Okay, sir. Okay.
Okay?
Yeah.
Now coming to the temporal bone anatomy, then we'll further go beyond.
Sir,
This is,
sir, you said subtotal petroscopy, especially in implantation, sir.
yeah.
Is it necessary to do canal wall down, removing all excentration of all pneumatic cell tracts? Is it mandatory
Yes.
in all cases?
Otherwise, how will you ensure the, the mucosa
Yeah,
not
yeah.
weeping?
Yes, sir.
If
Yes.
you leave the mucosa, it needs aeration.
Yeah.
Once you're obliterating the eustachian tube,
Yes, sir.
the remaining mucosa will start weeping. And
Can it
that's a
not
disaster.
undergo disuse atrophy like that, sir?
No. This needs
Like the
aeration.
way.
Mucosa needs aeration everywhere.
Yes, yes.
We
Yes, sir.
know the lack of aeration leads to secretiotitis media.
Yes, sir.
The
Yes.
movement aeration is, disturb the secretiotitis media starts, and
Yes.
then secondary infection. So
Yes.
aeration is required for mucosa. That's why in subtotal petrojectomy, the skin removal is easy. Removal of the canal wall skin is easier.
Yeah. Yeah.
Removal of the cholesteatoma is easier.
Yes,
The
sir.
difficulty is the removal of mucosa from everywhere. That's why got a
Yes.
good CT scan done and chase down all air cell tracts
Yes, sir.
to remove all the mucosa to prevent future problems.
Yes.
Now, on the surface of the temporal bone,
Yes, sir.
this is exotic canal. That's the surface of the temporal bone.
Yes.
Wash.
Sir, in such conditions, as you said, in case if the petrous apical cells are also aerated,
अगर stool वाला आ जाए,
excuse me, sir.
जाइज वाला आ जाए तो देखो कोशिश करो वो नीचे केस चल रहा है सर वो हो जाए जब ला देना और कैमरा ये क्लैरिटी अच्छा है वैसे ये ट्रू कलर्स नहीं आ रहा फोन किया था हां यहां पर जो है ये अच्छा ऑनलाइन में देखा ठीक है देखो हो सके तो लाना है ना दैट विल बी इवन बेटर हेलो
Yes, sir.
now
Yes.
why we consider this temporal bone as the most complex bone
Yes, sir.
see this temporal bone formed by the 4 different bones joining each other at various levels in this region. This entire outermost part of the temporal bone is formed by the squamous part of the temporal bone.
Yes, sir.
Means all outer structure are formed by the squamous part. They belong to the squamous part. Means this bone forming the lateral wall of the middle fossa, this zygomatic arch.
Yes, sir.
अगर आ जाए तो देखना. This zygomatic arch, this entire lateral mastoid process, this
Yes.
spine of Henle, everything are formed by are part of squamous part of the temporal bone.
Yes, sir.
The entire medial part of the temporal bone is formed by the petrous part of the temporal bone. Do we have the skull model, Vishwas?
You want temporal
Get the skull model?
Temporal
Vishwas? We had somewhere. We had the skull model. Just to show you better. Yes. See, just to orient you
Yes, sir.
regarding this anatomy
Yeah.
of the, can you bring the external camera, please? Where the temporal bone is situated. This is very important to understand. Can you come here? External camera, please. This will orient everybody from this complexity. इधर आओ पीछे आया कर रहे हो. As behind as possible. Yes. Zoom in. Can you see the bone now?
Yes, sir. Yes. Clear.
See, this is the temporal bone from outside.
Yes, sir.
I told you this is a complex bone having relationship with other surrounding bones. And this is the temporal bone from inside. Can you see?
Yes.
What this elongated process is seen, this is entire petrous part of the temporal bone.
Yes.
From inside, it is all petrous bone,
Yeah.
petrous part. From outside, this is all squamous part.
Yes.
Okay.
Yes.
The third part is a thick bone. This is forming the circumference of the extraordinary canal, is the tympanic bone.
Yes, sir.
You mean? This is tympanic bone. Okay. This
Yes.
forms more than 2/3 of the circumference of the extraordinary canal.
Focus.
And the fourth part,
Yeah.
emerging from the tympanic bone below, is the styloid complex. This is part of the temporal bone.
Yes, sir.
All this goes deep inside the posterior part of the mesotympanum,
Yeah.
which is all formed by the temporal bone, this styloid complex.
Yes.
Means the facial canal, the fallopian canal is a part of styloid complex. All the caudal eminence, ponticulus, subiculum, caudal eminence, this pyramidal eminence, all in the posterior wall of the mesotympanum are part of the styloid complex.
Yes.
So styloid complex, tympanic bone, squamous bone, and petrous bone. These are the four parts of the temporal bone. And see how the temporal bone is complex, how it is situated in the head, in the center of the head. See this? Are you getting the proper view?
Yes. Yes, sir. Yes. Clear.
This is the middle cranial fossa.
Yeah.
This temporal bone has a relationship with the middle cranial fossa.
Yes.
All the intratemporal structures, see this? This is the temporal bone here.
Yes.
All the intratemporal structures, the superior surface, the superior limit is the middle cranial fossa. So this is all, this thin bone is all tegmen, forming the superior wall of the extra-aortic canal and the mastoid. Now see, my extra-aortic canal is here. Extra-aortic canal is here.
Yeah.
Corresponding to this, bone, where is the extra-aortic canal? My
Yeah.
extra-aortic canal is here.
Yes, sir.
Posteriorly, this is the area of the mastoid. See this?
Yes. Yes.
Here, this bone is tegmen
Yeah.
tympani and this is tegmen entri.
Yes, sir.
बस इसको इधर इधर लाओ. Yes. Dark neo. Yes. Now it is better.
Yes, it's good.
Now it is better.
Yeah.
So this is tegmen. Focus.
Focus, sir.
Focus, please. Focus. Yes.
Yeah.
Lighting so.
No. Don't bring the light.
Good inside.
I think this light will go like this.
Light alle hoga.
Leave it.
This one. Light.
Yeah, fine.
Can see.
See this. So this is tegmen entri and this is tegmen tympani. Okay?
Yes.
From here, medial to lateral to medial, if we go, this is all petrous bone.
Yeah.
Yes, sir. Yes.
And I told you all the neurovascular structures are in vicinity of this bone.
Yes.
This bone joins here. Can you see this fissure?
Yeah.
Yes, sir.
This
Yes.
bone joins here with the clivus. This is all clivus.
Flavors.
Yeah.
The thick clivus over which is the fossa for the pituitary.
Yes. Yes.
This thick clivus is formed by the occipital bone. This is the occipital bone and this is the sphenoid bone.
Yes.
This sphenoid bone is there in the center of the head,
Yeah.
which has this lesser wing
Yes.
as
sir.
well as this greater wing. This is all greater wing of the sphenoid. This
Yeah.
is lesser wing of the sphenoid. And
Yes.
this is the body. Underneath this pituitary, below is the sphenoid sinus.
Yes, sir. Cellar.
This is greater wing. All
Yes,
the
sir.
foramina. Can you see all these foramina?
Yeah,
They are
very
in
well.
the greater wing.
Yes, sir.
So
Yes.
this petrous bone is so deeply insinuated
Yeah.
within the sphenoid and the occipital bone anteriorly. Can you see?
Yes, sir.
In total temporal bone dissection, subtotal temporal dissection, I
Yes,
will
sir.
show how will we make the cuts to separate this bone completely intact.
Yes, sir.
So this is the length of the petrous bone.
Yeah.
Here it makes the fissure. This is inferior petroclival fissure. This is petrous, this is clival.
Yes, sir.
Petroclival fissure through which the inferior petrosal sinus runs.
Yes, yes.
Above is the superior petrosal sinus runs through the superior surface of the petrous bone.
Yes, sir.
Both these sinus, here is the cavernous sinus.
Yeah.
Here on the either side are the cavernous sinus of the pituitary.
Yes,
Either
sir.
side of the pituitary. From cavernous sinus, one sinus communicates and the blood flows from the cavernous to the superior petrosal sinus joins here.
Yes.
What? The transverse sinus,
Yeah.
from where it becomes the sigmoid sinus.
Yes, sir.
So this is the superior petrosal sinus. Okay?
Yes. Yes, sir.
And here is the inferior petrosal sinus,
Yes,
which
yes.
goes here. This is the jugular foramen,
Yes, yes.
which opens as a medial opening in the jugular foramen. We'll show once
Yes.
we open the jugular foramen as inferior petrosal sinus openings.
Yes, sir.
And in between these is the temporal bone, the petrous part of the temporal bone.
Yes.
Now see, if I go from behind, you know the venous blood flow, if I rotate it from behind, the
Yes, sir.
superior sagittal sinus comes from here,
Yeah, yeah.
then continues as a
Lateral side.
right transverse sinus.
Transfer side. Yes, sir.
Right transverse sinus here.
Yeah.
And here the superior petrosal sinus joins.
Yes, sir.
And then it becomes the sigmoid sinus as the posterior surface. See this?
Yes, sir.
Yes.
Yes.
This is your petrous bone.
Yeah.
And this on the posterior surface means this is
Yeah.
posterior cranial fossa.
Yes, sir.
On the posterior cranial fossa surface, this petrous bone
Yeah.
has a relationship with
Yes, sir.
sigmoid sinus, which goes inside and becomes the jugular bulb.
Yeah. Yeah.
So superior petrosal sinus opens here
Yes,
and the
sir.
inferior petrosal sinus opens here. Is that clear?
Yes, very clear, sir.
Very clear?
Yes,
Now
sir.
see, if you see from outside,
Yeah.
if you see from outside the inferior surface,
Yes.
this is the jugular bulb.
Yeah. Yeah.
This is the jugular bulb, the jugular foramen into which the jugular bulb is.
Yeah.
This is your styloid process, which
Yes.
is immediately lateral to the jugular foramen. We will see in the dissection
Yes,
later
sir.
on how the styloid process is a great landmark. If I'm operating from here, this is the mastoid tip,
Yeah.
the styloid process.
Yeah.
As long as you are lateral to the styloid and styloid muscles,
Yes, sir.
your great vessels are protected. That's an
Okay.
amazing landmark.
Yes, sir.
And see, this is the jugular foramen, and anteriorly, this is the carotid
Carotid.
foramen.
Yes,
So the
sir.
carotid artery from the neck, parapharyngeal, ascends into this foramen.
Yes, sir.
Goes for a short centimeter long vertical course. Okay.
Yes, sir.
Then here, anterior to the cochlea, I will show in this section.
Yeah.
It becomes horizontal in the entire length of the petrous bone, like this.
Yes, sir.
Entire length of the petrous bone, this carotid artery goes, and
Yes.
here this is the level of the foramen lacerum.
Yes, sir.
Normally, this is not a foramen filled by the fibrocartilage below.
Okay.
Carotid runs in the floor of this foramen
Yes, sir.
to come above to become
Yeah.
the cavernous carotid. See, here it becomes the
Yeah.
cavernous carotid lateral to the sphenoid sinus. Sphenoid sinus is here.
Yes, sir.
And then it goes medial to the clinoid process.
Yes,
And
sir.
this becomes the anterior genu, which
Yes,
is
sir.
in relationship to the endoscopic surgeon, the sphenoid,
Yes, sir.
where the opticocarotid recess is, and then come above to give intracranial course.
Yes,
And
sir.
it gives a retrograde branch here. This is the ophthalmic canal.
Yes, sir.
This, once it comes here, it gives a retrograde branch anteriorly into the orbit. See, here from the orbit goes the ophthalmic artery,
Yes, sir.
along with the optic nerve, which is
Yeah.
above the carotid artery.
Yes,
Okay?
sir. Yeah.
So the carotid runs in this, foramen to come up. So this is anatomy on the bone. So
Yes.
in temporal bone resections,
Yeah.
I told you, this gives minimal morbidity. This subtotal temporal bone resection, sacrifices only 7th and 8th nerve.
Yeah.
To remove the temporal bone, you have to sacrifice 7th and 8th nerve.
Yes,
Rest 9, 10th, 11th, 12th cranial nerves are all spared. Carotid jugular system entirely spared. That is the
Yes.
beauty of subtotal temporal resection. You can remove the entire cancer without sacrificing any critical structure except 7th and 8th cranial nerves, which are most of the time in advanced malignancies are involved. Even your piecemeal resection cannot spare.
Yes, sir.
And the 7th and 8th sacrifice enables to remove this entire thing intact. So the limit is anteriorly, this limit, the foramen lacerum. Can you see here?
Yes,
The
sir.
carotid. The entire greater wing of the sphenoid is spared.
Yeah.
Here from the posterior cranial fossa, the
Yeah.
5th cranial nerve ascends over here on the petrous apex. This is petrous apex.
Yes,
For
sir.
everybody, the deepest structure is petrous apex here.
Yeah. Yeah.
So the 5th nerve comes over here and divides into 3 branches.
Yes, sir.
The first one, the mandibular, goes in foramen ovale.
Yes, sir.
The second one, V2, goes in foramen rotundum. And the third one, V1, goes in superior orbital fissure. It is here.
Yes,
See,
sir.
1, 2, 3.
Yeah.
All these in the greater wing of the sphenoid. And
Yes, sir.
behind the ovale is the foramen spinosum for middle meningeal artery. We'll show in dissection. So
Yes, sir.
all these are, once you dissect from here, all these come lateral to the carotid artery. See, this is carotid here.
Yes, sir.
Carotid runs here, and posterior to anterior, they all come in lateral relationship to the carotid once you dissect from here, from outside. So the first posterior structure would be middle meningeal, then the V3 passing
Yes.
to the oval, then V2 and then the V1. So this is, this anatomy, why we are, discussing again and again. We have to understand this anatomy from different perspective. From inside, the anatomy looks different because we see from the different perspective. From lateral side, it looks different. From inferior side, it looks altogether different. So we
Yes.
need to understand. Secondly, before going to the dissection, this is Peter's bone. See? Now, there are various important relationships of the Peter's bone. See the sigmoid sinus coming over here to enter into the jugular foramen.
Yes, sir.
Immediately lateral to the jugular foramen, superior to the jugular foramen.
Yeah.
You see in the dissection, the jugular foramen is inferior structure,
Yes,
and
sir.
superior to that is what? Internal acoustic
Internal.
meatus. See this?
Yes. Yes, sir. Yes.
From here, the brainstem is here. That's the
Yes.
foramen magnum.
Yes, sir.
Brainstem is here. From here, the 9th, 10th, 11th cranial nerve. From here, go into the jugular foramen.
Yes, sir.
7th, 8th ascend into the internal acoustic meatus.
Yes, sir.
5th, 6th ascend over the Peter's apex.
Yes, sir.
And the 12th from here go into this canal. See this?
Yes, sir.
Medial to this. This is the canal in the occipital condyle. This is occipital condyle.
Yes, sir.
This is occipital condyle, and there is a canal in the occipital condyle, hypoglossal canal.
Yes, sir.
So that's a separate canal for hypoglossal nerve, not with the 9th, 10th, 11th.
Yeah.
This is jugular foramen.
Yes, sir.
In the medial wall of the jugular foramen, this is medial. Medial wall is a tubercle, jugular tubercle.
Yeah.
Medial to that is the occipital condyle, and through the occipital condyle, the hypoglossal runs. I will show in dissection.
Yes, sir.
Whatever anatomy I am showing from here, will
Yeah.
dissect each and every anatomy in detail. So
Yes,
that
sir.
you can have a three-dimensional perspective. Why it is important? Because in lateral skull base surgery, we are fraught with morbidity.
Yeah.
By understanding of this three-dimensional anatomy, we can save all these important cranial nerves and neurovascular structures.
Yes.
Without knowing this anatomical information, we can end up damaging everything. And that is not the goal. That's why earlier, the lateral skull base, skull base surgery was, regarded as a futile exercise, was going to disrepute because of the morbidity. Now, with the advancement of the surgical technique, it has become so popular now. Earlier, even the carotid artery, facial nerve, these are all important structures traversing to the various parts of the temporal bone. And lesions deep to them were difficult to dissect earlier. But nowadays, I will show today how the carotid facial nerve can be transposed.
Yes, sir.
And any lesion deep to them here and there can be resected with ease and comfort. So that's the goal of understanding this anatomy. So I hope you understand well.
Yes, yes.
Yes,
This
sir.
is
Yes.
the temporal
Very
bone.
well
This
told,
gives
Yes.
Dr. Satish sir.
So we will
And also,
dissect,
can you?
at the end, we will dissect the temporal bone from here anteriorly,
Yeah.
from the sphenoid, here from the clivus,
Ribus.
and
Occipital.
here the jugular foramen at the limit, then sigmoid sinus here from the posterior canal fossa. This is your posterior canal fossa and the occipital bone.
Yes. sir.
Here, for the outside cut, see, we will remove this entire thing. Can I get a marker, Vishwas? See, this is the squamous part of the temporal bone. This is the mastoid part. Can you see?
Yes, sir.
This everything has to go. Only limit is what you need to leave is the carotid and the jugular.
Yeah.
So my resection limit, see here, my resection limit will go lateral to the carotid and jugular like this.
Yes, sir.
See this?
Yeah.
Behind the mastoid.
Yes. sir.
Behind the mastoid. This is asterion.
Yes, sir.
This suture line is asterion,
Yes,
Yeah.
which is junction of various bones, the parietal, temporal, and the occipital. We'll go the asterion. This is the point where the sigmoid sinus starts below, and
Yes.
above it goes as a transverse sinus. This is
Yes.
asterion. So
Yes,
this
sir.
is the limit of resection, and we'll remove this entire temporal bone and block.
Yeah.
See this?
Yes,
Now
sir.
here, we'll remove the mastoid tip, go underneath the jugular foramen.
Yeah.
See this jugular foramen here?
Yes. sir.
And we'll connect this posterior wall of the jugular foramen to the resection here.
Yeah.
And leave the jugular bulb below.
Yes.
So this bone we will cut separately. This is the part of the occipital bone forming the posterior wall of the jugular foramen. Laterally, we'll take the styloid in it. And laterally, this is the area of the temporomandibular joint.
yes.
Yeah.
This is the zygoma.
Yes,
So we
sir.
will include the TM joint. As I said, it is frequently invaded by the cancer.
Yeah.
We'll take the TM joint
Yes, sir.
far anteriorly and we'll take the zygoma, and
Yeah.
this will be our resection limit and block
Okay, sir.
most oncology sound operation for the temporal bone malignancy.
Yes,
Now
sir.
see here, again, the beauty. This is the temporal fossa where the temporalis muscle is situated, we know.
Yes, sir.
And this is temporal fossa.
Yes,
And
sir.
below that is
Infratemporal fossa.
infratemporal fossa. For guys who consider the infratemporal fossa as a difficult to understand, the simplest way.
Yeah.
This is temporal fossa, this is infratemporal fossa.
Yes, sir.
What is the anterior limit? This is maxilla.
Yes, sir.
The posterior wall of the maxilla, posterior lateral wall of the maxilla is the anterior limit of infratemporal fossa.
Yes.
See this?
Yes, sir.
Posteriorly is what? The pterygoid plates.
Medially, sir.
Yeah, pterygoid plates.
Yes.
Medially.
Yeah.
And here is the temporomandibular joint. So here is the mandible.
Yes, sir.
Mandible is your lateral limit.
Yeah.
And this entire fossa is filled up muscular tissue and neurovascular structure.
Yes.
So
sir.
this is, and see the communication with the temporal fossa is through the zygoma.
Zygomatic.
This
Yeah.
zygomatic arch.
Yes.
So
sir.
above the arch is the temporal fossa, below that is infratemporal fossa.
Yes,
And
sir.
this is the roof, see, formed by
Yes,
the
sir.
greater wing of the sphenoid bone.
Yes,
This
sir.
forms the roof. So this is infratemporal fossa.
Yes, sir.
See, immediate anterior anatomy to the temporal bone. So many of the infratemporal fossa lesions earlier, I
Yeah.
remember Mario Sana, Professor Mario Sana, whom I call is a phenomena. Is phenomenal in addressing, simplifying everything for us to popularize this lateral skull base. He would remove all these infratemporal fossa regions from the lateral skull base approaches, including even angiofibromas. Now with the advancement in the endoscopic science, it has become most direct approach, not this one, but this is a very, very important approach for many lesions, from anterior lateral to anterior skull base extending. We have removed many cholesteatomas, temporal bone, Peter's bone cholesteatomas going in the sphenoid sinus.
Yes, sir.
Everywhere. And with the infratemporal fossa, B approaches, C approaches, I will show in dissection, you
Yeah.
can address all these lesions following them right into the anterior skull base,
Yes. Yes, sir.
So the skull base is 360. For our convenience, we have divided into anterior, middle, posterior, whatever,
Yeah.
but this is one unit and we should be able to address all these lesions
Yes,
by
sir.
various approaches which are designed to give better results. It's not that I'm a lateral skull base surgeon, I will push everywhere the lateral skull base approach. Like this lesion, see this area. This
Yeah.
is petrous apex.
Yes, sir.
This is clivus.
Yeah.
This is petroclival region.
Yes, sir.
Such a area in the depth of the head of the center of the head, petroclival region, with carotid artery around, with
Yeah.
all the cranial nerves around, with the pituitary gland above, and everything here, critical structure here, addressing the various lesions here, calls
Yes,
for
sir.
various approaches. So depending upon the situation, you can address from the lateral skull base approach, you can approach endoscopically as well, you can approach by the neurosurgical approach, and various approaches you can use. And we will discuss later what can be the best approach for various lesions. So this is to give you better understanding of this area.
Yes.
Now we
One
move on to
question,
the dissection.
Satish sir. So how much of the clivus you think from laterally, so we can access?
Pardon? How much is that?
How much of the clivus, which part of the clivus, so you think so laterally, so we can access, and
Yes.
so
See
which
this.
anterior
See
is
this. This is the entire clivus. This is the central part is clivus. The mid,
Yes.
and see on the clivus of either side, the carotid arteries ascending from the foramen lacerum. See this groove for the carotid artery on either side?
Yeah.
And in middle is the clivus. Now the central lesions of the clivus are best addressed endoscopically. In between the carotid arteries. Now tumor which is behind the carotid artery here, how will you address endoscopically? Either you have to transpose the carotid artery, or you come laterally, or you come from behind.
Yes,
So
sir.
depending upon the relationship to the carotid artery, depending upon the laterality of the midline lesion, lateral lesion, or depending whether it is intradural or extradural, whether it has invaded the bone or not, all these are the factors which, are important in deciding or choosing the surgical approach. Endoscopy, for example, has a limitation in addressing only the central lesions. Got my point?
Yeah,
The
exactly.
lesion which is around the carotid, behind the carotid, is difficult to address endoscopically. Otherwise, one can damage carotid and has to be very, very experienced to transpose the carotid. Secondly, the intradural lesions are difficult to excise by the endoscopy alone because of the neurovascular structure, CSF leaks, and so many other issues which are difficult to address. If this petrous apex is involved, again, it is difficult to address from the midline, particularly if it is a malignant lesion or a difficult lesion, invasive lesion. So, for this, there are various posterior approaches. Infratemporal fossa B is one of the best approach here. I will show you which allows the entire exposure of the, this carotid, horizontal petrous carotid and the cavernous carotid. It gives complete control, including control for the transposition, and you can remove all extra and interdural lesion under vision with both hands free, binocular vision with full ease and control of CSF leak and everything. So there are various approaches we'll discuss. So once we discuss each and every approach, we'll discuss accordingly the indications and contraindications as well. Yes. So question from Arshad here regarding the infratemporal fossa A, B and C. See, infratemporal fossa, we'll show all the approaches. We have ample of time today. So in A approach, what A is directed to the jugular foramen. Now see where the jugular foramen is? Here in the depth. And this is styloid process, and lateral to the styloid process comes out the facial nerve. To address the jugular foramen lesions, particularly the vascular lesions, where the facial nerve is crossing, you need to transpose the facial nerve, which Hugo Fischer decided as a infratemporal fossa A approach. After transposing, you can remove this tympanic bone, you can remove styloid process, you can remove all this mastoid, and you can head-on approach to the jugular foramen. That is infratemporal fossa A. And the carotid artery is immediately anterior to it, and then it becomes horizontal. If the lesion is extending further anteriorly along the horizontal carotid, the approach designed is infratemporal fossa B, and further approach anteriorly C and D. So, Arshad, during this section, I will address this issue. What is A, B, C, D indication? Believe me, it may be looking difficult, but once you understand this anatomy, this is not difficult at all. If I can do, you can also do, as simple as that. What all we need is more and more understanding of this three-dimensional anatomy, for which we are here to discuss. And once again, thanks to Deepak sir. So, coming to the dissection now. See, this is the lateral surface, and what
Yes,
we
sir.
see is the lateral surface of the temporal bone. Can you see?
Yes, sir. Yes.
I hope the picture is good.
The picture is good.
Little bit focus.
Little bit
Are
focusing
we
is
switching
needed.
over to microscope, sir, now? This is
Now,
a microscope or external camera, sir?
This is
is
microscope.
it coming from the external camera or
Microscope.
what?
Okay. Yes, sir. Fine. These are
No,
microscopic views.
now it
Fine.
is to the microscope, I think.
Yes, sir. Yes.
Now it's fine.
Yes, sir.
See now, this is your zygomatic root.
Yeah.
See this?
Yes, sir.
This is a very, very important landmark. We call it as the inferior temporal line as it goes behind. See this as a line going behind. Prominent line.
It is same as supramastoid crest, sir.
Yeah, that is also known as supramastoid crest.
Yes, sir.
See this? This is a periosteum I am removing.
Yeah.
This is the spine of Henle. This is the lateral surface of the mastoid. What I am removing is this periosteum to expose the bone.
Yes, sir.
Please feel free to interrupt me or ask any question in your mind or any suggestions. See this. This is all the mastoid cortex is exposed. This line for the junior colleagues is a great landmark. See, my entire mastoid process is here, and in order to address the mastoid air cells,
Yes, sir.
my limit above is the middle cranial fossa plate, that is tegmen. We saw on the skull, that is a very thin bone,
Yes, sir.
forming the roof. Anteriorly, anteriorly in the circumference of the canal, and posteriorly roughly joined together in the depth would be the
Yes, sir.
sigmoid sinus. This is roughly
Yes.
this lateral rough limits Now, before going to the depth, you have to, define your limits. या दूसरा दे, काट नहीं रही. Not cutting. काटने वाली तो. This is a huge landmark, this temporal line.
Yes, sir.
The beauty is, as long as you limit your dissection to the temporal line, you can never damage the tegmen. Tegmen is a couple of millimeters above the temporal line, and this temporal line warns us from going up. बहुत लंबी है ये बात. No.
When we are taking that superior cut along the inferior temporal lines,
लंबी है.
hello?
Superior cut along the inferior temporal line, yes.
Is there any specific point where we should stop? How far posteriorly we can go?
Posteriorly, the limit will be decided by the position of the sigmoid sinus.
Okay, sir.
The pneumatization of the temporal bone is variable.
Yes, sir. Yes.
And the situation of the jugular bulb accordingly is variable.
Yes, sir.
Sometimes it's deeper, sometimes it is very, very superficial.
Yes, sir.
And the change of colors here in the live situation is very, very useful to guide in identifying all these structures. Yeah, cut nahi rahi. Give me good cutting. But this will take away a lot of time.
Sir, good morning, sir.
Yes, sir.
I am Dr. Nageswara from Visakhapatnam, moderating the session, sir.
Sir.
What is the triangle of attack by Mario Sana? Because many postgraduates are observing.
So, this is what the triangle of attack described by Mario Sana.
Sir.
Means, take the advantage of the inferior temporal line, then go in the circumference of the canal and then join with the imaginary line and start drilling into it, and then keep going laterally wider and wider before going in the depth. Don't dig a well. See now, I don't know how behind in my sigmoid sinus is. So keep going wide until you reach your limit before going in the depth. Cutting there. पहले कहा था तेरे को ड्रिल लेके आना. Bar point. छोटी निकाल. इधर रखना. Give me a good bar point.
This is a metro.
Similarly, superiorly. See this temporal line, inferior temporal line, why I was saying a very, very safe landmark.
Yes,
because
sir.
the tegmen is couple of millimeters above this line. So if you consider this as a landmark and then keep on going up to look for the tegmen, makes you much, much safer.
So the handpiece, the front part is, I think, is moving along with the burr. If you can check the handpiece, the anterior
The
handpiece,
shaft, sir, the sheet is.
the nose, that cone is moving with the burr. Actually, you can tighten that.
Yeah. Looks like a good pneumatized temporal bone. Looks like a good pneumatized temporal bone.
Sir, can you just throw some light on the usage of the burrs? Again, the same things have happened. I think you can change the handpiece. I think the front part is just got detached from it, and it is moving and is coming in the way of vision.
Yeah.
Sir, can you just hello?
Yeah.
Can you just enlighten us with what are the burrs that can be used? What are the advantages and disadvantages for the benefit of the junior colleagues? So what?
Various burrs.
Yeah, burr. See, the burr what you are using is actually a dental burr. So what are the advantages and disadvantages?
Yeah, this is a good burr with a better control.
Yes, sir.
With a shorter shaft. See?
Yes, sir.
Shorter the burr shaft, better the control is. Find out. Shorter the shaft, better the control is. Number one. Number two, for the initial work, you need a robust cutting burr.
Sir, a small correction, sir. The burr, I think it is going in the reverse direction than the forward cutting mode. Can you just check it that? Yes.
Mode change करो देखिए, reverse जा रही है.
Good observation, Reddy. Prakash.
Oh, great. Thank
Thank
you.
you, sir. Thank you, sir.
Yeah? Reverse, reverse. Hmm? नहीं नहीं
Yeah.
no
No.
oh
Yeah. Now it's okay.
oh thank you. So this is a robust cutting bar and I am making more and more wider, you know. Wider. Before going to the depth, more and more lateral excenteration.
Whatever is taught from this orientation, we'll understand from my side. Correct. Go from inside and out, it is neurosurgical perspective.
Hello? Sir, can you just give us some tips about the drilling techniques for the benefit of the postgraduates? A lot of postgraduates are watching.
Yes.
The drilling techniques and the burrs.
Yes. So drilling technique, number one, as I said,
So shorter
first
the
work
length of the burr.
laterally, widen laterally, and then go medially. Number one.
Okay, sir.
Use the largest possible burr size for the
Okay,
given
sir.
area.
Okay, sir.
Largest possible burr size for the given area.
Okay.
Important, which is a more safer, sort of drilling, I would say. All this soft tissue which I am removing.
Sir, do you prefer to use the round burrs or the conical burrs, the dental burrs, what you're using now?
Conical burrs in the beginning.
Okay, sir.
And then, of course, later on in the depth are the round burrs only.
Are there any disadvantages?
Conical burrs have large surface area to drill.
Yes, sir.
So that is useful for the beginning, not for the, later work. But for beginning, these are good, burr points for the faster work.
Sir, are there any disadvantages of using these conical burrs?
No, these are fast. You have to be careful.
Okay,
These
sir.
are, robust cutting burrs.
Yes, sir.
Dr. Satish Jain,
Yes, sir.
when do you keep the anti-clockwise rotation of the burr? When you want to use anti-clockwise? Now it is clockwise rotation, isn't it? So in what situations you want to use anti-clockwise rotation?
Once you are working
Yeah.
over a critical structure, like you are drilling over the carotid artery, drilling over the facial nerve,
Yeah.
and you want to keep thoroughly irrigated to keep the under surface visible, and you don't want a robust cutting.
Okay.
Those situations, you can purposely use the anti-clockwise.
Yes, sir.
Okay.
See this? Our inferior temporal line was a great landmark.
Yes, sir.
Still, we have not reached the tegmen.
The advantage of the conical burr, you can see clearly the entire surface of the lateral surface of the burr is being used at once to remove the bone. That's the biggest
Always use the side surface of the burr to cut.
Yes, sir. Not the tip.
Not the tip.
Yes.
Thirdly, never use any force on the burr point.
Yes, sir.
Any inadvertent force can be dangerous to the underlying structure. See the beauty of the conical burr.
Yes, sir.
It has a large cutting surface.
Yes. Especially it is very useful in saucerizing the cavities, edges of the cavities.
Yes.
Smoothing the cavities.
So see, this is the root of the zygoma now anteriorly.
Yes, sir.
See, this is the zygomatic root going anteriorly.
Yes.
We are working here in the root, and here in the root is going to be the attic. Attic lies in the root of the zygoma. See this?
Yes.
Our tegmen is still little above. We are almost close to the tegmen. See, if you consider this temporal line, inferior temporal line as a landmark, you are still 4 to 5 millimeter at least away from the tegmen.
Yes, sir.
So that's a great safety landmark if you
So
consider.
So the
during
tegment.
surgery.
Satish,
Yeah.
one question. Being a right-handed surgeon yourself,
Pardon?
you are a right-handed surgeon, no? So, do you feel more comfortable with the right side surgery or left side master surgery?
Yeah, with the same comfort, no
Same
issues.
comfort. So,
Yeah.
Sir,
Not
just
never find any difference.
Sir, I just want to add a point, if you don't mind here. Dr.
Yeah, please.
See, to me, it appears that for a right-handed surgeon, whatever the complications have happened are all happened on the right side only.
right side only.
Because the dominant hand is on the other side of the dura, and whereas when you operate on the left side, the complication rate is lesser, to my knowledge. That is what
Really?
even the textbook also mentions. So
Really? I never realized. That's a
Yes,
great
sir.
point.
Yes, sir.
Because
And
the drill will be inclined towards the jura, the tip of the drill, the right
and
hand
the shoulder,
right side.
for a right-handed surgeon, right ear surgery, the shoulder is coming in the way. Whereas on the
See
left,
now what I have skeletonized.
Yeah.
See now, couple of important points. This is your tegment plate, and this tegment curvature is always, tortuous and depends from person to person differently. And this can be, if you really want to know the tegment curvature exactly, a pre-op CT can tell you from anterior to posterior and medial to lateral curvature. And accordingly, you can follow them to stay more safer.
In which film, coronal sections or axial sections?
Pardon?
To see the level of the dural plate.
Both coronal and axial. For superior, inferior, coronal.
Yeah.
For anterior, posterior, axial. Now see, where I am exactly working, the so-called sinodural angle. Let me tell you where exactly the sinodural angle corresponds to. See, this is your sigmoid sinus going down. This is your sigmoid sinus.
Yes.
This sigmoid sinus continues here as a transverse sinus.
Yeah.
The point where the superior petrosal vein, superior petrosal sinus, I mentioned during the, explaining the skull, the superior petrosal runs over the superior surface of the petrous bone.
Yeah.
This is the superior surface of the petrous bone here. And it joins the transverse sinus here. And after that, it becomes the sigmoid sinus. So, in the depth where exactly the superior petrosal sinus joins this venous system is the area of the sinodural angle. True sinodural angle is that area where the superior petrosal sinus joins the jugular venous system. See, this area I'm uncovering. This is considered a difficult area. When you remove the cholesteatoma, sometimes this is many a time look like a hidden area. So you have to completely uncover. See what I'm doing? Completely uncovering. See the cell over here.
Yeah.
In a cholesteatoma case, one can miss this cell and leave the cholesteatoma behind. So the sinodural anatomy is always mentioned in cholesteatoma surgery to be very, very careful in this region while removing the cholesteatoma. See now, I've completely flushed.
Yes.
See, the sinodural angle is completely uncovered now.
Yes, very clear.
See this?
Sir, is this sinodural angle is a misnomer, sir?
Yeah. So actually, it is the level where the sigmoid transverse sinus joins the inferior petrosal sinus. Superior petrosal sinus will show you later the superior petrosal sinus.
There is a
See,
dura.
this area is uncovered.
Yes, sir.
Now this is your jugular sigmoid sinus going inferiorly.
Yes, sir.
See, if I thin out this canal wall, you will understand better. Now all these cells can be removed with much more safety and faster, having seen both the limits. Both the limits means
Satish Jain.
sinus and the
Dr. Satish Jain.
plate. Yes, sir.
Yeah, see, we are all oriented towards first reaching the mastoid antrum and then doing these bone work.
Yeah.
Is that advantageous that way, or here you have not yet opened the antrum, isn't it? Till now.
See, antrum is the largest cell in this region.
Yeah.
See this? And once you go medially, it automatically opens once you excentrate the cell. And here, see this area is opened. See this? And what you see in the depth, some ivory white bone. Can you see here?
Yeah,
Lateral
yeah.
canal.
That's a lateral semicircular canal.
Semicircular canal.
Here is going to be the labyrinthine block. I will show you in detail. And this is all cellularity perilabyrinthine cells. Can you see?
Yeah.
Yes, yes.
This is your canal wall. I will make it little more thinner.
So for the regular otologist, since
Yeah.
we first get into the mastoid antrum, so is it always better to first get the mastoid antrum and then do all this bone work, or you did this way?
Yeah. So
which one you advise?
once you go from lateral to medial,
Yeah.
once the largest cell opens, in floor of which you find the lateral semicircular canal
Yeah.
is the antrum. That is the antrum.
Yeah, yeah.
So antrum is identified by identifying a large cells, and secondly in the floor where you find the lateral semicircular canal. Now see, inferiorly if I go, very important anatomy. Because we'll, as I mentioned in the beginning, we'll discuss today the facial nerve right from origin till destination in detail. And facial nerve is an important anatomy. We should be able to know which landmark is most useful for which part of the facial nerve. Different parts of the facial nerve have different, most useful landmarks. See what I'm doing? I'm separating the outside muscles from the tip. Can you see?
Yes, sir.
This is mastoid tip. See this?
Yes, yes, clear.
Now, the outside muscle, in the medial part of this tip, a very, very important muscle is inserted in the digastric. In the medial part of the mastoid.
Okay.
This is the lateral part which I am removing.
Which approaches do you identify facial nerve first, or you do mastoidectomy and then identify?
No, I will identify later. I am showing one of the landmark here, which is considered to be one of the best landmark for the
Digastric
lower vertical part of the facial nerve.
Digastric, sir?
Yes. And how can you easily identify? That is one of the most reliable landmark.
Yes.
See my sigmoid sinus here?
Yes.
I'm skeletonizing. As you go inferiorly, the sigmoid becomes more and more deeper.
Yes, sir.
It is more and more deeper.
Yes.
And here, inferiorly in the tip, you will find the insertion of the digastric muscle. Can you see this white horizontal line?
Yes, sir, we can say.
This is the insertion of the digastric onto the inner surface of the mastoid tip. Can you see this?
Yes.
This line goes anteriorly. Now see, we know in parotid surgery, or we all know otherwise, the facial nerve comes out of the stylomastoid foramen. Styloid means styloid process medially. Mastoid means mastoid process laterally. So on the mastoid process medially is this muscle inserted. So this muscle, if you follow anteriorly, the facial nerve is immediately in relation to it, immediately medially. If I follow this, the facial nerve will be immediately medially in this relationship. This is one of the best landmark in the lower vertical part. See this? Where the facial nerve goes out of the stylomastoid foramen. This is one of the best landmark. See this? So I just mentioned this. We will use it later when we see the facial nerve course. Okay? Fine. Now at this step, you see the curvature of the canal wall.
Yes,
You see a lot of vascularity. You see the skeletonized tegmen plate and the sinus plate. Okay? And this is digastric ridge. In subtotal petrojectomy, all these cell lines are excentrated, all these.
Okay.
And these cell tracks, you have to follow each and every cell tract in detail till you find the flat bone. See, like for example, I am showing here. till you find the flat bone. Perisinus tract. See this?
Yes.
Perisinus tract. Here is going to the facial now, and this is going to be the retrofacial cell tract. See this?
Yes,
Here
sir.
going to be. We'll show you the facial and then show you the tract and the relationship. These are of perilabyrinthine cell tracts. The labyrinthine block, including the semicircular canal, is here,
Yes.
and all around are the cell tracts. These are supralabyrinthine, above in relation to the superior semicircular canal here, and these are perilabyrinthine cell tracts, just to mention that. Now, immediate anteriorly, can you see some ossicles as I widen the atic?
Yes, sir. Can see. Short process of the incus, body of the incus,
I will
malleus.
show you one of the popular approach nowadays, posterior tympanotomy, which is used frequently for cochlear implantation. This is your incus. Can you see?
Yes, sir.
Short process of the incus, which is housed here
Yes.
by means of a ligament. See this here?
Yes.
And here is the malleus.
Yes, sir.
Malleus. This was the superior malleolar ligament, which is by means of which it is inserted to the roof of the atic here, like this.
Yes.
And here is the
Lateral canal.
lateral canal, and here anteromedially in the circumference of the lateral canal is the second genu of the facial nerve.
Yes, sir.
Now, incus is one of the most useful landmark once you carry out a posterior tympanotomy. As you all are going to do, all junior colleagues are going to do cochlear implants in the future. And for this approach, the regular approach, the posterior tympanotomy is one of the most important procedure. And to carry out the posterior tympanotomy, there are certain landmarks to be taken into consideration to preserve the facial nerve in the medial wall. So posterior tympanotomy is what? We make an opening from retrotympanum, posterior part of the mesotympanum to the mastoid, staying lateral to the facial nerve and medial to the tympanic membrane.
Yes, sir.
Medial to the annulus. So what landmark can we take into consideration? Facial nerve medially, and for the annulus, we can consider the chorda tympani as a landmark, which is lateral landmark, as the chorda runs in the immediate medial relationship of the annulus.
Annulus.
Yes, sir.
We can't see annulus in the bone here. So we can consider the chorda as a lateral limit. To preserve the facial nerve, what landmark can we use? Number one, I told you the facial nerve has a different landmarks at different places. Here, this lateral semicircular canal is a great landmark for second genu. All semicircular canals are related to different parts of the facial nerve, for that matter. This posterior canal here is related to the vertical course, which is immediately lateral to the posterior canal.
Yes, sir.
The superior canal is immediately behind the labyrinthine segment. So they are in close, relationship. So here, for the posterior tympanotomy, I will take two landmarks in consideration. Number one, so that I can positively identify the facial nerve and stay anterior to it, lateral to it. One is the lateral canal and other is the incus. Incus covers the facial nerve like mother's lap. Facial nerve is always medial to the incus, wherever the incus is, long process, short process, wherever. Cutting choti. So here, medium size. This is the cellularity. Yeah, dummy electrode, no? Good. Electrode. So I will now, as I said, the facial nerve is medial to the incus, and the facial nerve is anteromedial to the semicircular canal. As long as I work in plane of the incus, see this, as long as I run parallel to the incus, see this, I am pretty safe. My facial nerve is going to be
safe,
medial.
sir. Yes,
Got
sir.
my point?
Yes, sir.
One safety landmark is the incus, number one.
Yeah.
So as long as I can see some now. Now I am running parallel to the lateral canal.
Yeah.
The facial nerve remains lateral to the lateral canal.
That facial nerve, sir.
Pardon?
Facial nerve is medial to the level of incus. You are trying to say?
Yeah, level of the incus and level of the Dome of the lateral canal, both.
Yeah.
Facial. Now let me give magnification and show the chorda tympani and the
Yes.
facial nerve both together. See this? Is this better picture?
Yes, sir. Yes.
Little magnified.
No, this is fine, sir. It's fine. This is magnified
Fine,
on.
fine, fine.
See now, I am further
Yeah.
working couple of millimeters inferior to the incus, so as not to damage the incus.
Yeah.
कैसे
Yeah.
गया? बढ़ गई, drill गया. Somebody mobilize. Drill हिल गया. Drill connection. No. Yeah. See now, very, very important.
Yes, sir.
In no time, you will see the facial now, direct positive identification I am going to show you. See the change of color below.
Yes, sir. Yes. In the upper part. Yeah.
Can you see the facial now coming in picture?
Yes, sir. Yes.
See this. And
Yeah.
what are these two nerves?
Uh,
The chorda
It is a
tympani and the
chorda
facial nerve
tympani.
together.
yes,
Can
sir.
you see?
Yes.
See the facial now. I am extending my dissection inferiorly
Yeah.
to see where the chorda is arising from.
Rising. Yes, sir.
See this triangular space.
Yes, sir.
See, this is the facial now going. Can you see?
Yeah.
Sir,
And from here, the chorda is arising. This is
Arising.
chorda.
Yes, sir.
English very short.
And this triangular space,
Yeah.
see,
Sir.
this is facial recess.
Yes.
sir,
This
do you use,
space-
sir, you are using a cutting bar. In a live patient, do you use cutting bar or a diamond bar?
Yes. See,
For juniors,
I tell you, it depends upon how you use, but the cutting bar is more safer if you use properly. The diamond bar produces more heat. नहीं, छोटी थी ना.
So
Diamond
block
is
the air cells.
Diamond bar produces more heat. You have to be more, careful.
Irrigation.
See now, this space between these two is the
Facial.
facial recess, lateral to this. And this space is same in the adults what it is at the time of birth.
Okay.
Facial recess never grows.
Like middle layer.
Whatever size of the facial recess at the time of birth remains same in the adults.
Like middle layer.
Yeah.
Like middle ear. There are certain structures in temporal bone
Yeah.
which remains of adult size at the time of birth.
Ossicles and
Middle ear, inner ear, it never changes in dimension.
Yes.
Same middle ear in the adults what it is at the time of birth. What all changes in the temporal bone? The cellularity, the mastoid. This
Yes.
mastoid is not a part of temporal bone. I never mentioned mastoid as a part of temporal bone initially. I mentioned 4 parts.
Yes,
The
sir.
squamous, petrous, tympanic, and the styloid complex.
Benign.
Mastoid is not a developmental part of the temporal bone. It is formed by union of the squamous and the petrous bone behind.
Yes, sir.
And as the cellularity grows, it expands.
Yeah.
So at the time of birth, there is no mastoid process, but it develops after the birth and it keeps on growing. So what all changes? The dimension of the middle ear, inner ear, facial recess do not change. What all change is the mastoid dimension and the external canal curvature.
Yeah.
This external canal is more flatter at the time of birth and it
Yes.
takes a different curvature as it grows.
Yeah.
See now?
We
See
are.
now where I'm going?
Yes, sir. Sir, what about Herald cell or sentinel cell, sir? Your opinion?
What about?
Herald cell or sentinel cell in the facial recess.
cell for the facial.
I didn't get what you say.
The Herald cell or the sentinel cell.
You see the initial lateral cell.
Yeah. Is it constantly present or is it?
And you can follow that.
Okay.
See the chorda there in the depth.
Yes.
Can you see the chorda there in the depth?
Yes, sir.
What's the size of the coarse cutting burr tip, sir?
1.8.
Now it is 1.8. No, this is 2 point something.
No, 1.8.
Yeah. No.
When will you
See
switch
now
to
I
the
have gone in. Patla dena, ye bhi patli dena. See now I have entered into retrotympanum. See this?
Yes, sir. Yes.
This is the entry from behind into the retrotympanum.
Yeah.
And we'll show you the structure, what you see from here. Let me further widen it. See, my medial limit is what? Facial nerve.
Yeah.
Yes.
Now see what I'm doing. See, the facial nerve is here.
Yes, sir.
I am thinning the anterior to the facial nerve.
Yeah. Enter and enter in.
To widen this space.
Yes, sir.
This is adequate space to carry out our cochlear implantation.
Okay.
See this?
Yeah.
See the structures of the retrotympanum, what you see from behind. See how big the space is.
Yes, sir. Yes.
Now, if I point out superiorly, this is the region of my round window. I will show you.
Yeah.
First, let me show you the pyramid.
Okay.
See the stapedial tendon above?
Yeah. Pyramid and stapedial tendon.
Now we are
Can you see the tendon and the pyramid?
Yes, sir.
And the stapes bone?
Yes, yes. Posterior arch of the posterior crural
See
arch.
now, the stapes bone very clear?
Yes, sir. Yes.
Under
Now
high
it's clear.
magnification?
Yes.
Round window also we can see.
And the round window, right angle there, round window
Also see.
is variably hidden
under
the niche. See, I will show you.
But
see this.
Yeah.
Round window anatomy. This anatomy can be predicted very well on CT scan.
Okay, sir.
Now
See
we can
this?
see the niche.
Because if I tilt from below, you can see the round window.
Yes,
Yeah.
sir. Yes.
Can you
Membrane
see very
is
clear
visible.
now?
Yes.
Patla de, par patli de. So now, if I remove this round window niche, see, sometimes you predict the favorability of round window visualization. There are many ways on CT scan by means of which you can predict. On CT scan, you can make a line through the facial nerve, lateral to the facial nerve and the medial part of the canal. And if see the round window falling in between, that means it is favorable.
Yeah.
Now see, this round window niche, sometimes it completely hides the round window. Can you see the round window?
Yes, sir.
And this is the round window niche. On CT scan, I can easily measure before surgery that how thick my round window niche is going to be.
Okay.
Everything is predictable on CT scan. See now. See now the round window in front of you.
Yeah. Membrane, directly we can see the membrane, sir.
See now directly you can see.
Yes.
See this?
Yes, sir. Yes.
Very clear. Now, this round window is the backdoor entry to the cochlea.
Yes.
Okay.
See, we'll discuss the anatomy of the cochlea in detail.
Yeah.
And this is the backdoor entry, and we prefer to put our cochlear implant from this backdoor entry for the regions. Okay. When we dissect the cochlea,
yes, sir,
I will tell you exactly where the implant should lie.
Okay.
Implant should lie in the position where it should optimally stimulate the spiral ganglion cell population. So, in order to stimulate the spiral ganglion population, it should be close to the spiral ganglions and it should line the scala tympani, which is closest.
Yes, sir.
And this round window is the backdoor entry to the scala tympani.
Yeah.
Once I show the cochlear anatomy, I will show you in detail the significance and in-depth anatomy of the cochlea.
Yes, sir.
See now?
Yes,
now,
sir.
if I drill this,
Yeah.
if I remove the incus, I will show you the facial nerve. Let's discuss something about the facial nerve over here.
Are you?
Dr. Satish,
Yes, please,
for
sir.
cochlear implantation, the round window entry or cochleostomy entry, which is better according to you?
Yes. You don't fall into it. What we want, any approach which gives a straight shot implant. The implant should go right straight under vision in the scala tympani. Is a good approach. let me show you at this point of time. Okay.
Okay.
See, if I open the round window, then let me open the round window for you.
In fact, ever since Satish taught me the extended round window approach,
see this,
I feel
sir.
the 3D opening. Yeah.
See what I have done? I opened the round window. Can you see?
Yes, sir.
Yeah.
Yeah.
Now you see the what is there? Gray structure. Yes, leave it. Leave it. Yeah. See, straight fine.
Can you magnify, sir? Still, we can go on for this.
Let me show you at this point of time to answer your question. See what I see in the depth straight there. Can you see this?
Yeah, yeah.
This is modulus.
Yes, sir.
Correct.
And my turn of the scala tympani goes down like this.
Yeah.
Yeah.
Now, if I implant here straight, the
Yes.
implant is going to go straight and hit the modulus.
Yeah. Yeah.
An implant is a soft structure, it will curl. See this?
Yeah.
Yes, sir.
Don't see the lumen here.
Yes.
What we want the implant to go in the lumen. Now, this is scala tympani. Above is the scala vestibuli here. Above is the scala vestibuli and the scala media here. Once I open the cochlea, I will show.
Yeah.
So, this is the inferior tunnel. So, how to make this tunnel straight to ensure that your implant goes right in the lumen? What I will do, see this. Chota the size.
Small.
I will remove the inferior wall of this round window.
Okay.
Extend the round window inferiorly, like Deepak sir said, extended round window. The goal is until I see the straight tunnel of the cochlea to push my implant without hitting here and there.
In the basal tunnel.
Without hitting here and there. So,
Okay.
see now, right now, I don't see the tunnel. I see the modulus straight. See that?
Yes, sir.
Now, I am removing the inferior wall. See this. Not the medial wall. Mind it.
Yes.
Yeah, it's inferior
Yes.
wall.
Now see. Can you see the tunnel?
Yeah, we can see that.
Yes, sir.
Yeah,
Let
yeah.
me show you. Now my trajectory is inferiorly directed.
Yeah, we
See
can
the
see the
lumen.
shadow.
See the three-dimensional lumen. See the fluid
Yes,
there in the
yes.
lumen.
Yes, yes.
If there is an endoscope, can you just show with the endoscopic view? If endoscope is there.
I will show it with the styloendoscope.
Yeah, yeah.
Once I dissect the cochlea, thanks to Deepak sir again, Vishwas again for arranging styloendoscope.
Okay.
See this, I am pouring saline in the lumen. Can you see the lumen?
Yeah, yeah.
Yeah, yeah.
Deep lumen, deep lumen. Can you see this lumen? This is deep lumen. If I direct my, see now,
Yes, yes.
towards the round window trajectory, what do you see in the medial wall? That is modulus.
Yeah.
See that wall inside is the modulus. Had I not drilled this round window inferiorly, my implant would go and hit the modulus. Can you see there? And
Yeah.
now with this, see my trajectory now. Now the implant is going inferiorly in the lumen.
Straight. You can go.
See this? We have a dummy implant and we'll show you later how the implant is going in all the 2.5 tons of the cochlea.
Yes.
Dr. Satish, opening
Without hitting
this,
anything. Yes, sir.
yeah, opening this much will not empty the perilymph completely.
Pardon? Hope we?
If we open this much of round window,
Yeah.
won't we
Sudden,
empty the whole perilymph?
yes. Your point is right. To avoid intracochlear trauma, we should not give pressure excursion by sudden suction of the perilymph or anything. It may ooze out, let it ooze out, you can refill the saline or you can refill the steroid, whatever. Okay?
Okay.
But directly suctioning over lumen like this should be avoided. This will invite intracochlear trauma for sure. So in the live surgical situation, we never promote, your point is right, direct suctioning over the opening. See that opening?
Yes, yes.
Once I dissect the cochlea, I will show from inside in detail. Yes, in all cases, you extend your round window opening inferiorly until you see the straight shot insertion. See now the straight three-dimensional lumen. Can you see?
Yes,
Yeah.
yes.
What an insertion would be straight in the lumen at this point of time. Give me the styloendoscope to show you the lumen in depth.
Easy insertion.
Yeah, we have
Dr. Satish,
styloendoscope. Yes.
then in which conditions you prefer to go for cochleostomy?
No question of cochleostomy round window. We want a straight shot insertion. Why separate cochleostomy? Extend the round window inferiorly. All cases, if you make a separate cochleostomy, it could enter into a cell, infracochlear cell or something, and your implant can be misdirected.
Okay.
If you follow the round window, you will always remain in the light cable, very light cable.
Dr. Deepak.
You are using the.
Thanks to Dr. Prithvi, Senior Maxillofacial Surgeon, Trustwell Hospital.
Yeah. He come with his silent scope.
They have come with the silent scope.
Yeah.
Deepak.
Light cable.
Yes.
Next time, please get the CT scan also for the specimens.
Okay, boss. Done.
That will give more information.
And done. Yeah.
Yes.
And we will also have an LED wall in the auditorium also. Because here we are getting wonderful picture.
So
we are just getting an amazing picture here.
Okay. Don't tell that we all will come to the.
How will you clean this? How will you clean this? चल पकड़ ले इसको यार वहां से लाइट जलवा.
Something with the flexible.
Switch on the light, please. Light, yes. Hello.
Yes, boss. Prithvi, the scope, we are still getting the fibers.
See the clarity.
Yeah, we need to.
Now
it's getting better. Yeah.
Yes, better.
Yeah. Little we.
Has it been connected to the light source?
Oh.
No, the camera is focusing on the fibers, I think.
No. The clarity is not.
And reduce the light.
Reduce the light, please.
Keep it minimal. Minimum.
Focus. Upside down. Where is the camera? Upside down करना है क्या उसको? Yeah, upside down करो. Rotate upside down. Yeah, the upside down. The picture is upside down. Yes, upside down. Focus, please. Now see a very important anatomy. See the lumen.
We can see the modulus now, actually.
See the medial wall, this whitish bone is the modulus.
Yeah.
And see this extension of the white bone superiorly. That is the osseous spiral lamella.
Yeah. We need a little focus, maybe.
Clarity is not there. Yeah.
Focus.
See, I am in the inferior tunnel. See this?
Irrigation, I think.
And this is bounded superiorly by the white bone in the medial part.
Yeah.
And then the membrane in the lateral part, which is basilar membrane. I will
Yes.
show you later with the diagram.
Yes. Now we can see. No, we can see.
Yeah, this is the lumen.
Yes.
So this way, this is the straight lumen of the cochlea.
Yes.
Where my implant is going to go.
Directly
and this
to the
turns
skeleton.
2.5 to 2 3/4 tons. This above is the roof. Can you see the roof?
Yes.
The roof, the medially, this whitish is the all, what do you call that? Osseous spiral lamella. This white in the roof medially is the osseous spiral lamella.
Yes.
This is osseous spiral lamella, which is not reaching far laterally. Can you see?
Yes.
It is ending before reaching far laterally.
Yes.
So from modulus, this white osseous spiral lamella is going laterally, but before the lateral wall, and that is the gap is filled by the basilar membrane. I will show later with the microscope.
Yeah.
So this was in the lumen through the silo-endoscope. So the picture was not very clear.
Prithvi, is the endoscope lens or something to be cleaned? The camera to be cleaned?
See, let me show you what I was trying to say.
Yes, sir.
This anatomy I will show in detail. Nobody will forget ever. देखना सही लगा हुआ क्या?
Thanks, Dr. Prithvi, for obliging us with the silo-endoscope today.
Correct.
We extend a warm welcome to Dr. Madhusudan sir, who's a chairman of Trustwell Hospitals and the director of neurosciences, Thank you for coming today. Thank you.
The great
As
Madhu
usual,
Sudan,
Dr.
the great
Satish,
neurosurgeon.
sir, doing a
See now,
good job. Thank you.
what I'm trying to say, can you see the microscopic picture?
Can
Yes,
you
yes.
focus a little bit, sir? Little
Yes. Now,
focus.
Now,
Yeah.
yes, yeah. We are getting a very good view now.
Yes, sir.
now
Excellent.
see, this is the cochlear tunnel. Can you see?
Yes,
The
sir.
medial wall, this is modulus.
Yes, sir. Yes.
So my tunnel now, my drilling of the round windows enables me to go straight in the tunnel. Can you see the straight in the tunnel?
Yeah, yeah,
Now, from this medial wall modulus,
yeah, yeah.
in the roof, a bony lamella is going in the roof like this.
Yes, sir.
See this?
Yes,
Which is
yes.
separating above from the scala vestibuli,
Yeah.
scala tympani. That
Yes.
bony lamella from the modulus is going above the roof of the scala tympani like this.
Yes, sir.
And before the outer wall, it ends over here,
Yes.
roughly here. And
Yes.
from end of this lamella to
Yes,
the
sir.
outer wall, this gap is filled by basilar membrane.
Yes, sir.
Got my point?
Yes, sir. Yes, sir.
So that basilar membrane separates above from the scala media, which is close to the outer wall.
Yeah.
See this scala osseous spiral lamella emerge from here,
Yes, sir.
ends over here, and then the basilar membrane starts.
Yes, sir.
From the edge of the basilar spiral lamella, one more membrane goes anteriorly. So between these two membrane encloses the scala media, and above the regional is the scala vestibuli. Just, I will show in detail, just to apprise you, pen and a paper. Just in brief what I had shown in a minute, so that you will not get confused.
Yes, sir.
Paper, any paper. Give me any paper. Yes. See this. Hello?
Yes, sir. Yeah.
You were looking from the round window like this. Okay?
Yeah. Yes, sir.
In the medial wall is this basilar membrane. Well,
Yeah.
sorry, the modulus.
Modulus.
Now this is the cavity.
Yes.
There's one osseous spiral lamella arching from the modulus like this towards the lateral wall, like this. What my point?
Yes, sir.
Our
Osseous
inferior cavity is scala tympani. Okay?
Yes. Yes.
From the end of this, can you give me regular pen? Regular pen. Any ball pen? From the end of this osseous spiral lamella, which is ending at a free edge.
Yes.
From the modulus here, this osseous spiral lamella ending here.
Yeah.
Now from here, a thin membrane goes towards the outer wall.
Yeah.
To complete this as a scala tympani where we are putting our implant. Okay?
Yes, sir. Yes,
This
sir.
is what we have opened.
Yeah.
Okay?
Yes, sir.
Now from here, from the edge of the osseous spiral lamella,
Yeah.
there is another membrane going towards the outer wall.
Yeah.
This is basilar membrane.
Yeah.
And this is Reisner's membrane.
Yes, sir.
This is promontory, outer wall of the promontory.
Yes, sir.
Promontory. So close to the outer wall of the promontory, this triangular space is enclosed between two membranes.
Yes, sir.
This entire cochlear tube is divided into three cavities now.
Yes, sir.
Got my point?
Yes, sir. Yes.
So this is scala media, this is scala tympani, and this is scala vestibuli.
Yes, sir.
So this modulus and the spiral ganglion cell population is here.
Yeah. Yeah.
We want the implant to line the scala tympani.
Yes, sir.
Closest to the
Modulus.
modulus, closest to the spiral ganglion cell bodies for the optimum stimulation.
Yes, sir.
So we want implant to line this inferior tunnel.
Yeah.
Now, if you don't make this extended round window and push your implant right on the modulus here, it will curl. It will curl and it will fracture the fragile osseous spiral lamella. It will fracture the membranes. And then the entire endolimb, perilimb all mixes. And that is the huge intracochlear trauma. Everything is destroyed. The residual hearing is destroyed.
Yes, sir.
So this scala media contains the endolimb.
Yes, sir.
And rest 2 contains the perilimb.
Yes, sir.
The ionic composition of endolymph is rich in potassium and this is rich in sodium, which is important for optimum, generation of the electric wave.
Yes.
And if this is disturbed, that everything is lost. So that is highest level of intracochlear trauma. So
Yes.
in order to protect this, our implant should go in the inferior tunnel.
Yes, sir.
Without disturbing these 1, 2, 3, anything. So this can go only if you see the tunnel directly rather than hitting on the wall.
Yes, sir.
So to show this better, for optimum cochlear implantation results, I will dissect the cochlea from inside later and show you how the cochlea is formed. This is a very complex anatomy which God has given us for a specialized function and will uncover today in detail before going to the skull-based procedures. Okay?
Yes, sir. Yes, sir.
So this is the outer cochlear wall. This is to be preserved. This is a specialized, periosteum, spiral ligament, and all this which secretes the fluid, the endolymph, perilymph, and we have to protect this from damaging.
Yes, sir. Yes.
Yeah. So just opening the round window is never sufficient.
Yes.
Pushing the implant blindly is not sufficient.
Yes, sir.
Everybody asks and go in a fight whether round window approach is good, peri-round window is good, cochleostomy is good, whether varia is good, posterior tympanotomy is good. Anything is good if you under vision implant into the straight tunnel. Whatever technique you are using, at the end you should be able to implant under vision.
Yes,
Straight under vision. Got my point?
Yes, sir. Yes.
Yes. So let me widen this tunnel and show you. I will push my implant and show you what I'm trying to say. See this? Little bit I'm widening here.
Yeah.
Deepak, sir?
Sir, most of the patients
See
are
the
children.
tunnel?
Yeah.
Can you see the tunnel?
Yes, sir. Very well.
Most of the
Dr. Madhusudan
patients.
sir has joined us in the hall here, sir.
Most of the
Who?
patients are children,
Dr.
sir.
Madhusudan sir has joined us in the
Yeah.
If the children are affected with meningitis, what are the precautions to be taken to the ossificants of this cochlear ossificants?
Pardon?
Most of the patients are pediatric age groups. If the patient suffering from meningitis, then what are the precautions to be taken?
What is the?
What?
Precautions
Satish.
to be taken
Precautions.
to...
Okay, that's a great question. I'm coming to it. See this.
Regarding meningitis.
See now, like this is the implant, dummy implant. See my tunnel now?
Yes, sir.
Can you see the straight tunnel?
Yeah, we can see, sir. Very well.
If you push your implant into this straight tunnel, this is always going to go straight everywhere without hitting here and there. वो दे forceps, implant forceps देना यार, चल ये दे दे. See this? If implant goes in this inferior tunnel, see this?
Yes, sir. Yes.
See, this is straight shot insertion.
Okay.
Yeah, very clear.
Once it is going without hitting any wall, keep on pushing, it will keep on going inside. See this?
Yes.
Yes.
Keep on going till the end without going here and there. See this implant is coming out?
Yes. Sir.
Yeah.
Implant is going. So this is in the inferior tunnel. This way I am not damaging any basilar membrane, osseous spiral lamella or anything. Can you see this?
Yes, sir. Yes.
It should be a straight tunnel. Got my point?
Yes, sir.
Rather than hitting on the modular. See like this.
Yeah.
That's just to give you an overview. Now coming to your question of the ossificants. Let me point out at one very important structure at this point, at the beginning of the round window.
Yeah.
See this? Close to the round window opening here. Close to the round window opening here.
Yes, sir.
In the medial wall here. In the medial wall.
Yes.
See, my instrument is going in.
Yeah.
In the opening.
Yes.
My instrument is going in the opening. Very small sub-millimetric opening.
Yeah.
Is the opening for the
Singular
cochlear aqueduct. Number one.
Yes.
And there are a couple of openings of the inferior cochlear veins.
Yes, sir.
So this cochlear aqueduct, I will show the other end of the cochlear aqueduct during dissection, translate dissection. This cochlear aqueduct is the lateral end and the medial end of the cochlear aqueduct. From here, here it goes medially here at the posterior petrous ridge.
Yeah.
Just above the jugular bulb.
Yes.
From here, medially, it goes deep and deep medial. During the translate dissection, I will show just above the jugular bulb, it opens in the posterior canal fossa.
Yes.
The posterior canal fossa is the wide end and the narrowest end is in the scala tympani, the basal tunnel of the cochlea.
Yes, sir.
This This is a cochlear aqueduct which contains fibro-meshy material, and it acts as a shock absorber because it has a direct communication with the subarachnoid space. Why I mentioned here? Because of the meningitis, this is a direct conduit of inflammation to the inner ear.
Yes, sir.
Yes.
Post-meningitis, if it is particularly pneumococcal, this acts as a direct conduit of inflammation extending from the subarachnoid space to the inner ear, right from the basal turn of the cochlea, and the ossification starts first close to the round window in the basal turn of the cochlea.
Yes, sir.
And then it progresses in the entire basal turn, middle turn, apical turn. Then it progresses in the scala vestibuli. First starts in the scala tympani, then in the scala vestibuli. And that's how it progresses. If we know this, the child who has developed pneumococcal meningitis, in the Western world, what we are not practicing, evidence-based medicine everywhere in our country. The first call from the pediatric unit of any child who develops meningitis goes to the otolaryngology unit.
Okay.
In the first call to start the antibiotic steroid to prevent, further spread and to monitor the hearing.
Very good.
Yes, sir.
Those children, adult, anybody who develops meningitis must be monitored for the hearing. If the hearing level goes below 30 decibel, is the indication for immediate MRI.
Okay, sir.
A T2 weighted, heavily T2 weighted image, which picks up the fluid of the cochlea as a hyperintense signal. The initial meningitic response ossificans first starts with the fibrosis, then ossificans.
Yeah.
The fibrosis starts, the fluid signal will be lost in the cochlea, which can be picked up by MRI.
Okay, sir.
And that is the time to implant. If the patient is not implanted in that given time, the ossification ensues and then the implantation is so difficult.
Okay, sir. Okay.
So that's why in all meningitis patients, the first call goes to the ENT to pick up earliest changes of meningitis in the cochlea,
Okay, sir.
to prevent future implantation if not taken care of at that point of time. So we can implant even before the ossification ensues.
Okay, sir. Irrespective of the degree of deafness, are we implanting?
Yeah, if the deafness is increasing and the MRI is losing the fluid signal,
yeah,
that is the indication that the fibrosis is started and the ossification will ensue further.
Yes, sir.
If not taken care of.
Yes, sir.
So, in the children, in the youngest of the implant, because of the meningitis concern, implanted in the world is 4 months old.
Okay.
Though the FBI, declares as 12 months as a minimum limit, but because of the concern of meningitis, otherwise the child will lose the opportunity later on if the cochlea ossifies.
Okay, sir.
So that is something has to be done earliest. If suppose the patient is not affording that point of time for the implant cost and so many things matters, what you can do, you can put a dummy implant inside the cochlea to keep the lumen intact.
Okay, sir.
So that will be acting as a lumen keeper.
Okay.
The companies give dummy implant free of cost.
Yes, sir.
In such patients where the right point, how to manage the meningitis in our patients, and if it is pneumococcal give highest incidence of ossificans.
Yes.
Dr. Satish from
where is he?
Any conservative method to prevent?
So we are pleased to have our the boss, the neurosurgeon, Dr. Madhusudan, and I am his big fan of his surgical skills, his work. And Deepak sir, I am saying here, Deepak sir is so fortunate to have a colleague like Dr. Madhusudan in his team. Amazing.
Thank you, sir. Really appreciate.
Yeah, Madhusudan is a phenomena. What an amazing neurosurgeon. I had some time got the opportunity to work with him and learn little bit of the things, whatever time I had. And he's amazing.
Embarrassing me beyond. Thank you.
He's amazing.
Sir, one question from a neuro point of view.
Yes, please.
If a child is having meningitis,
yes,
and you're going to implant, how do we control the meningitis infection itself?
So, child is having meningitis, active meningitis is never an indication for any surgery. You have to control the meningitis first.
Okay.
At the same time, you have to monitor the ossification.
Okay.
All meningitis do not give ossification. It is mostly.
So only after the CSF has turned completely.
Yeah, absolutely normal.
Okay.
Then only. During this period,
Yeah.
if the cochlea is getting, losing the fluid signal, you have to implant.
Okay.
Either if you can implant the actual one, you can. Otherwise, you can put a lumen keeper to keep the lumen intact for future implantation.
That's a learning for us.
Okay, boss. So,
Sir, I am
yes,
Dr. Nageswara,
another
sir.
question. Hello?
Sir, I am Dr.
Yes.
Nageswara, sir. Can you...
Pardon, sir?
Nice route.
Hello?
Hello?
Hello? Hello, can you hear me?
No.
Yeah, please
In
proceed.
the auditorium, we
Yeah.
can hear you.
Another question at this point of time
Yeah.
came to me is regarding the singular neurectomy.
Yes, sir.
I'll come to it. The one more point here. This is the opening for the cochlear aqueduct. And
Yes,
close
sir.
to it are a couple of openings of the inferior cochlear vein. So these are in the medial wall.
Yes, sir.
Mind it, at the time of enlarging the round window, we are not working at the medial wall at all.
Okay,
We are
sir.
not drilling on the medial wall to kill all this.
Yeah.
We are working only on the inferior wall to widen inferiorly.
Yes, yes.
Never ever drill on the medial wall to protect all this. Okay?
Yes, sir.
Now, another question from Dr. Kumar Swami is our senior colleague regarding the singular neurectomy. Singular
Yes.
neurectomy, singular nerve is what? Is a branch of inferior vestibular nerve which supplies the posterior semicircular canal.
Yes, sir.
And posterior semicircular canal which is responsible for BPPV most often.
Yeah.
Because the otoconia released, they settle down in the most dependent canal and the most inferior one is the posterior one.
Yes.
For BPPV, the primary treatment is the maneuver, Appler's maneuver to resettle down, allow the otoconia to resettle down,
Yes, sir.
from the place where it has come from the canal. To drill the posterior canal, blue line it, and the final bone you remove with the elevator and expose the periosteum in endosteum of the canal. Never ever damage the endosteum. And then push the endosteum with a bone wax or the bone dust to plug the canal, circulation in the canal. If the posterior canal circulation is blocked by pushing the bone dust without opening the endosteum, the circulation in the canal is stopped and the vertigo so. Vertigo happens because of the air currents generated because of the otoconia. So when the circulation in the canal is over, the VPP is finished. But that requires an invasive approach. That requires opening the posterior semicircular canal, where you have to be careful not to damage the endosteum. If you open up the endolimb, then the sensorineural hearing loss is imminent. So in 1980s, Kesek was the surgeon who described the technique to denervate the posterior canal.
Yes, sir.
Posterior canal is supplied by the singular nerve.
No.
Now, where the singular nerve is lying? Is diamond there.
In relation to round window, sir.
So singular nerve comes out of the intra-aortic canal. Here is the level of the intra-aortic canal in the depth. The depth, intra-canal is quite deep. See, this is the posterior canal. Deep to posterior canal would be the intra-aortic canal.
Yes, sir.
So that now comes singular nerve comes from the intra-aortic canal.
Yeah.
Laterally.
Yes.
Here is the vestibule.
Yes, sir.
Here is the posterior canal ampulla.
Yes, yes.
So that now comes from here to the posterior canal ampulla. From the intra-aortic meatus to the posterior canal ampulla.
Yeah.
And that is the point where you can damage that nerve.
Okay, sir.
So that is Gessex procedure. One can do transcanal.
Yes, sir.
This procedure has gone to disrepute after that because of difficulty in identifying this nerve.
Yes, sir.
Let me tell you the key point, the landmark where you can identify this nerve easily. See this. Here is your round window.
Yes, sir.
No, round window.
Yes,
not
downwards.
very clear, sir. Can
you see the round window opening?
Yes.
Now we can.
Now we can see.
Now you can. So 1 millimeter inferior to this and roughly 2 millimeters deeper. See this here.
Okay.
This is the site where this nerve comes. I can see the glimpse of the nerve.
It's like a thread-like structure, sir.
Yeah, hairline structure.
Okay.
That's the nerve.
Okay, okay.
That's the nerve, and
Yeah.
one can.
Higher magnification?
Yeah. This is the nerve.
Yes, we can see.
Yes.
Yes.
No, is
This
it?
nerve is to be damaged here. This
Yeah.
nerve here, coming from the intra-aortic meatus to the posterior canal, and
Yeah.
in this course, this should be completely
Yeah.
drilled off, or you can use a cautery over here. See this, like this.
Yeah.
That's it.
It is inferior to round window, sir. A millimeter.
Inferior and deep to round window.
Okay.
Completely drill away
Okay.
to denervate the posterior canal. This is another treatment of definitive treatment of
Yeah.
BPPV.
PPP. Yeah.
Sometimes the autoconia can pass on to other canals also, which can further, keep on giving BPPV. So if all these procedure fails,
Yes,
then
sir.
you have to do a triple canal plugging.
Hmm.
Triple canal plugging is what? All these three canals, like posterior canal, same
Yes.
thing is done with all the three canals.
Satish, what is your experience in the singular neurectomy?
Yeah, I have done a few cases. Most of the patients nowadays, resolve with the Appel's maneuver. Most of the patients.
Risk
Very
of
easy to do all.
So any risk of hearing loss, sir, with this while trying to drill below the round window? Because you're drilling the basal turn.
No. There is nothing, no hearing material here. See, we are here, right here, not going anywhere to the hearing system, anywhere inside the cochlear vestibule. Okay? Only the singular nerve is damaged. Okay? So we will go in the depth of the anatomy of the cochlea and the vestibule later.
Yes, sir.
Now this is the intact canal wall, and I can show one procedure here before going to the depth. I showed you, I mentioned earlier, in the end I will show you the subtotal temporal bone resection and block, and which is the most major procedure, and we'll be needing both the occipital and the middle fossa craniotomy, for which Dr. Madhusudan is here to help us out for the craniotomy, to make that procedure simple for the subtotal dissection of the temporal bone. Before that, for the external auditory canal malignancies, another very, very useful procedure described, that is lateral temporal bone resection. These malignancies have to be thoroughly investigated and addressed, otherwise they ultimately give poor results in terms of outcome. So this external auditory canal malignancy, the external auditory canal is here. Malignancies of external auditory canal have a tendency to go very early in the course anteriorly into the parotid. Either contiguous spread by the fissures of Santorini, that is the potential space, or through the first echelon lymph nodes which are situated in the parotid. So most of the external auditory canal malignancy where the middle ear Petrus bone is not involved, the limited procedure is the lateral temporal bone resection. And you can remove this entire sleeve of the bony and the cartilaginous canal intact, along with the tympanic membrane below, along with the malleus and the incus below, separating at the IS joint, entire circumference of this bone, along with the lining, flap, this skin, everything can be removed and blocked. That is lateral temporal bone resection. And you can reconstruct the hearing later on with the stapes. So in lateral temporal bone resection, it is almost always associated with the parotidectomy anteriorly. See this? The parotid, either there is a contiguous spread or a lymph nodes, first echelon lymph nodes. And that parotidectomy specimen is sent for frozen then. Always has to be sent for frozen for optimizing our results. If any of the lymph node is positive, you have to do a total parotidectomy.
Sir, is it superficial peridectomy, deep peridectomy, sir? Is it superficial peridectomy?
Is completing the parotidectomy, total parotidectomy, including the deep lobe as well. The reason is the lymph nodes in the superficial lobe are in continuity with the lymph nodes in the deep lobe. If any of the superficial lymph node is positive, you have to convert to a total parotidectomy. And if any of the lymph node is positive, you have to do a selective neck dissection also of level 1B, 2, 3. And in sampling, if any of the neck is positive, neck node is positive, then you have to do a complete modified neck dissection. That's the protocol. So neck has to be addressed accordingly, optimally. Now, drill the medium size partly. How to remove this? How to remove this and block? See this? The posterior tympanotomy is the medial limit.
Yes,
you
sir.
can see very clear?
Yeah.
And staying lateral to it, all around, including the TM intact in the specimen, That is lateral temporal bone resection. See this? My lateral limit is here, the bone. Anterior limit is here, outside the canal, outside the cartilaginous canal. This is your zygomatic arch. See this?
For lateral.
This is your limit of resection all around.
Yes.
So now, during this procedure, now see, we were respecting the chorda here. Now we have to sacrifice the chorda as well. So what I will do, I will go in the attic all around.
Yeah.
It's a very useful procedure. Everybody, any middle ear surgeon can do it easily.
Yes. For lateral temporal bone dissection, facial recess is a prerequisite, sir.
Pardon?
For before doing lateral temporal bone dissection, should we do facial recess before performing?
Yes, yes. Facial recess is the limit because facial nerve has to be left below.
Okay, sir.
Yeah. Prerequisite. You have to stay lateral to the facial now.
Yes, sir. Yes.
This is my anterior limit.
Yes.
See there?
Sir. Yeah.
So entire canal skin will come intact with the bone.
Yes.
And tympanic membrane together. That is lateral temporal bone resection.
Along with malleus and.
Along with malleus, incus.
Yes.
Except stapes. Except stapes. Sir, how to avoid injury to the TMJ in this?
Yeah, TMJ bone most of the time comes along with it, the bone behind the TMJ.
Sir.
You are not damaging the joint. You are removing the bone posterior to the TMJ.
Sir.
The bone separates from the TMJ clearly.
Yeah.
In any given situation, if the TMJ is involved, along with the parotid, you have to remove the TMJ as well.
Yes, sir.
Now going toward the hypotympanum.
Yes, sir.
And you have to stay above the jugular bulb.
Yeah.
You have to sacrifice the chorda tympani.
Yes, sir.
And stay above the jugular bulb. Clean kar de iska lens. I hope the picture is good there.
Yes, sir. Fine.
Yes, sir.
Very clear.
See this chorda. I am taking off and going in the hypotympanum.
Yes, sir.
My medial limit is the facial nerve. See the facial nerve?
Yes, sir. Very clear. Inferiorly, as we are going, are we exposing the jugular bulb, sir, or?
No, we are staying just lateral to the jugular bulb.
Lateral to the jugular bulb. Okay, sir.
We have to stay lateral to the jugular bulb. We have to stay lateral to the Eustachian tube.
Yes, sir. Yes.
Yeah, this is only for the extraordinary canal lesion.
Yeah.
If the malignancy happens to involve the middle ear or the petrous bone, and the en bloc resection is the answer. Definite answer.
Okay.
Best alternative, I would say. See my digastric ridge, can you see?
Yes, sir.
See, it is pointing right on the facial nerve. Can you see?
Yes, sir.
And here is the stylomastoid foramen.
Focus.
Here is the stylomastoid foramen. See
Fine
that?
focus.
See, this is facial nerve. What a great landmark.
Yes, sir.
Oh, dangerous यार. Vowel कर रही है. Fit. Vowel.
Can you focus a little bit, sir?
Yeah.
Over the facial nerve.
Injure the facial nerve. The drill is wobbling. इसे छोटा दे ना, छोटा दे ना. See, I am right into the hypotympanum here.
Yeah.
This way I am going anteriorly.
Yes, sir.
Similarly, from superior side, sickle them. See, this is your malleus. This is the step is below. So my level would be at the maleo-incudostapedial joint. See this?
Yes, sir.
See the step is head below.
Yeah. Fine focus. Little bit fine.
See this? वहां से कर यार. Better?
Okay, sir. Yeah.
Magnify. Okay.
Yes.
Better?
Sir. Yes, sir. Yes.
See the step is head.
Yeah.
Now
we can all. Yes, sir. Yes.
Circumferentially keep thinning the wall and keep going. Going through the attic.
Yes, sir.
So what are the indications for this surgery? Apart from malignancy?
No other indication. Malignancy.
No. Can we do this?
This is the radical treatment for the external auditory canal malignancy and block excision of the external auditory canal.
Okay.
Popularly known as lateral temporal bone resection.
Yeah. Can we do this in cases of malignant otitis externa? If it is
malignant
to this
otitis
bone.
externa is a different entity, let me tell you.
Yeah.
That is infection in diabetic patients. And the infection, diabetes is, we all know, is a microvascular disease. And the drug penetration is difficult. And that infection involving the bone, giving osteomyelitis with no vascularity, drug not reaching to the area, is a difficult is a difficult entity. I am cutting the tendon.
Yes, sir.
See this tendon here? Yeah.
Inserting penny.
So, skull-based osteomyelitis is purely Pseudomonas infection in immunocompromised patient where the status is diabetes.
Yeah.
So, most of the time, majority of the times, even drugs do not penetrate.
Right.
And infection in the bone is very, very difficult to control. And our procedure for choice on those patients is to get a good MRI, the T2 weighted and diffusion to see the infection, the involvement of the bone, the necrotic bone, wherever, and remove that necrotic tissue. It is like gangrene.
Yeah.
It is like gangrene, diabetic gangrene. You have to remove the gangrenous tissue. So wherever is the necrosed tissue is, within the temporal bone, we do a subtotal petrojecmin obliteration so that it doesn't remain a discharging cavity later on. That is our procedure of choice, and you can cure majority of the patient.
Okay.
Many a times we have seen in that skull-based osteomyelitis, the infection extending beyond the temporal bone. We have seen many a time going in the infratemporal fossa, parapharyngeal space, anywhere going, you have to chase the necrotic tissue and remove it, where there is no drug penetration.
Sir, what is the difference between lateral temporal bone resection and sleeve-like excision?
What is the
difference between this lateral temporal bone resection and sleeve-like excision of the actioneal?
Difference between
sleeve-like excision and lateral temporal bone resection.
Sleeveless resection.
Sleeve-like.
Sleeve-like resection
Hmm.
of the canal.
Yes.
This is what we are doing. That is what the lateral temporal bone resection.
Yes, sir.
Complete removal of the canal sleeve. This is what exactly we are doing. Removal of the canal sleeve completely. And block removal of the tumor along with the canal skin and the bone. Previous section. See, in life situation, you have to work more and more with a diamond and takes away a lot of time. You have to be having patience in this.
Sir, you can go to little bit low power, sir. It is magnified.
Low magnification?
Lower magnification, better.
Yes.
Yeah. Focus, sir. Focus.
Better?
Yeah, but fine focusing. Little bit focus.
Okay. Focus kar.
Yes.
See, this way I am going more and more.
Yeah.
Centering my specimen on the wall lateral to the Eustachian tube. Then with the chisel and hammer, we will break entire as a single unit.
Yeah.
You have to remove whatever. If anything is involved in the cancer, it has to go, undoubtedly.
Medially, sir, if you are drilling this way, what
See,
to...
my Eustachian tube is in my view. See my
Yeah.
Eustachian tube orifice.
Yes.
Hello?
Yes, sir. Yes, we can see. Even
My
hypotension.
Eustachian tube orifice is in my view.
Okay. Yes, sir.
All the way.
Yeah.
This is thick tympanic bone I am drilling.
Yes, sir. Yes.
This is all tympanic bone.
Yeah.
Forming the circumference of the canal.
Yes. Should we keep the Eustachian tube in view, sir, when we are while drilling
The
this?
Eustachian tube will be medial limit.
Okay. Yeah.
You are not supposed to go in the medial wall of the Eustachian tube, rather stay lateral to it. Medial wall of the Eustachian tube has carotid artery.
Yes.
See, I am lateral to the jugular bulb this way.
Yes. Towards the hypotympanic area now.
Yes, my jugular bulb is here left below.
Yes.
Yes, sir.
Sir, if you don't mind, can you define the high jugular bulb?
Huh?
High jugular bulb?
Yes, sir.
High jugular bulb is when it over project in the hypotympanum.
Sir.
Now the definition why people have defined separately, differently.
Yes.
In my opinion, if your jugular bulb reaches high to the level of the posterior semicircular canal, it is considered high. If it reaches above that level to the round window,
yes,
considered high.
Yeah.
Then if it goes above that level, considered very high.
Very
Sir.
A high jugular bulb is a big problem to the skull-based surgeons, and there are maneuvers to manage that. It's not a contraindication for any surgery. We have seen in the practice many times coming across high jugular bulb. Then you have to skeletonize the bulb and push it down with the Surgicel and bone wax. You can push it down as much as you want.
Sir.
But you have to deal with it.
So this is the lateral temporal bone resection. How is it different from subtotal temporal bone resection, sir?
Subtotal means, see, this lateral temporal bone is limited to the exonerary canal. Subtotal means everything, this entire bone has to go along with the labyrinth, everything.
And
Facial nerve, labyrinth, everything.
And the choice of neck dissection in this case would be to what extent, sir?
To what extent?
Yeah.
Depending upon the lymph nodes, I told you. We do a superficial parotidectomy along and send the lymph node for frozen section. If any of the lymph nodes in the parotid turn positive, we remove the entire parotid and again send for frozen. And do a level 2, 1B, 2, 3 dissection. If any of the lymph nodes is positive in selective neck dissection, then you have to convert to a comprehensive neck dissection.
So
it is like that.
End limit of dissection in this lateral temporal bone is visualization of what all structures, sir?
In lateral temporal bone?
Yes, sir.
Lateral temporal bone, see here. I'm all around the canal, the bony canal. I am respecting my medial limits. See that? My medial limit is the Eustachian tube below. See this? Can you see the Eustachian tube orifice?
Can you show it with the probe, sir? Small probe.
Yes, sir. Clear.
Here is my Eustachian tube
Yes,
orifice.
sir. Yes.
Yeah.
See that? That is my medial limit.
Yeah.
Lateral limit. See this? My tympanic membrane is in the specimen.
Okay, sir.
Tympanic membrane, malleus, incus are all in the specimen.
Yes, sir. So it is the external auditory canal, tumor in the external auditory canal, tympanic membrane, malleus, and incus.
Now,
along with.
let
Yes,
us
sir.
assess for the final cuts.
Yes, sir. Yes.
Let me assess for the final cuts. Let me clear this soft tissue here. Chisel hammer, no?
Sir, can we fracture it now, sir?
Pardon?
Can we fracture it now? Fracture.
No, are you going to
Yeah,
fracture?
yeah, I will fracture at the end. I will fracture. I will fracture in toto.
Yes, sir.
Chisel hammer.
If you expose the external auditory canal, it will be better, sir. The view will be
See,
better.
now the extra-auditory canal all around is segregated. Can you see?
No, lumen of the external canal. Please expose the lumen. Yeah, canal. Yes.
Here it is the canal.
Yeah. Okay, sir.
Here is the interior of the canal.
Yeah. Yeah.
Okay?
Yes, sir. Yes. Yeah.
See this?
Yes, sir. Yes.
Coming en bloc.
Yes, sir.
See the inside of the canal. This
Yeah.
is the sleeve of the canal.
Yes, sir. Yes.
Coming en bloc intact. That is.
Yes, sir. Yes.
This is lateral temporal bone excision, and after this resection,
Yeah.
one can reconstruct this.
Okay.
See, my stapes is here.
Yeah.
Stapes is here. This is the stapes.
Yes,
This
sir.
is the promontory.
Yeah.
That's the Eustachian tube. Let me show you under magnet. Can you see?
Yes, sir.
My cut was lateral to the Eustachian tube.
Yeah.
See this?
Yes, sir.
The Eustachian tube is medial there.
Yeah.
Now some anatomy. Having removed all this, this is the facial nerve coming
Yes.
all the way. This was injured here. This is the lateral canal.
Yes, sir.
That is the stapes.
Yes.
This is the process of cochleariformis.
Yeah.
This is the tensor tympani muscle coming, and then this is the tendon through the
Yeah.
processus.
Yes, sir.
This is promontory.
Yes.
See the round window from behind.
Yes. Yes.
And this is the nerve
Yeah.
crossing the promontory. Can you see this?
Yes, sir. Very well.
This is Jacobson's nerve.
Jacobson's nerve.
Yeah.
This is coming from here in the hypotympanum.
Yes, sir.
At the level of the crotch, the area between the jugular here and the carotid here. I will show you.
Sir,
At
roll up.
that point, it is emerging from the glossopharyngeal.
Yes, sir.
Okay?
Role of tympanic neuronectomy in Fraze syndrome, sir. Please explain.
Yes, that is one of the options. This
Yes,
supplies ultimately the parotid gland.
sir.
The postganglionic fibers from this nerve, from the otic ganglion, are supplied to the auricular temporal nerve to the parotid.
Yes.
So in Fraze syndrome, wherever you want the parotid secretion to be reduced, diamond, thodi badi diamond.
Yes, sir.
You have to do this tympanic neurectomy. You can do that. There is a simple procedure. Though majority of the time you need not to do all this. Now see, this is Eustachian tube.
Yes, sir. Yes.
This is the lateral wall of the Eustachian tube. The
Yeah.
TM joint is here anteriorly.
Yes, sir.
This is Eustachian tube, and the medial wall of the Eustachian tube, this is the glimpse of the carotid artery.
Carotid.
So
That
let
bluish.
me
Yes, sir.
see. बहुत बड़ी दे दिया.
Yes, sir. Yes.
See, this is the level of the carotid artery here.
Yeah.
This is the cochlea immediately behind.
Yeah. Yeah.
And here is going to the jugular bulb, and here is going to the carotid going.
Yes, sir.
So these are the hypotympanic cells. See the number of cells.
Yes, sir.
See, sometimes the opening in this cell look like cochleostomy.
Yeah. Yeah.
So we avoid a separate cochleostomy, otherwise sometimes you are mistaken into
Yeah.
one of the cells. So I am exaggerating
Yes,
these
sir.
hypotympanic cells to show you
Yeah.
the critical structures. Just to show you better.
So that is, it is like a infracochlear approach to petrous apex, sir.
Yes. That is the infracochlear approach. I will show you the approach.
Yes, sir. Yes.
I have not started the approach. I will show you the space between
Yeah.
the area where the infratemporal. See now.
Yes. Yes.
This is the cochlea here.
Yeah.
Immediately anterior to the cochlea. This bone. This is
Yeah.
carotid artery. Vertical petrous carotid.
Yeah.
If I drill this bone, blue line this bone, you will see the carotid per se.
Yeah.
This is the carotid artery.
Yes, sir. Yes.
See that? The Eustachian tube is lateral to the carotid.
Yeah.
This is all peritubal cells I am drilling.
Yes. Yes.
In subtotal petrojectomy, you have to excentrate all these cells.
Yeah.
See the carotid now in the middle of the field.
Yes, sir. Very well.
Little more
Is the-
skeletonizing to show you.
Yes, sir.
We'll see the entire course of the carotid today, right from the origin till destination in the brain.
That is a geno portion, sir. Geno
That
portion.
is the vertical portion.
Yeah.
See this?
Yes, sir.
And
Yes.
here it turns, it becomes
Yeah.
genu to go horizontal. See
Yeah.
that?
Yeah.
See
Yeah.
the genu.
Yeah.
So this is carotid.
So,
And this is cochlea.
yeah.
And here in the hypotympanum below is going to be jugular bulb below.
Yeah. So you have accentrated all pericarotid cells.
Yes. All pericarotid cells need to be excentrated in subtotal petrojectomy. This is your jugular bulb now.
There is
Yeah.
subtotal petrosectomy for any reason. If you do, even you need to remove all these carotid
All
cells.
cells in the temporal bone for that matter.
Okay. 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 Sir, what are the
Extensive hypotympanic pneumatization you can see.
Yes, sir. Yes.
sir, apart from
Extensive.
sir, apart from malignancy, what are the other indications for subtotal petrosectomy?
So many. So many for, see, ultimately
Polyptomia.
subtotal petrojectomy achieves a dry ear. You know,
Okay. Okay.
see the jugular bulb here.
Yes.
Yes, sir. Yes.
Carotid artery there. See
Yeah.
that?
Yes, sir.
In between this is bone.
Yeah.
This bone is known as crotch, through which the glossopharyngeal gives a branch.
Yes, sir. Yes.
Let me drill this a little bit more. The Jacobson now come from here in between. The branch of the inferior tympanic artery, which is a branch of ascending pharyngeal, supplying the glomus tympanicum, come from here.
Yes, sir.
See this bone? This
Yeah,
bone is lost in glomus jugulare.
Glomus. Yes, sir.
And then this tumor, once this bone is lost, this tumor from the jugular bulb, they spread to involve the carotid artery.
Yeah.
See the carotid and jugular both?
Yes, sir. Yes.
This is the bone which is intact in between.
Yeah, yeah.
So for subtotal petrojectomy, you were asking.
Yeah.
Subtotal petrojectomy aims to give a dry ear. What all is needed is excentrating all air cell tracts, remove all skin and mucosa from the temporal bone and do a cul-de-sac closure and blind sac closure and Eustachian tube closure.
Yes, sir.
The dry sterile area and then it is closed with a fat.
So in case if you leave some of the air cells and mucosa and you
Pardon?
so in case you fail to excentrate all the cells but still you do a cul-de-sac closure, what will happen, sir?
That the mucosa may, secrete, keep on secreting, inviting secondary infection.
Okay.
So, chase all cell tracks on the basis of the CT scan.
Yeah.
In any given situation, suppose I am not able to remove the mucosa from here, you can do a bipolarization.
Okay.
Make the mucosa devitalize the mucosa.
Kill the mucosa.
See now where I am working in between.
Yes.
You talked about infracochlear approach.
Yes, sir.
See, for infracochlear approach, my limits, the carotid artery anteriorly,
Yeah.
the jugular bulb behind,
Yes, sir.
the cochlea above, and in between these cells. I will show you, I had shown you on a skull, the area deep to the petrous carotid. This is the petrous apex.
Yes.
In between these three structures, I keep on going anteriorly. See, deeper. See, I'm going deep to the carotid artery. See, straight.
Yes. Yeah.
In between cochlea, carotid, and the
Jugular bulbs.
jugular bulb, all these cell tracts I am excentrating. Right now, I am entering the petrous apex.
Yes.
This is the head-on approach to the petrous apex.
Yes, sir.
Now, petrous apex lesions can be addressed by the open approach, by the endoscopy, and by the lateral skull base approach, what we are doing.
Yes, sir.
So, which approach is useful depending upon the anatomy on CT scan?
Yeah. And the space available.
If my sphenoid is over-pneumatized,
Yes, sir.
my carotids are not in the midline and over-pneumatized sphenoid pushing the carotid laterally, I can go easily from the sphenoid.
Yes, sir.
Hello,
Straight away, straightforward, I need not to drill all this.
Dr. Satish Jain.
Depending upon the favorable anatomy. Yes, sir.
Hello, here you did lateral temporal bone resection and then you are showing the subtotal petrosectomy, isn't it?
Yeah, I am showing all the anatomy one by one.
Yeah, what I mean is subtotal petrosectomy, if you had shown before the lateral temporal bone resection, then we would have assessed how much space you would have got.
Then I would have removed the canal. Now to show the lateral temporal bone resection.
Okay.
I would have removed the canal completely then.
Either this or that. But here, subtotal petrosectomy, here we get more space after lateral temporal bone resection. But actually, we don't get so much space.
That actually has to remove as a part of subtotal petrojectomy. You have to remove the entire canal, skin, everything.
Okay.
That's a part of subtotal petrojectomy.
Okay.
That gives a more exposure, is a bigger procedure than canal down. Because you have to chase down all cells. Now see, this is the entry into the petrous apex.
Yes.
Yeah.
Yes.
So to address the petrous apex lesion, like cholesterol granulomas, cholesteatomas, so many things, you can address by the lateral skull base approach, you can address endoscopically, you can address by the petrojectomy neurosurgical approach.
Congenital cholesterol.
So depending upon the favorable anatomy from CT scan, you have to choose the right approach. Okay?
Sir, they said these are for infracochlear or whatever approach we have to the petrous apex, sir. They are for this infracochlear approach to petrous apex.
Yeah.
For petrous apex lesions, like you said, the cholesterol granuloma or mucocele, they are like drainage procedures, sir, not excision. They are like drainage.
It's a drainage procedure. Yes. So, like if there is a cholesterol granuloma, you remove and leave a wide drainage in the middle ear.
Okay.
That's the cure.
Yes, sir.
You remove and leave a wide drainage in the middle ear. That gives the cure. So this is petrous apex going down. I will show petrous apex today from various different angles. Okay.
Yes, sir.
Now, coming to the medial part. Now, what you see is the facial nerve.
Yeah.
This facial nerve, I told you in the beginning, we'll discuss the facial nerve course in detail, right from the origin at the brainstem till destination.
Yes, sir.
What you see here in the temporal bone, this is the vertical course.
Yeah.
First genu, horizontal course, and from there, it becomes the
Labyrinthine.
labyrinthine. So, and first we'll discuss this, then we'll remove this part of the facial nerve and go deeper.
Yes, sir.
See, this is the genu.
Yeah.
Second genu. This is processus cochleariformis, and now I am going to the first genu.
Yes, sir.
See that first genu?
Yes, sir. Yes.
This is the tegmen above.
Yeah.
Now, first genu, beyond the first genu, the labyrinthine segment. See, from here it becomes vertically medial and behind going as a labyrinthine segment. Chota dena.
Yes, sir.
Now, whether you can address the labyrinthine segment by the transmastoid approach like what we are doing, or will require a middle fossa approach, depending upon the anatomy, space. How you can decide on the basis of CT scan.
Yeah.
Simply.
Highly cellular mustard.
Yeah. So how you can decide? See, this is the level of the lateral canal.
Yes, sir.
If my axial cut at the level of the lateral canal, you measure that distance from the tegmen.
Yes, yes.
If the distance is more, that means you have ample of space to address from the transmastoid. If the tegmen is down close to the lateral canal, means space is less and you cannot address the labyrinthine segment from here, and you have to go by the middle fossa approach. And today we will show you in detail the entire middle fossa approach. Okay?
So even if the mastoid is not pneumatized like this,
pardon?
If the mastoid is sclerosed, it is difficult to approach the.
Yeah, labyrinthine segment, then you have to go by that middle fossa.
Yes, yes.
Middle fossa approach is the most direct approach to the labyrinthine segment. Though it is a complex approach, you have to do a middle fossa craniotomy, extradural, and then reach out there. Now see, this is I am reaching toward the first genu. See that?
Yes,
Yes, sir.
From the first genu, it gives off a branch.
Yeah. GSPN, sir.
Yeah, little under magnification, I am showing something. Patla de. Ye bhi patli de. See, I am showing something here. A very, very important anatomy. See, that's the facial nerve. See this?
Yes,
Yeah.
yes.
Yeah.
This is the tendon of tensor tympani here.
Yes.
And this is the tensor tympani muscle, and the Eustachian tube is below.
Yes, sir.
And in the floor of the Eustachian tube is the carotid artery.
Okay. Yes,
Now, see this. Here the carotid is taking the anterior turn. In the genu, the carotid going anteriorly like this. Okay?
Yes, sir.
But extracranial. Can you see? Extracranial.
Yes.
This anatomy will show again from the middle fossa perspective. Here, this is the facial nerve. See, this is the facial nerve.
Yeah.
Yes, yes.
And here the facial nerve. See here. Here it turns deeper here. See this deeper.
Yes, sir. Yes.
Like this and comes back like this.
Yeah.
Here it deeper and comes back like this into the intra-aortic canal. That short segment is the labyrinthine one.
Yes, sir.
And at this genu, it gives off a branch anteriorly. See that branch going?
Yeah.
See that branch?
Yes, sir. Yes.
Yes, yes.
Going
This
anterior.
is the branch going anteriorly.
Yeah.
That is GSPN.
Foramen osseum.
See this. Let me show you very clear the GSPN.
Jumps into the
It's a
foramen.
very important landmark for neurosurgeons.
Sir.
For us, there's a very, very important landmark. This is the GSPN going anteriorly. See that?
Yes, sir.
See my GSPN where my instrument is.
Yeah.
Yes,
Yeah.
sir, clear.
This is going anteriorly. Can you see?
Yes, yes, very clear, sir.
So this GSPN goes intracranial. See this?
Yes, yes,
But extradural.
yes,
And go far anteriorly at the level of the foramen lacerum.
yes,
Again, intracranial but extradural.
yes.
We'll see from the middle fossa approach again.
Yes, sir.
And this carotid artery goes extracranial right to the foramen lacerum.
Okay.
Okay? Both these structures go parallel like this.
Yes.
The landmark
One
for the carotid.
intracranial, see the GSPN.
Yes, sir.
Can you see GSPN very clear?
Very
Yeah.
clear, very clear.
There must be
GSP.
LSPN also there. LSPN, lesser superficial
Yeah, I will
petrosal
show the
also.
LSPN. I will show the LSPN also.
Okay.
So this GSPN goes intracranial but extradural.
Yeah.
And the carotid below, the GSPN above, carotid below goes extracranial. At the level of the foramen lacerum, I will show later once I remove this bone. And
Okay.
at the level of the foramen lacerum is the site of crossover. Means there the carotid ascends intracranial and the GSPN crosses the carotid and come extracranial, join the deep petrosal to form the median nerve. So the site of crossover is what? Foramen lacerum. This anatomy is GSPN going above and the carotid below. Remember, we will again see in the middle fossa approach. Okay. Here, the rest of the facial nerve goes behind. See this here. That is the posterior tongue. That is labyrinthine segment. See here,
Yes, sir.
and here it comes back above the cochlea. See, this is the cochlea.
Yes.
This labyrinthine segment again here comes back in close relationship to the basal tongue above. Close relationship. So this facial nerve will follow the course of the facial nerve later on in the intra-auditory meatus and the labyrinthine segment. Okay.
And can you show the extension of geniculate ganglion?
The geniculate ganglion. This is geniculate ganglion here. Here is the geniculate ganglion from where the GSPN is arising. See this?
Okay. Yeah.
And this GSPN carries the fibers of nervus intermedius.
Yes.
This GSPN carries the fibers into the median nerve to supply the lacrimal gland, the nasal palatine gland, all those glands, and these fibers are from nervus intermedius, which joins the facial nerve in the intra-auditory meatus.
Yes.
Yeah.
Yes. See, this is the GSPN arising from the genu.
Yes, sir.
Very clear?
Very clear, very clear.
Very clear. See this going anteriorly and the
Yes.
labyrinthine segment going behind. See here.
Hmm.
Now, this lateral canal was in relationship with the second genu.
Yes, sir.
And here is the superior canal, which is in close relationship to this
Labyrinthine
segment.
Yes, sir.
And
Yes.
this labyrinthine segment here, which comes deeper, is sandwiched between the superior canal and the cochlea.
Yes.
It's a very, very narrow segment of the facial nerve, sandwiched above between the superior canal and below between the cochlea, and runs extreme medially and posteriorly into the intra-auditory meatus. We'll uncover that. Okay?
Yes, sir.
Now, this part of the facial nerve, earlier facial nerve, see, this runs through the temporal bone like anything. Coming here at the first genu, horizontal course, second genu, and running to the running out to the stylomastoid foramen, running in the middle of the temporal bone. Similarly, parallel to it, see the carotid artery.
Yes.
Coming horizontally, anteriorly like this, like facial nerve horizontal course, genu here, and then vertically goes down to the carotid foramen in the parapharyngeal space.
Yes.
These both structures run parallel to each other. And in temporal bone lesions, which are deep to these two, how to address them? Earlier, they were considered to be inoperable. But now, having understood the vascularity, having understood the course better, and advancement in the surgical technique, we can address any lesion deep to them by transposing these structures, transposing them, placing them to different space. Like, for example, facial nerve, there are two kinds of transposition described, anterior and posterior. See, what I had shown is the jugular bulb here. Can you see?
Yes, sir.
Carotid here, jugular bulb. Now, this jugular bulb is right from here. This is the sigmoid sinus. The jugular bulb is still here. From here to here is the jugular bulb.
Okay, sir.
And in the middle of the course, it is crossed by the facial nerve. Now, if you have a vascular tumor like paraganglioma in the jugular bulb, with the carotid running over it, the facial nerve running over it, how can you address and preserve the facial nerve? Either compromise with the tumor removal or compromise with the facial nerve. So what we can do, this facial nerve goes out of the stylomastoid foramen in the parotid. I will show you later. I will transpose this facial nerve by exposing right beyond the bifurcation and elevate this from here to here, the entire coastal first genu, elevate and put it here anteriorly.
Anteriorly. Yes.
Then facial nerve will run from here into the parotid.
Yes.
That is anterior trans. Once you do that, your jugular foramen is head-on accessible now. Nothing comes in between the surgeon and the jugular foramen, no critical structure. You can open the jugular foramen and do whatever you can. That is infratemporal fossa A approach. In case, see this, you are drilling the labyrinth here. If you have a lesion deep into the cochlear vestibule here, suppose, and the facial nerve is running right over it, you have to remove the tumor from the labyrinth, and below is the clivus. If you have to remove the tumor from the clivus below with the facial nerve running over it, what you can do?
Posteriorly.
Transpose the facial nerve posteriorly.
Posteriorly.
Now, how can you transpose it posteriorly?
Dr. Satish,
Cut the GSPN. See this GSPN here?
Yes, sir.
Cut the GSPN, elevate, expose the course of the facial nerve right to the intra-auditory meatus, elevate from the first genu after cutting the GSPN. First genu elevate, labyrinthine segment elevate, intra-auditory meatus segment elevate, and elevate in the stylomastoid foramen and push everything right on the jugular bulb, sigmoid sinus, and then you have uncovered everything in front of you. That is posterior transposition. And you can remove the lesion deep to it. Yes, boss.
Sorry for it.
Yeah, please.
When you're transposing, do you worry about the vasovascular and how
Yes,
does...
yes. That's a very important question from the master, Dr. Madhusudan. When we transpose, do we take away the vascularity? This is very important. Thus, yes, vascularity is compromised. That's why after anterior or posterior transposition, any transposition, there is facial paresis which is imminent, not complete paralysis. Now, how the vascularity is taken off? This facial nerve has a unique blood supply than any other nerve in the body.
Yes, sir.
Unique means, see how it is supplied by. The facial nerve is supplied by artery entering into the stylomastoid foramen from below. That is either a branch of occipital or the posterior auricular.
Yes, sir.
Okay? One artery enters the stylomastoid foramen from below, and one vessel enters at the first genu here.
Descending
Here, see at the
petrosal
first
artery.
genu.
Descending
This vessel.
petrosal artery.
This vessel is the descending petrosal artery.
Yes.
It's a branch of middle meningeal.
Middle main.
One vessel comes from the first genu, one from the stylomastoid foramen, and they join together and make an arcade of plexus around the periosteum of the facial nerve.
In between the epineurium,
You take away the blood supply. No, the blood supply goes off.
Yes.
So some of the blood supply remains from above, some from below, but that anastomosis goes off. And that's why, in spite of keeping the nerve completely intact, by anterior posterior transposition, facial paresis grade 2, 3 is imminent. So it improves over the period of time. Once we transpose in the parotid bed, it acquires vascularity again.
Yes.
So it may not be completely normal, but to grade 2, I have seen many such patients in the long term coming to grade 2. This is acceptable. But it gives an opportunity to dissect deeper areas after transposing. You know, so the posterior transposition is seen in transcochlear approaches. I will describe later, I will show. And the anterior transposition is in infratemporal fossa. Similarly, the carotid artery. This carotid artery, deep to the carotid is the petrous apex and the clivus. See this? The horizontal carotid going anteriorly. And many a times we have paragangliomas going deep to it. And by infratemporal fossa B approach, wherein you completely skeletonize the carotid right up to the foramen lacerum, you can, and in the neck, you can elevate completely and push anteriorly. And once you push anteriorly, you can drill away everything, you know, easily and remove the tumor from the clivus and the petrous apex. That is transposition of the carotid artery. So now, with the advancement in the surgical technique, you know, all deeper areas are accessible. See the carotid canal. See, here is the cochlea. And cochlea and carotid canal have a common partition. Sometimes it's very thin and sometimes the partition is deficient. So even the implant you are pushing in the cochlea, if the partition is deficient and if you are not aware on CT scan, one can push the implant in the carotid canal, and this has happened and published. So that's a disaster if that happens. because you cannot then dare to pull the implant. It can lacerate the carotid. If it has happened, leave it and forget it and, switch off the implant. This will not harm.
Okay.
Pulling the electrode, because that is a metal, can lacerate the carotid. So you have to be careful. If the partition is deficient, you have to be careful and implant accordingly. You can take a fluoroscopic guidance in that situation if the implant is going under the C arm, if it is going in the canal or not, or going in the cochlea, rotating in the cochlea. Okay? So that's about the facial now.
Satish,
Now,
just one question, sir.
Yes,
Hello.
please.
Yeah, what is your approach to decompress the labyrinthine segment only, sir? In case you have a Bell's palsy which is not recovering,
Yeah.
only
Yeah. See, I'm
labyrinth. How do
elevating the
you
facial.
approach it, sir?
Yeah. See, in Bell's palsy, again, a very controversial subject, but yes, there's a right time to answer this. Bell's palsy is what? A viral palsy, idiopathic. And the nerve becomes edematous at the labyrinthine segment, which is the narrowest, and get compressed in the bony canal. It cannot expand. So, most of the time you give steroid or it resolves on its own. So, when to do the decompression and what technique? This is a big question. Majority of the times, in our clinical practice, 98 to 99% of the time, nothing is required to be done. It resolves. How to predict the facial nerve which is not recovering and when to do a decompression and what kind of? So what we do in all Bell's palsy patient, our protocol, even if it is resolving, do
Electromyography.
a electroneuronography after 5-6 days at the end of the week to see the neuronal responses, how much it has gone, 90%, whatever. Then after 2 to 3 weeks, electroneuronography to see how much neurons are not responding and compare with the opposite side. 3 weeks not responding, again wait and get an EMG. EMG is something which predicts recovery. At the end of the 3 weeks, facial palsy not recovering, EMG is showing fasciculations. That means facial nerve is recovering. You don't need to do anything. This was a big study from the grants. It was a surgeon grants from the Italy who published in the JLO, was the biggest the super hit paper in the JLO long back in 2000. Gantz studies. So after 3 weeks, if your EMG is silent, electroneuronography showing complete palsy, EMG is silent, that is the indication for Bell's palsy. And what he studied in his study, those group of patients, after 3 weeks, where the EMG is silent, EMG is no response, he divided into 2 categories. One did nothing and followed for 6 months or whatever. Another category, he did a middle fossa decompression of the labyrinthine segment and followed for 6 weeks and was amazing difference in the decompressed patients with much, much better results. So that came and opened up eyes for everybody to selectively decompress only those patients after 3 weeks of complete palsy. If ENG no response, EMG no response. And that is selected less than 1% group of patients requires a decompression. And if it is, then you have to choose whether transmastoid or middle fossa. Transmastoid doesn't allow you to access the entire, labyrinthine segment because the semicircular canal is there too. If you try to drill, you will hit semicircular canal, superior canal, and give a complete loss. Then another approach, transzygomatic, Dr. Morwani, Dr. Madhuri Mehta described, to come from anteriorly. See this, what I'm saying. If I go and see, this is the labyrinthine segment. See this. If I go and keep drilling this to open the labyrinthine segment, I may end up hitting the superior or the lateral canal. Superior canal. So what they described, come from anteriorly to the zygomatic arch, and rather than going over the semicircular canal, come from anteriorly and drill open the labyrinthine segment if there is a space. So generally it doesn't give adequate space to decompress entire labyrinthine segment. So we go from the middle fossa side. I will show you later the middle fossa approach to the labyrinthine segment, and you can decompress well, preserving everything. That is a pure extradural approach, no intradural approach. And that is an amazing approach, for such lesions, for decompressing the labyrinthine segment.
So you do often, sir, middle fossa, this decompression in such cases?
Yes, yes, in cases, very limited cases. Now, so that answers the bells. I hope it is clear.
Yes, sir. Thank you, sir.
Now, somebody asked about the lesser superficial petrosal nerve. This is my facial nerve, which I have elevated off the fallopian canal. Can you see the fallopian canal? See this periosteal blood supply. See this periosteal blood supply, which is taken off after the decompression. Can you see this?
Yes.
Yeah.
See, even the capillaries are injected. The injection is done so well. Deepak sir, who has done this injection? Who? See from the facial now. Can you see this tendon, this muscle?
Yes.
This is stapedius.
Yes, sir.
This is going through this
Yeah.
Pyramid.
eminence, pyramidal
Pyramidal
eminence, and
eminence.
this is the stapes there. Okay?
Yeah.
Yeah.
Yes, sir. Yes.
And this is the entire fallopian canal. Now, another question asked to me was the lesser superficial petrosal now.
Yeah.
Can you see something?
Yes, sir.
See, I have elevated the processus cochleariformis.
Yeah.
See this tympanic nerve.
Yeah.
This nerve goes deep to the processus cochleariformis.
Yeah. Yes, sir.
And this nerve further joined two more twigs. As it goes anterior, see it is going anteriorly here.
Yeah.
Very slender nerve, this one. Can you see?
Yeah. Yeah.
This nerve here.
Yes, sir.
Here at the first genu, it receives a twig from the facial nerve.
Yeah.
Yeah.
Okay? And another twig it receives from the 10th nerve. Where does the 10th nerve come? Vagus nerve.
Vegas.
Vagus nerve gives a branch at the jugular foramen level. This is Arnold's nerve from the lateral part of the jugular foramen. That nerve runs in the posterior canal wall and it gives a twig into the facial nerve at the second genu.
Yeah.
Yeah.
That twig runs in the fallopian canal outside the facial nerve sheath. Remember,
Okay.
runs in the fallopian canal outside the facial nerve sheath.
Yes, sir.
And here all the way it goes to the first genu and then it comes out and joins the Jacobson's nerve. So Jacobson's nerve is joined by two nerves, one twig from the facial and one from the 10th nerve by the Arnold's nerve. And Jacobson's nerve carries fiber from the 9th nerve. So 7, 9, 10 together form the lesser superficial petrosal nerve.
GSP.
So this is the greater one. The greater one going anteriorly. See this?
Yeah.
There. And the lesser one immediately below that anteriorly. And it joins the otic ganglion. Otic ganglion is where I will show you where the mandibular nerve comes out of the foramen ovale. Immediately below is the otic ganglion. And from there it joins the fibers in the auricular temporal nerve to supply the parotid. So this is how the course of the lesser superficial petrosal nerve is. So greater superficial petrosal nerve supplies the
Lacrimal.
And the lesser superficial supplies the parotid.
Parotid.
And these now comes out of the attic in the medial wall of the attic anteriorly into the space outside the temporal bone. Okay?
Yeah.
One more nerve here. See, we saw the chorda tympani above, which runs medial to the incus or lateral to the malleus here. This is the chorda tympani.
Yes, sir.
This is the chorda tympani.
Yeah.
This chorda runs here anteriorly. This is the fissure.
Yes, sir.
The anterior vertic Glaserian fissure.
Yes, sir.
In the medial part of the fissure, this nerve passes out of the temporal bone here to the canal of Goussier.
Yes, sir.
Yeah.
And comes medial to the TM joint. Once I remove the TM joint, I will show the chorda tympani there.
Yes, sir.
Comes out and then go vertically down and joins the lingual nerve in the infratemporal fossa.
Yeah.
So all these nerves are important as they supply all salivary glands.
Yes.
The chorda tympani supply the submandibular and the sublingual gland. And this GSPN supply the lacrimal and the nasopalatine gland. And the lesser palatine supply the parotid gland. See, these are very, very important. I will show you one anatomy there. Once this chorda tympani comes out here, it runs over the spine of sphenoid. And this GSPN LSPN is close proximity to the spine of sphenoid. Chorda and LSPN lesser superficial petrogenic run very close to each other in relationship to the spinal sphenoid. In fractures of the sphenoid in trauma, when the spine is fractured, all ipsilateral salivary paralysis. The LSPN supplying parotid and the chorda supplying the submandibular and the submaxillary. In the ipsilateral complete salivary paralysis because this nerve pass here close to the structure of the sphenoid spine, which is frequently fractured in trauma. So all these are important clinically. Now see, having seen this anatomy, this is the facial nerve which I have elevated.
Hello.
Why I have elevated facial now? So that we can go deep to the facial now. What you see deep to the facial nerve now? Labyrinthine block. Labyrinth consists of what? The cochlea anteriorly.
Yes, sir.
And the vestibule and the semicircular canals behind.
Yes.
Okay.
Hello,
Now,
Dr. Satish.
let me uncover medium size the cutting. Let me uncover the cochlea and vestibule together and see the inside anatomy of the cochlea and vestibule so that lot of inner ear procedures can be carried out much better if you understand this anatomy.
Hello, Dr. Satish.
Yes, sir.
Dr. Arshad here.
Yes, Arshad.
Yeah. Can you please explain why there will be no taste disturbances in some people despite cutting the chorda?
No taste disturbance.
No taste disturbance.
No taste disturbance.
Taste.
See, most of the time, when you cut the chorda in chronic suppurative otitis media cases, it doesn't give, like canal down, you always damage. Doesn't give taste disturbance because of the chronic inflammation, the neuritis happens in the chorda, and the function of the nerve supply to the anterior two-thirds of the tongue is taken over by the other nerves, the opposite side or posterior nerves. In sudden transaction of the, healthy nerve, like in stapes, most of the time it gives symptoms. But most of the time, it recovers because of the surrounding nerve, the posterior glossopharyngeal or the opposite side chorda. Most of the time it is taken over. So in long run, it doesn't last. The test change doesn't last in long run, but initially it bothers the patient. Yes. Now see.
Sir, can you show the Trotman's triangle? Sir, what is Trotman's triangle and its significance?
Trotman's triangle. Okay.
And significance.
And?
Its significance, anatomical.
Okay. See now, let me show you the labyrinthine block and then show you the Trotman's triangle and the significance.
Yes.
So, see this. This is the lateral canal. You can see?
Yes, sir.
Yes.
Sir,
Let me skeletonize all the canals. They are
Yes,
all
sir.
perpendicular to each other.
Yes,
You don't
sir.
see the vestibule. Vestibule is a deeper anatomy. Okay?
Yeah. Yes, sir.
So now I had shown all the canals as relationship with the different parts of the facial now.
Yeah.
The most lateral is the lateral. That's why it is known lateral.
Yes, sir.
Then below is the posterior canal, the most dependent canal.
Yeah.
This is the vertical course of the facial nerve here, fallopian canal.
Yes, sir.
And the posterior canal is deep to the vertical portion of the facial nerve, a deeper anatomy.
Yes, sir.
And it is a very, very important relationship with many things. I will come.
Yeah.
I missed the point, Aljos.
Sir,
This is the posterior canal coming in picture.
yes, sir. Yes, we can see the glimpse of posterior semester.
This is ivory white bone. See my direction of my drilling.
Yes, sir. Yes.
That is the direction of posterior canal. This is the posterior canal now.
Yeah.
Thick bone. I will open up the ampullary end and show you. This
Going
is posterior canal. This
medial
is
to
lateral canal. Okay.
Yes, sir. Yeah.
And this posterior canal is immediately deep to the facial now.
Facial. Yes,
Close
sir.
to the. Now here, close above all these is the superior canal.
Yeah.
See this ivory white bone coming?
Yes, sir.
This is the superior canal.
Yeah.
And this is the blue lining as well.
Yeah.
Can you see the superior canal?
Yes, sir. Yes.
Actually, in the superior canal dehiscence, where exactly will be the dehiscence, Dr. Satish?
Yeah, so superior canal dehiscent is one subject which is, we have to be very cautious. This is not uncommon. The only issue is, the diagnosis doesn't come to our mind frequently. The regions we don't frequently get the CT scan done. And secondly, the symptomatology is overlapping to other pathologies.
Yeah.
superior canal dehiscence is not uncommon. See what happens normally. Normally, what happens? This superior canal this superior canal gives the impression in the middle fossa floor
Yeah,
at the
yeah.
arcuate eminence.
Yes, sir.
And it is covered by the thick bone.
Yeah.
So pulsations of the bone are not appreciated to the canal. Now what happens? Our inner ear block is a thick bone which has only two avenues for the pressure change. One is oval window, one is round window. There is no third window.
Correct.
Got my point? The
Yeah.
sound reaches preferentially through the ossicular chain to the oval window, and the oval window goes in. See, this step is, this goes in and the round window comes out.
Yeah.
That is what the baffle effect. And this is a closed system, so perineum moves and we hear. Now, if there is a third window, what will happen? The sound reaching to the oval window will not mobilize the round window. Sound will leak to the third window.
Yeah.
So that will give a conductive loss. Because of the inner ear window, yet giving conductive hearing loss. The only inner ear disorder which gives conductive hearing loss. The third window. Now this third window can be anywhere. Will give the same problem. If there is a window, cochleocarotid fistula, the sound will leak there. That is third window. The commonest third window is at the superior semicircular canal. So if the superior canal fistula is there, sound coming to the whole window will leak through the third window and will not efficiently give a baffle effect for a perilimb to move and will give a low frequency conductive hearing loss. Now, depending upon the site and size of the fistula are the symptomatology. If superior canal close to the ampullary end as a fistula will present predominantly as vertigo, vestibular symptoms. If the fistula is close to the non-ampullary end, will predominantly present as this auditory symptoms. And in that situation, the hearing becomes hyperacute. Patient, even if you put a tuning fork here on the lateral malleolus, he will hear here. The bone conduction becomes more sensitive in minus. Much better bone conduction than normal. The hearing at the bony, cochlear septum becomes more sensitive. So, there are various ways to, predict
Sir,
this pathology. Symptomatology by auditory or vestibular symptoms.
What is
Yes.
the reason for
That's normal.
autophonia, sir? What is the reason for autophonia? Autophonia. What is the reason for autophonia?
What is the?
Autophonia. Reason for autophonia in third window lesions. Autophonia, sir.
Autophonia.
Yes, I am talking of superior canal dehiscence. It has nothing to do with otoconia.
Autophonia.
Autophony. Because the patient become more sensitive to bone conduction hearing. So he starts hearing his own voice.
Yes, sir.
That is one of the symptomatology. So the symptomatology presentation is so varied. Sometimes autophony happens because of Eustachian tube blockage.
Yes.
Who will predict the semicircular canal fistula? Who will order the CT scan? Because the final diagnosis can be based only on CT scan to see a clear fistula. The canal is not completely covered above, and it is in, the dural pulsation can be transmitted to the canal.
What is the size of the cut section you prefer to see
0.5 mm.
0.5 mm. So that you don't miss anything. 0.5 mm sections. So if there is a third window disorder, you have to repair it, seal it so it doesn't give any problem. Now what happens? We have seen two patients. Patient had a third window, superior canal fistula, no symptomatology, conductive hearing loss. Hand had associated ossicular fixation, stapedial fixation. Classical otosclerotic picture. And we did a stepidotomy and patient became symptomatic. So only that time, only two windows were working. One with the fistula, one was the down window, and we created a third window. So CT scan is mandatory, what we believe. If you really want to prevent surprises, if you really want to prevent cutting sorry figure, before stapes surgery, we must do a CT scan. This is our philosophy. We have so many times, found so many surprise diagnosis, inner ear disorders. So in such situation, if you are not aware of it and you make a third window and patient becomes symptomatic. and then it is difficult to control. Then you need another surgery to
Sir,
seal the
we
third
can do
window.
stapedial reflex, sir. You can
Huh?
do stapedial. We can do stapedial reflex. If it is
Stapedial
present, that
reflex is not that sensitive. The
Sir.
only thing, yes,
Clear,
in
bro.
third window disorders,
Yes, sir.
stapedial reflex will not be absent. Number one.
Yes.
There are many ways to predict.
Yes.
Clinically also you can predict many times. You do a vamp. Vestibular evac myogenic potential becomes oversensitive because it tests the saccule, which becomes oversensitive. So vamp is quite diagnostic for the third window disorder. So here you were talking about the semicircular canal fistula. So what I have done here now, I have skeletonized all the three canals. Can you see?
Yes, sir.
Yes.
Now these canals open in the vestibule in the medial wall.
Yeah.
See, this is the labyrinthine block. Can you see very clear?
Yes, sir. Very well.
Now, between the labyrinthine block, this is the tegmen above.
Yeah.
Dura behind.
Yes,
The
sir.
sigmoid sinus behind labyrinthine block.
Yeah.
Anteriorly and in between. What is this?
That is sinodural angle, sir.
What is this triangle?
Trotman's triangle.
Why it is important? This is the area where if you go medially, you can go right into the cerebellum.
Yes, sir.
Earlier people used to, drain the cerebellar abscess to the Trotman's triangle.
Yeah.
Transmastoid drainage of the
cerebellar abscess.
cerebellar abscess. This is Trotman triangle.
Yes,
What
sir.
I am doing, I am accentrating these cells to uncover the pre-sigmoid
Yes, sir.
pre-sigmoid plate. See this pre-sigmoid plate.
Yeah.
Is this pre-sigmoid bone?
Yes, sir. Yes.
If I drill, I will be right at the CP angle.
Yeah.
See all these cells. So this is one of the most direct pathway to the
CP angles. Huh?
CP angle. Now, before drilling the semicircular canal,
Yeah.
some more important things to discuss here. See the
Sir.
pre-sigmoid plate. This is Trotman triangle.
Yes, sir.
Whoever has asked, this is Trotman triangle.
Yes, sir.
Between the labyrinthine block anteriorly,
Yeah.
tegmen superiorly, and the sigmoid sinus behind. And if I drill this, I'll be right into the CP angle.
Yes.
Okay.
Sir. Yeah.
Now, this
Sir,
is
if you
the
have time, you please show the Donaldson line and tell the treatment of Meniere disease.
okay. I will come to it. Definitely, I'll remember. Remind me again. Once I drill the semicircular canal, I will show you the Donaldson line and the SEC. And then we'll discuss the management of Meniere disease. That's a very important pathology, common pathology in our practice. Now, before going to the labyrinthine block, one more, procedure. See, here is the facial nerve above. Can you see?
Yes, sir. Yeah.
Here is the posterior semicircular canal till here.
Yeah. Yeah.
And below is the jugular bulb.
Yes, sir.
And the medial wall is the pre-sigmoid dura. See this again here.
Yes.
In
Sir.
between these limits, all four limits,
Yeah. Yeah.
my lateral limit is facial nerve. See this?
Anterior limits.
Medial limit is pre-sigmoid dura.
Yes, sir.
Superior limit is what?
Posterior semicircular canal.
This is posterior semicircular canal, and inferior limit here, the
Is a
jugular
canal.
bulb.
Yes, sir.
What I am accessing?
That is infra
This is
labyrinthine.
retrofacial axis.
Yes, sir.
See this?
Yes, sir. Is it same as
Depending upon the status of the jugular bulb, the size of the space is defined.
Yes, sir.
If the jugular bulb is high, the retrofacial space is narrow.
Yes, sir.
See, the jugular bulb is coming right over there.
Yes. Is it the same as infralabyrinthine approach to petrous apex?
Yeah,
sir?
that will be infralabyrinthine. See, this was infracochlear.
Yes, sir. Yes.
If we reach to the petrous apex from here,
Yeah.
that will be infralabyrinthine. Same.
Yes, sir.
That's the basic difference.
Yes.
Because here, you're going below the labyrinthine block.
Yeah.
Now, see, let me skeletonize. If I get any retrofacial space,
Yeah.
I cannot afford to damage the posterior canal, otherwise we'll lose the hearing.
Yes, sir. Yes.
You cannot afford to damage the jugular bulb, it's a disaster.
Yeah.
You cannot afford to damage the facial nerve above.
Yes, sir.
Laterally. That's
Yeah.
a disaster.
Yeah.
So whatever space between all these limits,
Yes,
if
sir.
you reach into the middle ear through that, is the retrofacial axis. Sometimes it is too, pneumatized. See the jugular bulb coming.
Yes, sir. Yes.
See high jugular bulb. Can you see this? This is jugular bulb.
Yes, sir. Yes.
This is high jugular. I told you, somebody asked about the definition of the high jugular bulb.
Yeah.
See, this jugular bulb is reaching almost to the level of the posterior canal. Can you see?
Yes, sir. Yes.
This is high jugular bulb. And see, this is jugular bulb here, jugular bulb here. And in the middle, it is crossed by the facial nerve.
Yes, sir. Yes.
See this?
Yes, sir. Yes, sir.
So this is the jugular bulb. And retrofacial axis in this patient is very, very narrow if it is.
Is it a dominant jugular bulb, sir?
Pardon?
Dominant.
Yeah, jugular bulb is prominent. Yeah, this is right side dominant.
Yeah, yeah.
And it is high as well.
Yes, sir.
Normally, this is not so high. And if you do a translabyrinthine procedure in this patient, you know, from superior to inferior, this axis is narrow.
Yes, sir. Yes.
My intra-aortic canal is here.
Yeah.
And this axis is narrow. So in order to carry out the translab excision of the vestibular schwannoma, what you need to do is, I told you to the technique to push this down with the bone wax or surgical. More skeletonize, remove that bone and more, keep on pushing.
Sir, can
That
we
is-
cauterize the surface, sir?
No, jugular bulb has no periosteum.
Okay.
Don't dare to do. You can do on the sigmoid sinus. It has a periosteum.
Yeah, yeah.
But you cannot afford to do that on the jugular bulb.
Okay.
Cautery will
Jugular
cause
bulb
tear
devoid
off.
of periosteum. One
Yes, sir.
can puncture and it bleeds like anything. See this, how high the jugular bulb is.
Yes, sir. Yes.
So jugular bulb means it is a dominant jugular vein. That's what it means.
Right side is considered dominant.
Dominant.
Most of the time because it is a continuation of right transverse sinus.
Yes, sir.
Right side transverse sinus continues as a right sigmoid sinus and jugular bulb.
Yeah.
Left side, the transverse sinus doesn't continue as a jugular bulb. Right side, the great cerebral vein and the straight sinus form the
Okay.
left sigmoid sinus, not the transverse sinus, direct continuation. So right side is most of the time it is dominant. See my entry into the middle ear.
You're going
this?
medial to the facial nerve, sir.
This entry should be below the
Facial nerve.
facial nerve. See
Yes,
this?
sir. Yes, sir. Yes, sir. Yes.
In this, you should not damage the posterior canal, you should not damage the jugular bulb, you should not damage the
Yes, sir.
facial, fallopian canal, facial nerve. Okay?
It is same
So
as,
now,
sir,
pardon?
it is same as retrofacial tympanotomy, sir.
Yeah, this is retrofacial.
Yes, sir. Yes.
And what is the
By means
indication
of
for this?
By means of this, you can remove the disease from the retrotympanum.
Yeah.
This is retrotympanum here. Sometimes you have a sinus tympani cholesteatoma. This is additional avenue to remove that from the sinus tympani. Now, cochlea, three semicircular canal, but we don't see the vestibule. Vestibule is deeper.
Yeah.
Vestibule is deeper and the lateral wall of the vestibule is formed by fallopian canal.
Yes.
That's why I remove the facial nerve from here so that we can go to the vestibule deeper.
Yes, sir. Yes.
Vestibule on one side with three semicircular canal and cochlea on the other side, they constitute the labyrinth. Now, these vestibule has 8 openings. Those are important to understand because connections of the vestibule are important to understand the inner ear anatomy. So this lateral canal, see, I am opening.
Yes, sir.
I am opening the lateral canal. It opens through 2 openings into the vestibule.
Yes, sir.
2 separate openings into the vestibule. It opens deeper down.
Yes, sir. We can also see the...
See the...
Yes.
See the ampullary end of the lateral canal? Hello?
Hello, sir. Yes, sir. Yes.
This is the ampullary end of the lateral canal
Yeah,
opening in the superior wall, and this is the non-ampullary end. See here, opening in the posterior wall of the vestibule here. And
Yes,
this is
sir.
opening in the superior wall. Okay?
Yes.
2 separate openings. 3 canals, they open in the vestibule by means of 5 openings. So lateral canal by 2 openings.
Yeah.
Ampullary end of superior and ampullary end of the posterior, they each open by separate opening, 4 openings. Non-ampullary end of the posterior and superior join together to form the crus commune and make single opening. So 5 openings of the vestibule. 6th opening of the vestibule is this oval window.
Yes.
See this? 7 and 8 I will show inside. So 1, 2, this is the 3rd opening. The see, close to the ampullary end of the lateral canal is the ampullary end of superior canal. See that?
Yes, sir.
3rd opening. This is the posterior canal. See this?
Yeah, yeah.
Let me show you the ampullary end of the posterior canal. See that?
Yeah.
See that?
Posterior semicircular canal.
Yes. See the
Ampullary ends.
See this?
Yeah.
This is the ampullary end of the posterior canal.
Yeah.
This one going. And this is the non-ampullary end going behind. See this?
Yeah.
Ampullary end of the superior canal and the non-ampullary is going behind.
Yeah.
Now, see 1, 1 and 1. All canals are perpendicular to each other.
Yes, sir.
That's the beauty. See that?
Yes, sir. Yes.
Now, what is hidden still is the non-ampullary end of superior canal and non-ampullary end of posterior canal. See this?
Yes, sir.
So let me follow the non-ampullary end of posterior canal. See such a thick bone.
Yes, sir.
Strongest bone in the body is the petrous part of the temporal bone, forming the labyrinth. That is the strongest bone in the body. See this non-ampullary and I am following behind. Can you see?
Satish, sir.
Yes, please.
Through that, we can also see the membranous structures within the semicircular canal, I think. That is ampullary.
See the
membranous structure that in the ampullary end of the lateral semicircular canal. That is a part of semicircular duct, I think.
Yeah, see this here.
Yeah, yeah.
The membrane.
Yes, sir. Yes.
That is the specialized, sensory membrane.
Yes, sir.
Now, this is the non-ampullary end I am following.
Yes, sir.
The ampullary end is going there.
Yeah.
And non-ampullary end I am following here.
Yeah.
Which is going, see here, non-ampullary end. See this going there?
Yes, sir. Towards
and this is going to join the non-ampullary end of the
posterior semicircular canal.
Superior canal. Find out. See this. So again, a question from Dr. Kamaraswamy. The approach for the superior canal dehiscence. The straightforward approach in the middle fossa. Just raise the dura from above. You will find the fistula, cover with the bone dust and fascia and come out. That's it. So simple. See this?
Yes, sir. Yes.
The non-ampullary end. I am see how these two non-ampullary ends join each other in the depth. The very, very thick bone. Huh? It doesn't allow to give you effective work, Transmastoid approach is doesn't give that much of clear exposure. See this non-ampullary end of the canal coming down?
Yes, yeah.
And they join together.
Dr. Satish,
yes,
in your hospital, who will do the middle cranial fossa approach, ENTs or neurosurgeons?
What?
in your setup, who is going to do the middle cranial approach, middle cranial
We
foot
do
approach?
on our own. The neurosurgeon is on our team, so he's always there.
Yeah.
But we do on our own. Ours is a teamwork.
Okay.
Sometimes he does extracranial work, I do intracranial work. So it's like
Okay.
ours is a teamwork, so that we'll learn from each other.
Yeah.
He he loves the extracranial work, I love the intracranial work.
Very good.
Reverse. So when he's doing extracranial, I assist him. When I do intracranial work, he assists me. See now, this is crus commune.
Yes, yes.
Can you see?
Yes.
This is crus commune. This is opening into the vestibule here. So 1, 2, 3, 4, and 5 openings. Okay. So let me remove this labyrinthine block now to see the vestibule below.
So before that, can you show the endolymphatic sac?
That will come later.
Okay.
That is still in the depth of this. All this is the deeper anatomy. I will show that. The 7th opening of the vestibule is the opening of the vestibular aqueduct, opening of the endolymphatic duct. Okay. 6, 5 are this. 6th is the whole window. 7th is endolymphatic duct. Now see, fallopian canal, I told you, is the lateral anatomy of the vestibule. Now I'm destroying. I'm uncovering the vestibule in no time, and vestibule is a huge cavity. See this vestibule below. Can you see?
Yes, sir.
See this big cavity inside.
Yes.
Now see, the vestibule contains utricle and saccule. These 5 openings, they join the utricle. See now, this is the oval window here. See, still there is a foot plate here. Let me show you. See, this is the oval window. Can you see?
Yeah, yeah.
The foot plate forms the lateral wall of the vestibule. I am removing. See this? See the big cavity in the depth. This is vestibule. This is cochlea. All this is the superior canal opening into it. The posterior canal from here, crus coming from here. Lateral canal was opening from here. So all the 5 openings, I am uncovering the vestibule now. See such a big cavity in the depth. Can you see?
Yes, yes, sir.
See, that was the oval window here. I removed, if you remember, just now. The oval window was here.
Yeah.
When we put a piston in the oval window, there is always a discussion where to put the piston.
Piston, yeah.
The reason being, how far you are from the structures, the membranous labyrinth in the medial wall. See in the medial wall carefully. This is a spherical recess anteriorly.
Yeah.
See this rounded?
Yeah.
Spherical recess containing the saccule. And this is the elliptical recess all the way behind.
Utricle.
This is utricle. All the semicircular canals open in the utricle. Okay?
Yeah.
This saccule, the oval window was here. Anteriorly, the medial wall of the saccule is very close. We never advocate the piston
To be
inserting
anterior.
anteriorly.
It's post one
So
third.
we advocate the piston in the central part here, and that too inferiorly. That is away from the saccule and the utricle structure altogether. The farthest area of the medial surface of the whole window to the medial surface of the vestibule is in the central part inferiorly. And that is the preferred site for fenestration here. Okay?
Yeah.
No, posteriorly. Posteriorly, I will show you this cochlear basal turn. This basal turn gives the elevation here posteriorly. So never try to go inferiorly, posteriorly, otherwise you'll keep on end up hitting the basal turn of the cochlea. and complete loss. So central part is the safest one. Okay.
Okay.
Now, more drilling of the, this thing to completely uncover the vestibule. Now I am removing this bridge to show you the crus commune. See the three openings is still to communicate. This is a non-ampullary end of the lateral canal. See this?
Yes.
This is the crus commune and this is the ampullary end of the posterior canal. See? All three are opening in the utricular vestibule. So now, one by one. See how hard bone it is. In the translabyrinthine approach, this drilling of this bone is required. See now?
Yeah.
See this? This is the tunnel. This is the tunnel. This is the opening of the, see this?
Yeah, crus
Crus
commune.
commune. And here is the posterior canal which is opening there.
Yeah.
See this bridge?
Yeah.
And now I'm uncovering the posterior canal opening in the posterior part of the floor of the vestibule. See now?
Yeah.
Both the openings again. See, this is the bridge. This is the crus
Crus
commune.
commune. Yeah.
And this is the posterior canal which is coming. See this?
Correct.
Posterior canal draining. And see how big the vestibule is. See this?
Yeah. So now we are seeing the medial wall of the bony vestibule.
Yes, full.
That corresponds to the lateral wall of the intra-auditory
Yes.
meatus.
But very thick.
Yes, because the intra-auditory meatus is medial to it.
So what size is the burr bit you are using, Satish?
This is
3 mm?
3 mm. Now see, we have seen 5 plus 6 lateral opening of the this thing oval window and 5 opening 6. Now where is the 7th opening? See in the medial wall.
Yeah.
See in the medial wall, this opening. See this?
Yeah.
This is so thin where you barely can pass a hair. See this?
Yeah, is the
This
vestibular
is
aqueduct?
the inner opening of the
Vestibular
vestibular aqueduct,
aqueduct.
endolymphatic duct.
Yeah.
You were asking about the endolymphatic system.
Yeah.
So that is the inner opening of the endolymphatic duct. Let me drill to show you the endolymphatic duct thoroughly. It is a J-shaped duct. Starts from the medial wall of the vestibule, whitish duct,
And goes below the Donaldson's line.
then it takes a lateral turn. See this inferior turn of the opening. See this. This opening. This is the endolymphatic duct starting.
Yeah.
Was going behind and then going down. And here at the petrous edge behind will form the sac. So now Donaldson line, somebody was asking. Here was the lateral canal. Here was the lateral canal.
Yeah.
Draw a line in the plane of the lateral canal. Here was the posterior canal. here like this.
Correct.
This?
Yeah.
Draw a
Perpendicular.
line from the plane of the lateral canal bisecting the posterior canal. Where the line bisect, okay? Just below that is the endolymphatic sac.
Yeah.
That is Donaldson line. Okay?
Correct.
So now, let me show you the sac proper. Forget the lines. See the endolymphatic duct.
Yeah.
Can you see the duct
It's very,
coming from the
very,
vestibule?
it's very clear.
Very good.
Very clear.
Very
And
good.
see where it is going and giving what?
Yeah.
See, this is expanding here.
Yes.
Yeah.
This is expanding here. This is endolymphatic sac.
Sac.
This one.
Yeah. That the endolymphatic sac in the extradural space in the
Yeah.
posterior
And
fossa.
this is between two folds of the dura.
Double-layered dura.
Yeah. This is the space between two folds of the dura. See this?
Yeah.
See one fold I am elevating. See this?
Yes.
Yeah.
Can you see the space?
Yes. Yes.
Yes, you can see that lumen.
This is the space between two folds of the dura. This is endolymphatic
sac.
So the Donaldson line was like this, and where it crosses the posterior canal, the sac is always below here.
Below that. Yeah.
Okay? And this is the entire endolymphatic duct. This contains endolymph. The cochlear aqueduct contains perilymph.
Yes.
And this vestibular aqueduct contains endolymph.
Endolymph.
Okay? So this is the canal in the medial wall of the vestibule. So you have seen 5 openings, 6th opening and 7th was the oval window. And see the vestibule in front of you. I hope it is clear so far.
Yeah,
See
it's
how
clear.
deep anatomy, vestibule, high deep anatomy. Deep to the semicircular canals is the vestibule. I hope still you are oriented.
Yeah, we are oriented. Yes.
And I think cochlear aqueduct is also, I think, visible. Is it visible there, superior to the jugular bulb? Anterior.
Now, where is the 8th opening?
Cochlear aqueduct.
No.
Round
Cochlear
window.
aqueduct I have already shown in the round window. Where is the 8th opening of the vestibule? See this. See this. पतली दे यार. बहुत तेज काट रही. काटती तगड़ा है. Cutting से बढ़िया काटती है. Let me show you the 8th opening quickly. That is scala vestibuli emerging from the floor of the vestibule anteriorly. ये बड़ा यार. Now, let me show you the 8th opening. See now. See this with this angle. See this?
Yes, sir.
Can you show us with a probe?
Yes, sir.
See from this angle
Yeah.
something very important. Brother. Patla. This was the round window we had seen earlier.
Yeah.
This opening from behind we made was the round window. See that tunnel?
Yeah.
Now from the floor of the vestibule anteriorly another opening.
Floor of the vestibule anterior. Okay. Oh, that is.
That is, can you see the narrow opening?
Yeah, scala vestibuli. Scala vestibuli.
This is scala tympani and this is scala.
Vestibuli.
Can you see both the openings?
Yes, yes, both are clear. Yeah.
Yes.
Now again, remember the diagram I made.
Yes.
See, here is the modulus. Here is the modulus.
Yeah.
In this
Scala
tunnel,
cochlea.
this tunnel which is around the modulus has 3 compartments.
Yes.
From the modulus, this bony spiral lamella is emerging. See this?
Yes.
Yeah.
And going towards the lateral wall. See this lamella?
Yes.
Yeah.
Can you see this lamella?
We can see that. We can see that.
And before the lateral wall, it ends and this membrane starts.
Yeah.
See this membrane?
Yes.
See this membrane? See, this is the osseous spiral lamella below.
Yes.
And these are 2 membranes. The below is the basilar one and
Above
above the
the
Reisner's. And in between these 2 is the scala.
Scala media. Media. Yeah.
Very clear?
Yes, sir.
Very small, narrow space. See, close
Yes.
to the promontory. This is promontory.
Yes.
So the inferior one, bigger tunnel is scala tympani.
Hello.
Yes. The upper one, narrow is the
Vestibule.
scala vestibuli. This
Media.
is osseous spiral lamella emerging from the modulus, going towards the lateral wall, ends before and two membranes attached. This is enclosing the scala media.
Having endolymph.
See this?
Satish,
That is
in
scala media.
in Meniere's disease,
Yes.
yeah. So that bulges superiorly, is it?
What is that?
Hello.
In Meniere's disease is an endolymphatic hydrops. The pressure inside the endolymphatic system increases, you know,
Yeah.
and there are various treatments proposed for the Meniere's disease. Basically, vestibular stimulation is the cause of vertigo. Okay.
Yeah.
So vestibular overstimulation because of the distended endolymphatic space is the reason for vertigo.
Correct.
So there are many treatments proposed for the Meniere's disease. Somebody asked about the Meniere's disease treatment. You know? So the simplest treatment nowadays, see, it is vestibular overactivity. So vestibular deafferentiation is the best answer.
Vestibular?
No more deafferentiation. No more vestibular afferent stimulation reaching to the brain to give vertigo. Deafferentiation.
Okay.
Afferentiation. So what you can do, you can simply inject the gentamicin. Gentamicin is vestibulotoxic to the vestibular end organs. Selectively vestibulotoxic, though it has a, ototoxicity as well.
Yeah.
But less, but selectively vestibulo-ototoxic. And intratympanic gentamicin reaching to the vestibular end organs damages.
Okay.
Our practice is to give couple of injections of gentamicin. And the philosophy is to give, there is a protocol for gentamicin injection. 90% or more than 90% of the patient of, Meniere's disease can be managed with a proper gentamicin protocol. What is proper gentamicin protocol? We inject gentamicin once. We have, followed the studies of intratympanic gentamicin.
Okay.
Residing in the inner ear space, how long it resides.
Is it in all Meniere's or is it in only intractable Meniere's?
Intractable.
All Meniere's. See, the first line treatment is anti-vertigo drugs. That is, you never know what they are doing. You know, more of placebo.
Yeah.
If the patient is symptomatic, you have to do something.
Correct.
So, the gentamicin protocol, how we follow, is following certain studies. And the studies have shown that people have injected fluorescein level gentamicin. And fluorescein was detected in the inner ear space, fluorescein level gentamicin, up to 3 weeks.
Okay.
And then it washes out. Gentamicin, whatever ototoxicity it gives, is reversible. Irreversible. So our protocol is to inject gentamicin once, then wait till 3 weeks for the gentamicin to clear.
Okay.
At the end of the 3 weeks, we do audiogram. If there is any more than 10 decibel hearing loss,
okay,
at the end of 3 weeks, then you have to stop.
More
Stop
than 10 dB.
10 dB hearing loss means ototoxicity going on.
Okay.
And you can't afford to inject further.
Okay.
In patients already having dead ear with Meniere's disease, you don't have to
Then,
think twice.
Correct.
So second injection, if the hearing level doesn't drop, second injection is after 2-3 weeks.
Okay.
So most of the time, these 2 injections are sufficient to kill the vestibular system.
Okay.
Vestibular end organs.
Okay.
This is called chemical labyrinthectomy.
Okay.
So majority of the patients of the Meniere's can be managed with a chemical labyrinthectomy besides medical management. Now, those who are still facing intractable vertigo, there are many procedures in the basket.
Okay.
All depends upon the hearing level. We choose our target or choose our surgical procedure according to the hearing level.
Okay.
If hearing is good,
Huh.
still intractable vertigo,
Hmm.
vestibular nerectomy is the answer.
Okay.
Selective vestibular nerectomy by, retrosigmoid approach, MIRA, is the answer. I will show that.
Okay.
If the hearing is good,
Hmm.
another hearing preservation procedure which has gone to disrepute nowadays is the sac decompression.
Huh.
Distended sac pressed against the petrous bone, you decompress and it releases and the vertigo disappears, but it can come back.
Correct.
People have claimed that after the this sac decompression, even the hearing improves. Even the sensitive hearing loss improves and the decompression relieves. It has been claimed. I don't know.
Pressure, that is maybe because pressure on the
Pressure.
hair cells, yeah,
Yes.
decreases.
Yes.
Okay. Okay.
So some sort of reversibility has been claimed.
Same. Okay.
So, in our opinion, intractable vertigo with good hearing in spite of the gentamicin therapy,
Hmm. Hmm.
next answer is vestibular nerectomy.
Okay.
And
Okay.
those who have already lost the hearing,
Huh.
even gentamicin has not improved in
Improved.
spite of chemical labyrinthectomy,
Okay.
then surgical labyrinthectomy is the answer. The patient has already lost the hearing. Do the
Okay. Huh.
labyrinthectomy. What I did just now was labyrinthectomy.
Labyrinthectomy. Yes.
Remove the semicircular canal and vestibular end organ mucosa. It is labyrinthectomy.
Okay. Okay.
People have earlier described transcanal also, like
Huh.
stapes surgery.
Okay.
But that
Okay.
is inadequate a procedure. You cannot go all around and remove the
Huh.
entire mucosa and vertigo can still persist.
Correct. Correct.
Best is do a cortical mastectomy
Huh.
and do a complete labyrinthectomy. That is the
Labyrinthectomy.
final answer.
Answer. Okay.
See,
Right.
all these ablation procedures,
Huh.
like vestibular nerectomy, labyrinthectomy,
Huh.
their result depends upon the compensation from opposite side.
Correct. Correct.
In people having poor compensation,
Yes.
poor compensation,
Huh.
in spite of this surgical ablation, you cannot expect a good result. These are destructive procedures.
Correct.
So we never advocate these procedures in elderly patients who have a poor compensation, poor ability for compensating. So
Okay.
these are only for young patients.
Hmm.
Final answer, in spite of chemical labyrinthectomy, if persists, hearing preserved, vestibular nerectomy, hearing gone, surgical labyrinthectomy. That's
Okay.
the final answer.
Okay. Thank you, Satish.
Yeah, people have been doing, but variable results. Their long-term studies are not done. Endolymphatic decompression is most of the time. Centers nowadays for them is obsolete.
Okay. Okay.
Now, बाकी लोग we'll do break after 10-15 minutes. What's the time? So after 15, half an hour. After half an hour, after cochlear dissection, we'll take a break. Okay?
Okay.
Hello?
Yeah. Satish, tell me.
So, what I was showing was the vestibular, scala vestibuli.
Yes.
See that opening?
Yes. Scala vestibuli and.
Everybody should know how the three tubes are formed.
Hmm.
See this?
Yeah.
Dena, patli bar dena. And I will show again with the regular 4 mm endoscope. Can you give me 4 mm endoscope? 4 mm 0 degree. To show the architecture of all the three tubes, orientation of all the three tubes.
Tubes.
Yeah, give me 4 mm. See, the beautiful picture will be seen by the 4 mm.
Okay.
I had, drawn the diagram earlier, if you remember.
Yes.
I will show again. First, let me show with the 0 degree cable.
This is the Reasoner's membrane. This is the Reasoner's membrane. ಅಂತ ತೋರಿಸುತ್ತಾ
ಚಾಲು ಕರೋ ಯಾರ್
ಕೆಳಗಡೆ ಅದು ಹಿಂಗ್ ಅಲ್ಲಾಡ್ತಿತ್ತಲ್ಲ ರೀಸನರ್ಸ್ membrane.
Switch on, please.
Basilar membrane. Light.
ये नहीं हो गया, बंद नहीं होगा क्या? नहीं लगता क्या? How to switch on? Please switch on the light. Not yet. What's wrong with the light source? Who is the technical guy?
Can we use the Microsoft light, Satish?
Now.
Okay.
See what I want to show you. See the cochlear openings. Hello?
Yeah, Satish.
So focus karna. Focus once, just a minute. Now, yes. Can you see the tube?
Yes.
See
Yes,
what
sir.
is this lower opening?
Scala tympani.
Scala tympani.
This lower one is the scala tympani, okay?
Yeah.
Here is the modulus and above is the scala vestibuli. Can you see?
Yes.
Yeah.
Now
And
see how they are dividing.
Yeah.
Can you see this white?
Yes.
This whitish serpentine is what?
Basilar.
Spiral lamella.
Basilar spiral
See,
lamella.
it is arising here medially.
Yeah.
Okay,
From the
Modulus.
modulus. It is arising here medially from the modulus.
Very good.
And see, before reaching the outer wall, it is ending.
Yeah.
See, this white bone is ending. This is thin bone, osseous spiral lamella.
Correct.
Dividing the tube above and below. Can you see now?
Yes.
Now, at the outer wall. At the outer wall, see this tube. At the outer wall,
Yes.
it ends. Can you see?
Yes.
And there are two very, very thin tubes. Arise and join the lateral wall. Very small space between these two tubes.
That's media.
At the outer wall.
Scala media.
See that these two tubes joins to enclose the scala media.
Okay.
Very narrow space at the close to the outer wall.
Yes, sir.
It's just before the outer wall, this white bone is ending, and then
Correct.
thin membrane is attaching this white bone to the outer wall. Can you see?
Yes.
Less than a millimeter space.
That's the smallest one, yeah.
Yeah. So now let me draw the diagram same. Can you give me so that microscopic picture now, please? I hope it is clear.
Yes.
Yes, sir.
Now, give me the pen and
Sir,
pen.
can you show the distribution of spiral ganglion cells in
Yeah, I
different
will.
parts of the cochlea?
Show the?
In different parts of the basal turn, mid turn, and hyper.
Yeah, I will show. I will show. कुछ भी दे दो यार. मत दे. See now, the same diagram I am making now. Hello?
Yes.
Picture, sir.
ये क्या है?
No
pen है
picture,
क्या?
sir.
What is this? आगे तो बंद है. See this. This is the cochlear tube. Okay?
Yeah.
Here is the.
Satish,
Hello?
everything is blank.
ये क्या हो गया?
No, I think it is more brighter. Hello?
It's very bright, sir. We are unable to see
White
the.
Adjust ಮಾಡ್ತಾ ಇದ್ದಾನೆ.
Now it's okay. Yes. There are two lights, I think. One is the top one, other is the microscope. Yeah. Now
Yes,
it's okay.
now it's
Yes.
correct.
Yeah.
They'll do.
Yes, more. Yes. Hello?
Yeah.
Yes.
Now see, this was the cochlear tube.
Yes.
In the medial wall is the modulus. At the end, I will open up the modulus. This tube runs all around the modulus. Modulus is the central core.
Yeah.
And this tube runs all around the modulus, okay? In
Okay.
2.5 curves.
Yeah.
So this tube, one spiral lamella goes from the modulus towards the lateral wall. You had seen.
Yes.
And it ends just before the lateral wall.
Correct.
The lower opening is scala tympani.
Upper
From
is
here, one membrane. अरे यार, कौन है? From here,
Basilar membrane.
the one membrane emerges from here and go to the outer wall, and one membrane anteriorly going like this.
okay.
This small space close to the outer wall is scala media. Scala tympani and scala vestibuli.
Vestibuli.
And this is a thin bone, very thin bone, flimsy, you have seen. Osseous spiral lamina.
Just paralamina. Yeah.
This is the architecture of cochlea.
Okay.
Now, and this is the modulus here. Okay?
Ah.
Now, how the hearing goes. See this. Again. You have understood all these three?
Yes.
Vestibuli, tympani, media,
Yes.
and modulus.
Perfect.
Now, I am enlarging this scala media here. See this.
Yes.
And this system runs all along 2.5 tons.
Okay.
Okay? And there are around 35,000 nerve fibers which emerge from the scala media. So at every point, what happens? This is scala media. I am enlarging this. This is basilar membrane. This is Reedner's membrane. Okay? Hello? Hello?
Hello? Yes.
Can you hear me?
Yes.
This is the picture.
Hear
I have
you.
enlarged the scala media.
Yes, sir. We can hear you.
The
Yeah, we
scala
can.
media close to the outer wall, there are a couple of outer hair cells like this.
Yes. Okay.
And then a single large inner hair cell.
Okay.
And the tectorial membrane above.
Yes.
This inner hair, because of the current generated, this inner hair cell fiber, it runs through the opening in the scala, opening in the osseous spiral lamella. Right from the round window till the helicotrema, apex. This is osseous spiral lamella you had seen. This osseous spiral lamella. Such 35,000 fibers run through the osseous spiral lamella like this. What my point?
Yes, sir. Clear.
Yes, sir.
And every fiber comes from the inner ear cell fiber from the scala media. Run through the opening in the canal in the osseous spiral lamella. Okay? Hello?
Yes, sir.
Hello, yes, sir. Clear.
Osseous spiral lamella carries the fiber, and that fiber goes in the modulus. So this is peripheral fiber emerging from the inner hair cell, goes to the osseous spiral lamella to enter into modulus. I hope it is clear.
Yes.
Now, I'm enlarging the picture of the modulus. Now from everywhere, see this like this.
Yes.
The fibers converge into the modulus, all 3 tons. 2.5 tons.
2.5 tons.
35,000 fibers.
Yes,
And
sir.
their cell bodies are in the peripheral part of the modulus.
Yes.
Yes, sir.
All around.
Yes.
So this peripheral part of the modulus containing all the cell bodies of all 35,000 neurons coming from the osseous spiral lamella like this.
Yes.
This is spiral canal of Rosenthal.
Yes.
That contains the cell bodies of
Of all the
neurons.
cells. Yes.
Cell bodies. And from here, then the second order neuron starts, and all these 35,000 fibers, second order neuron coalesce together to form the cochlear nerve.
Cochlear nerve.
So the beginning of the cochlear nerve is at the level of the
modulus, central modulus.
Modulus is the beginning. And see now how, see if I make a cross section of the modulus, this is superior, inferior. You know, lateral, medial. All these fibers from the modulus, they take a spiral turn like this through the cribriform aperture in the medial part of the module. There is a cribriform plate.
Yeah.
In the medial wall of the modulus, which prevents the CSF coming down inside.
Okay.
Through these 35,000 apertures, the fiber come out and form the cochlear nerve below. Here.
Okay. Yes.
This anatomy we have to see.
Yes.
Got my point?
Yes.
How the hearing comes? See, this is scala media fiber come here. Here the cell bodies from the second of the neuron in the modulus, and from modulus the cochlear nerve forms. I hope it is clear.
Yes.
Let us see. Let us see this now. See this. Can you see the cochlear lumen?
Yes.
That's the osseous spiral lamella.
Yes.
See this? Such a flimsy lamella, and openings in this lamella right from here till there contains 35,000 openings. See this?
Correct.
This is a thin lamella.
Yeah.
So fiber from the outer lamella, scala media run through this to enter into the modulus here.
What is the
Here is the modulus.
magnification? What is the magnification?
Satish, can you go to one higher magnification?
One more.
One more higher magnification.
Okay.
Yes.
This one?
Yes. Yeah.
This is better.
This is better.
Okay.
This is better.
Now I will drill all around the modulus and see all the turns. Okay? See our implant, the base, why we are understanding this implant should go in this lower story. The whole idea of understanding this is to prevent intracochlear trauma. Our implant from the round window, extended round window, should go in this tunnel, inferior. Not in this superior one. Got my point?
Yeah.
We are not supposed to damage this osseous spiral lamella. If this damage, the residual hearing is gone. See this?
Yes.
So the implant should go in lower story. And this all the 2.5 tons revolve around this modulus. This modulus is here.
Okay.
Let's uncover rest of the things. Come.
Sir, if the basal turn is ossified, then?
If the basal turn is ossified, if the scala tympani is ossified, we should try in the scala vestibuli.
Yes, sir.
That is ossified, then we'll implant in the middle turn. We can put multiple arrays possible, one in middle turn, one in basal turn, if anywhere possible.
Yes, sir.
You have to explore all the possible things to stimulate. Now, I am drilling this outer wall. Drilling the cochlea now. This is cochlear drill out. Whenever cochlear drill out is indicated or doing, we always advocate following the subtotal petrojectomy. The reason being, see the kind of exposure we have. Through the narrow posterior tympanotomy, we try to do, one can end up damaging carotid artery. See how close the carotid artery is. Can you see?
Yes.
See,
1 millimeter thickness.
This is the cochlea. These are the upper story, middle story, all.
Yes, sir. 1 millimeter thickness,
and
sir.
Here is the carotid so close.
Yes.
If you try to do this drill out through the narrow posterior tympanotomy,
We may
it's a
enter
disaster if you damage the carotid arteries. Always, if you are doing a drill out, one must do a subtotal petrojectomy and do undervision like this. See this?
Yes, sir.
See this? See the turning. See, this is turning all the way around the modulus.
Yes, sir.
Yes.
And this will come like this above, and then second turn, then third turn, apical turn. So now, you were asking, where is the second turn? See this. We have a dummy implant and we'll show you how that, threads all around. Patli diamond. Now let me show you the second turn. See this. This is the ascending basal turn. You see, this is the ascending basal turn.
Yeah.
Yes. It goes all around. Right from top to bottom, it is basal turn. Rest of the two turns are in the lap of the basal turn.
Yeah, this is the lowest,
Pardon?
the lower turn.
Yeah. So this basal turn, see here, it is ascending. So it is ascending like this. See this? And then
Yes,
it
sir.
becomes a descending basal turn like this. See this ascending basal
Yes.
turn, descending basal
Descending.
turn, and then the
Second
beginning
turn.
of the second turn.
Yes, sir.
Okay? So let us see this. And where the descending basal turn is, see the facial nerve there, labyrinthine segment. See the facial nerve. Here at
Yes,
the descending basal turn is closest to the facial nerve. So this, where is the second turn? Likely I'm trying to open. This was our spherical recess. See this? Vestibule. That was our whole window covering the spherical recess. I am going just anterior to it. See this? See here. Hello?
Yes, sir.
Yes, yeah.
Yes, sir.
Just anterior to the spherical recess. See this. What has come?
Yeah.
Second turn.
Second.
That's the beginning of the second turn. Let me show you. See that?
Yes, sir.
Now give me the implant to show them. Let me push the implant and show you. See, I'm pushing my implant here.
Yes, sir.
Yeah, that's the implant. See this? इधर गया. Now, see my implant which has come out here in the second turn. Yeah. Just too flimsy. Here it is. Here it is now. Yes, now. That's what I wanted to show. Yes. See, my implant is here.
Yeah.
My implant is here. See this?
Yeah. Yes, yes.
And then it is rotating towards the apical turn. See, it is going there. If I push further, it will go further. Now it is going towards the apical turn.
Yes, sir.
See this?
Yes,
Yeah.
sir.
Now let us remove the bone completely, uncover everything.
Does it stop at helicotrema?
Yes.
Yeah. Yes, yes. That is very narrow space. We are not
Yes.
supposed to push that level. Now my level of the apical turn is where? Just below the GSPN. I will show the same from the middle fossa side.
Yes.
See, this is your facial nerve. This is the beginning of the GSPN. See here?
Yes, sir.
That's the beginning of the GSPN. Can you see?
Yes,
Yeah.
yes.
Can you see the GSPN?
Yeah.
Yeah.
This is GSPN. My apical turn is here below the GSPN. इसको साफ करना. See, my implant.
Sir, what is retrograde and antigrade implant inserts?
This is antigrade. Retrograde
Yes.
I will show from the middle fossa side.
Yes.
See, this is my apical turn.
Yeah.
Yes.
And this implant, if the space is not narrow, can reach. It is going up. See, going up. And here is the apical turn. Now
Yes,
I can see the implant in the apical turn as well. See, my implant is there in the apical turn. I have seen. Oh.
Yes.
Let me clear for you. I have already seen.
Sir, is it need to introduce the entire length of cochlear duct?
Pardon?
The
Pardon?
Electrode, sir.
Not clear. Not clear.
Is it need to in the entire length of the duct to
It is
introduce
needed
the
to.
electrode?
No, no, no.
No, no,
Or
no.
only
I will tell you
baseline
the
middle
concept.
turner in
Not needed. Not at all. I condemn. Strongly condemn.
Yes. Yes, sir.
I will show you. I will show you. Just a minute.
Yes, sir.
You can't climb up to the tip of the branch.
Why at
One
what
step.
length one should,
Stem.
push?
Like a tree.
Yes. I am removing all interscalar septa now.
Yes, sir.
See the implant lying everywhere. See, I am removing all the septa. See the implant going?
Yes.
See the implant going?
Yeah, yeah.
This is basal turn, this is middle turn.
Yes, sir.
Can you see?
Yeah.
Yes.
That is even osseous spiral lamina we can see, sir.
And now see very clearly where the implant is going up in the
Yeah.
apical turn. See there.
Yeah.
Yeah.
Yes.
Appara.
Yeah. Seen, sir.
Appara.
Yeah.
Yeah.
This implant we push from here.
Yeah.
It came in the second turn.
Yeah.
And from where it is going up there in the
Yeah.
apical turn.
Apical turn.
See that? And see what is there in the middle? This is
Modulus.
modulus. All around.
Hugging the modulus.
Hugging the modulus. See this? This is the implant coming from the...
Sir, but it is not hugging. Is it hugging the malleolus? It is.
Pardon?
It is towards the periphery, no? Spiral
See,
lamina.
this is the free, mid-scala implant.
Okay, yes,
Then
sir.
the concept of modulus hugging implant, that is different.
Yeah, yeah.
I will tell you the reason and where it is indicated. Modulus hugging means the implant should be close to the modulus, and that concept was popularized
Yeah.
to stimulate the spiral ganglion cells more closely.
Okay, okay.
It looks so nice.
Yes, sir.
So what happened? The modulus hugging implants were introduced with a stellate inside.
Okay, sir.
Stellate makes the implant very, very thick, very stout. So once you push the implant with the stellate in, and when you remove the stellate, the implant closely encircles the modulus. You know?
Yes, sir. Yes, sir.
First of all, the introduction gives a lot of intracochlear trauma. It is too big.
Yeah.
Secondly, if you try to pull it, it will destroy everything because it hugs the modulus.
Modulus.
So
Yes.
nowadays, that is not used extensively.
Okay, sir.
Now, in which condition the modulus hugging implant is still indicated? We use still in one condition. Let me show you. See.
Sir, we have some online questions.
Yes, please.
Can you insert a cochlear implant while performing a labyrinthectomy?
Pardon?
Can you insert a cochlear implant while performing a labyrinthectomy?
Yes, same stage. Same stage.
What are the indications, situations?
See, the implant indications are expanded. The question was, can we do an implant at the same stage of labyrinthectomy? Yes. Yes, means labyrinthectomy done, surgical total, you can insert the implant. Rather, after labyrinthectomy, you really want to rehabilitate, it has to be inserted at the same stage. Otherwise, the cochlea will ossify. Labyrinthectomy incites cochlear reaction and ossification. If you don't insert at that time, you lose the opportunity.
Like subtotal petrosectomy for cholestoma, and
Yes.
implant surgery.
We have done numbers of implants with full cholestoma in one stage, subtotal petrosectomy, removal of cholestoma and implantation and cul-de-sac closure. Simultaneous, same stage.
For SLNAS patients.
Yes, all profound loss patients.
What is the bone anterior to the facial nerve to be removed to expose the round window?
Anterior to the facial nerve
to be exposed in order to see the round window.
Yeah, that is a part of the facial canal. One is the pyramid, and is that's what we call the anterior thinning of the facial nerve. Caudal eminence, pyramidal eminence, all these eminences are on the anterior part. Secondly, you asked about the labyrinthectomy. The implant indications are expanded now, and we have been implanting together after major lateral skull base procedures. Now the things have changed. The only principle is the basic functioning unit should remain intact for the implant to be effective. After any procedure, same stage. So what is the basic functioning unit for the implant to be successful? A fluid-filled cochlea and intact cochlear nerve. If these two are remaining after any ablative procedure of the skull base, you can implant same stage. Like after the glomus tumors, major glomus paraganglioma, infratemporal fossa, A, B, C, whatever you have done. If your cochlea is unaffected, cochlea is fluid filled and cochlear nerve is intact, you can do the implant same stage if the patient has a profound loss. Even after vestibular schwannoma resection, if the cochlear nerve at the end of the surgery shows response, patient having died year earlier, the end of the vestibular schwannoma, limited schwannoma resection, if the cochlear nerve shows response and the cochlea is fluid filled, you can implant same stage. So after any procedure in the lateral skull base, this is the indication. Rather than going into XYZ indication, where the basic functioning unit is intact, the fluid-filled cochlea and intact cochlear nerve is a candidate for implantation, having profound loss, not being rehabilitated with any hearing aid. Any other question? 5 minutes. The cochlear dissection, 5 minutes. So,
sir, what are the IP anomalies, IP1 and IP3 by synergicals? IP3 anomaly, synergically IP3 anomaly.
See, anomalies are related to the developmental arrest. Simply you can understand. And now implant is indicated in all anomalies, provided this basic functioning unit is intact. Means cochlea should have a fluid, maybe mal-developed cochlea. No architecture, fluid should be there and cochlear nerve should be intact. So in situation where there is no cochlear nerve like Michel's aplasia, You cannot implant. There's no fun in implanting. In cochlear nerve, yes, you should implant. Still, there are fibers to stimulate, enough fibers. So, cochlear anomalies in brief, what you can do, this was extensively studied by Sanaroglu. He did histopathological studies of all embryos in the temporal bone lab. So, normally what happens, the cochlea develops at the 3rd week of embryo. In 4th week, the otocyst, whatever develops in the 3rd week, it differentiates into cochlea and vestibule. Got my point? So, if the developmental arrest happens to take place after 3rd week, there will be a single cavity. Otocyst, maybe a bigger one, common cavity. So, if the embryo development, inner ear developmental arrest happens after the 3rd week, there will be a common cavity, no differentiation between cochlea and vestibule. And common cavity has a wide interneuterine canal because that is not developed the separation from the cochlea. So, moment you open, there will be gusher. And no internal architecture, nothing, single cavity, no cochlea, no vestibule, no inside turns, anything. So, the sensory epithelium is supposed to be at the periphery. So, still you can implant with guarded prognosis. After the 4th week, when the cochlea and vestibule differentiates, and the 4th week is common cavity, 3rd week is otocyst. After the 4th week, the cochlea and vestibule differentiate. So now in the 5th week, the variety of differentiation arrest happens. Suppose cochlea and vestibule are arrested in the 5th week, and in the 5th week, the cochlea and vestibule separated, but the development further arrest happens. There will be single fluid-filled cochlea, single vestibule, no internal architecture, and this is IP1, incomplete partition type 1, wherein the cochlea has no architecture inside. The dimension is okay, cochlear size is okay, vestibule size is okay, but no internal architecture, no modulus to prevent CSF leak. Again, you open, the sensory membrane is on the outer wall and there will be gusher. This is IP1. If further cochlear vestibule matures, the internal partition develops. And the IP2 is what? Some more development. After the 5th weeks, and later on, if the arrest happens, the basal turn forms. The apical and middle, they are together form a single cystic anomaly. But the basal turn is well formed. When the basal turn is well formed, the modulus forms. And that prevents the gusher if you do implant. And this is almost as a normal cochlea. You can give good result because the basal turn forms and majority of the hearing is through the basal turn. In the IP3, that's a different anomaly of the endosteum of the cochlea. In that, the modulus doesn't form and cochlear outer periosteum is absent. So, there is again a chance of good gusher because there is direct communication with the intra-auditory meatus, and this is IP3 is again dangerous. I mean, difficult anomaly. Then later on, the variety of differentiation anomalies are there. Sometimes cochlear arrest happens. Vestibule is normal. There is micro-size cochlea, hypoplastic cochlea, hypoplastic cochlea. Now, there are a variety of anomalies, but implant is possible in all with guarded prognosis. With difficulties in surgery, gusher you have to manage if happens to occur.
So what's the role of transtympanic ABR in hypoplastic?
Transtympanic EBR is to ascertain that the cochlear nerve is intact.
Is it to be used in all the, is there any particular?
If available, it is very useful.
What is the minimum dimension with which you can consider implantation? The thickness of the nerve?
No. Thickness is no criteria. It is the stimulation which matters. Thickness is no criteria. But generally on MRI, if your nerve is very thin, less than a millimeter or so, you can have a poor prognosis, but still it is indicated. Because the worst result of the implant is better than the best result of ABI. And so you must, first choice is implant irrespective of everything. So now you see,
So is there
the implant in the second turn here. See this? We place from here and it has gone all around the annulus in the second turn and gone in the apical turn there.
Yes, yes.
See now? Now I am removing this interscalar partitions.
Dr. Satish?
Yes, please.
Is there any way we can know whether the cochlear nerve is working or not through the skin without opening the thing?
Through the?
Through the skin and the mastoid, intact mastoid?
I didn't get your question, please.
You say you're doing an acoustic or something. Is there any way we can, you're doing a retromastoid. Is there any way we can make out whether the cochlear nerve is working or not through the thing?
Yeah, the cochlear nerve monitoring.
We can do that?
Yes, cochlear monitoring can be done.
Okay, then I think
yes, nowadays sensory nerve monitoring can be done. All sensory nerve monitoring can be done. Even fifth nerve, cochlear nerve, any sensory nerve monitoring can.
We do that. Even last week we did a cavernous sinus where we did the optic nerve and everything.
Yes, even the optic nerve monitoring can be done. See now, I am going to go to the intra-auditory canal in couple of minutes. See, I am showing this, removing this interscalar partition and showing you something, the labyrinthine segment on the facial nerve and relationship with the cochlea. See, I am showing how the upper basal turn is. See this? How the implant was coming. See this?
Yes, yes.
See, inner central core is modulus. Can you see all? The modulus very clear?
Yes, yes.
Yeah.
In the center is the modulus. In the center is the modulus. See this here. Here is the modulus.
Yes, sir.
And this part of the descending basal portion. See, this was the facial nerve. Can you see?
Yes, sir.
This is the labyrinthine portion. Can you see going down?
Yes.
Yeah.
This
Very
labyrinthine portion comes through here to enter into the intra-auditory meatus, which we are going to open.
Yeah.
And this is closest to the facial nerve here.
Yes.
Here, this implant here.
Yes.
In the descending basal portion. So in all CT scan, we must, before cochlear implantation, we must look at the thickness of the bone separating the labyrinthine segment from the basal
Turn.
See, this is the facial now I am uncovering.
Both carotid and facial nerve.
See this? Can you see the facial nerve here?
Yes.
And the implant is here.
Yeah.
So what happens? Many a times, if this bone is absent, then what will
Facial
happen?
pictures.
You start the implant, it will stimulate the facial nerve.
Facial palsy.
And facial stimulation is such a frustrating problem. Ultimately, you switch off those electrodes close to that, or either you may have to explant. The patient becomes so frustrated. Nobody can tolerate facial stimulation. So you must see this thickness of this bone between the descending basal turn and the labyrinthine portion to prevent that problem. And secondly, this problem happens in the autosclerosis. We have done many advanced autosclerotic patients implant. When the autosclerosis has given profound deafness, stepidotomy and hearing aid is not benefited, and there are a lot of cochlear destruction because of autosclerosis, which made the implant imminent. Otherwise, we would have lost the opportunity to implant with further destruction. So in autosclerostic pathology, what happens? The entire labyrinthine bone becomes hypodense. It becomes more, conducive for the current to pass. So in that situation, if you implant in autosclerotic patient, this electrode at the descending basal portion, in spite of the intact bone, the current can pass through the bone and stimulate the facial nerve. This is very common in autosclerotic patients. And in that particular category of patients, we order the modulus hugging implant. Implant away from the lateral wall, close to the modulus, so it stays away from the facial nerve. That's the only indication, in my opinion, in the present context, where we should use the modulus hugging implant so that it remains close to the modulus, not to the outer wall, where it can stimulate the facial nerve. So that is a very troublesome problem otherwise. So that was, I wanted to show, this is the labyrinthine portion. See that?
Yes, yes.
Yes, yes.
Now I am removing this implant and opening the modulus. See now, the way we inserted, the same way we will remove. See this?
Yeah.
Yeah.
See, the implant is all around the modulus in the lower story. Why it is in the lower story? Because we put straight tunnel in. See that?
Yeah.
Lower story
Short,
means
straight
scala
insert.
tympani. See, my upper story is intact. Can you see?
Yeah.
Yeah.
Yes, sir.
If you
Vestibular.
put under vision is a tunnel in the lower story scala tympani, it revolves all around in the scala tympani only.
It is more than 4.
If the implant hits the modulus everywhere, it will keep hitting everywhere.
It's more than 400 degree.
No. Yes, that question, that how deep it should be, it should go. Let me tell you.
470 degrees.
Yeah. Let me tell you how deep the implant should be placed. See now, what happens? See, the spiral ganglion fibers I told you come through the osseous spiral lamella. See this? They enter into the modulus in the basal turn horizontally. In the middle turn, they come obliquely. From apical turn, they come steep down.
Vertically.
So majority of the cell bodies are ultimately in the middle turn. Basal turn and middle turn. So if you put the implant around 450 degree is good enough. 450 degree, one full turn and then 90 degree. The reason being, there are two reasons behind this. Number one, not to unnecessarily push further in the apical turn to give damage. Apical turn is a very, very narrow tunnel. If you try to push that implant through it, it will damage everything rather than giving benefit. Number one. Number two, there is no point in stimulating the apical turn unnecessarily by more pushing. The apical turn cell bodies are already projecting down. Number three, very interesting. All these implant companies, the implant they're producing, they're not stimulating entire 20,000 human range. Human range of hearing is from 0 to 20,000 hertz.
Yeah.
0 at the apical helicotrema level, lower frequency, and highest 20,000 we hear at a close to the round window. This is our normal hearing.
Yes.
Maximum. All implant complete, and this is the principle that from basal to apical, according to the frequency phase, according to the frequency, that particular area is stimulated. Now, all the commercial implants available, they stimulate a fixed range. Not all. All implants stimulate the frequency range from 75 hertz to 11,750 hertz.
Okay.
So from round window, 20,000 to 11,700 around 4 millimeter is useless to stimulate. Even if you keep your implant, it is doing nothing. It doesn't stimulate frequency above 11,750. And it doesn't stimulate below 75. So there is no point in implanting beyond 24 millimeter. It's a useless exercise inviting problems. Maximum. So those who are measuring the cochlear length is for theoretical purpose. Don't think that, threading the entire cochlea will give better result. It will spoil the entire result. And that area of interest of stimulation is limited. Even from round window to next 4 millimeter, there is no point in keeping the electrode. It's not going to stimulate. See now, I have removed the implant. See now, I am removing this interscalar septa to uncover the entire modulus. Underneath the modulus is the beginning of the cochlear nerve and the beginning of the intra-auditory canal. Let me show you. See now the central core of the modulus, very prominent.
Yes.
This modulus I had shown you. See from the round window here, I had shown you this is modulus. Remember?
Yeah.
Our implant should never direct toward the modulus. Implant should direct inferiorly. That's why the inferior widening of the round window was done. Got my point?
Yeah.
So now we are reaching the modulus, and in next couple of minutes, I'm going to show you the beginning of the cochlear nerve and the intra-auditory meatus. How the cochlear nerve is formed. I told you there is a cribriform area through which this cochlear nerve fiber turns a spiral and then pass through the cribriform area to enter into the intra-auditory. See, this is intra-auditory meatus. Yes.
Yes.
Now, see, this is modulus.
The cochlear nerve.
I'll show just a minute. Right angle. चलो दे दो ये देता छोड़ो पतला दे यार सारी खिंच जाएगी. See now, this is modulus.
Yes.
This is the cribriform area. Now I'm removing. See this. This is cribriform area.
Yeah.
The porous bone. See this?
Yeah.
And underneath that porous bone, see this? This is the cochlear nerve.
Yeah.
Oh, yeah.
Good.
See, this was the porous bone, and this is the cochlear nerve. See this? This is the cochlear nerve, and this is the intra-auditory meatus. Can you see the nerve?
Yeah.
Yes, sir.
Yes.
Another nerve in this region, inferiorly the cochlear nerve. And here coming is see this labyrinthine segment? See this facial nerve?
Facial nerve.
You remove the bone and we'll follow this facial nerve in the
interlateral.
This is facial nerve. This is facial nerve.
Yes.
Okay.
See the movement. So here, this is the intra-auditory meatus, and that is how the nerve passed deeply inside. So we'll open later this intra-auditory meatus. This is almost a centimeter long, deep, vertically deep. See the orientation of the external intra-auditory meatus.
In the same plane.
See?
Same plane.
This was the external auditory meatus.
Same axis.
This is around 160 degrees. So this is intra-auditory meatus.
Yeah.
And now I will remove the entire vestibule, the wall of the intra-auditory meatus, all this labyrinthine remaining block to go deep down in the CP angle. So this is so far all around. This is the cochlea. This is, jugular. This is the carotid, jugular bulb, infracochlear approach. The vestibule we have drilled out. Semicircular canal we have drilled out. And this is intra-auditory meatus. And now we will move on to the skull-base approaches.
Where is the vestibular now?
Vestibular nerves.
Vestibular nerve, it came in suction, that fibers initially now. These are 4 nerves. Lower down will follow.
Higher magnification.
Yeah, lower down will follow.
Yeah.
Looks like thin. This is vestibular now. I don't want to disturb.
Yeah.
But the suction took away some of the fibers. See?
Okay.
Will follow from below at the intra-auditory meatus.
Yes.
The porous. So far is the basic anatomy of the temporal bone. Of the middle ear, inner ear, subtotal petrojectomy, cochlea, vestibule, limits, boundaries, all. And now we have a couple of approaches we'll follow. The extensive approach. We'll do some middle fossa approach, subtemporal bone resection. Dr. Madhu is here to give us craniotomy. So now the further advanced work will start after a break. We have 10-15 minutes break.
Okay.
Thank you so much, sir, for this excellent demonstration of temporal bone. We are awed by the amount of information there is. Totally inspired by the orientation. I think we took years and years to understand this. You have made it possible in a few hours' time. As sir takes a break for his lunch, may I request the postgraduates to stay back, and Dr. Dinesh Rajendran will take over the session for a few minutes to conduct a quiz program for you, and there are some attractive prizes while sir goes and has his lunch and comes back, so as to keep you engaged. I can switch on the lights. Lights. Those of you who have not had lunch, please go and have your lunch and come back here, please.
Yeah. I hope you had a good lunch. There's a white paper being distributed to the postgraduates. Please write down your name, your college, and what is that? What is that? Huh? Any of the postgraduates who are going for lunch? Anyone? All are here? Okay. I hope the postgraduates are here. It'll be a quick 10 minutes session. Simple questions, simple answers. Pen drive back. Write down your names, your college name, and your mobile number. No transmission. Write down your names, your college name, and your mobile number. No need to project there. It is only for only for here. इसमें कर लो ना कैसे में इसमें लगा हाँ ठीक है लगा वहाँ होटल में लगा दो लगा आगे बुला दो लगा दो अरे लिख दे hello. नहीं खाली है कि बोलते हैं वहाँ नहीं वहाँ नहीं जाएगा ऐसे क्या लगा ये इंटरनेट में नहीं आना चाहिए ये इंटरनेट में नहीं आना चाहिए खाली यहाँ पे डिस्प्ले कर इंटरनेट पे नहीं आना चाहिए नहीं कुछ होगा प्रॉब्लम सर खाली यहाँ डिस्प्ले ठीक है नहीं ठीक है ओके जल्दी कनेक्ट करो okay we are starting now there are some I hope you can see the screen. So welcome to the PG quiz 360-degree skull base. There are some quick scoring points. Correct response +1, wrong response -0.5. Slides are auto timed and there are totally 30 questions. So I have shared, just a minute, minimize this one. So we'll go from the beginning. So retaining the periorbital sling over the medial rectus during orbital decompression can prevent diplopia. So the natural os of the maxillary sinus is identified in the parasagittal planes. So this is an important question. The carotid artery and optic nerve are dehiscent in the lateral aspect of the sphenoid sinus in 25% and 4%. 25% carotid, 4% optic nerve. A little bigger answer, but anterior ethmoidal artery is encountered in the frontoethmoidal suture line approximately 24 millimeter posterior to the anterior lacrimal crest. So the petrous apex lesions which shows hypointense signals in T1 except in cholesterol granuloma. So the following are the otic capsule preserving approaches except translabyrinthine approach. So the following are the branches of the vertebrobasilar system except middle cerebral artery. So this one question was asked on internal auditory canal is exposed 316, which of the following translabyrinthine approach? It is the type 2 approach. So the landmark for internal auditory canal identification in the middle cranial fossa is, in this is all of the above: greater superficial petrosal nerve, arcuate eminence, middle meningeal artery. Which of the following structures do not pass through foramen ovale? All except nasociliary nerve. What is the distance of the anterior ethmoidal artery through the from the lacrimal crest? 24 millimeters. Which of the following statement about the anatomy of the pituitary fossa is false? It lies in the sella turcica of the ethmoid bone, which is not correct. So regarding the superior orbital fissure, which of it is incorrect? It is the common tendinous ring which binds the superior orbital fissure content and the nerves and muscles to the content of the optic canal. So this is an image of a meningioma. It has a dural artifact, dural tail defect. So anterior skull basis, these are all simple one-liners, but I've just added it to make it a little tricky. Okay, all simple answers. Okay, anterior skull base is formed primarily by ethmoid bone. The lateral skull base includes which and which bone? Temporal bone and the sphenoid bone. I'm not asking more specifics, but they're just superficial. Anterolateral skull base is composed of which all bones? Lateral sphenoid and temporal bones. Landmark in lateral skull base anatomy. That is the styloid process. Dash canal transmits the optic nerve through the anterolateral, that is optic canal. The orbital plate is a part of the frontal bone that contributes to the anterior skull base. The carotid canal is a passage within the lateral skull base that transmits the internal carotid. Simple answer. So the pterygopalatine fossa is bordered by the temporal bones in the anterolateral skull base. So the olfactory nerve, very common. No, normal answer, cribriform plate. The sigmoid sinus is located laterally and inferior to the skull base. Here, better to be added lateral skull base. Okay, and dash nerve exits the anterolateral skull base via the superior orbital fissure. That is the oculomotor nerve. Okay, dash sinus is located directly beneath the anterior cranial fossa, the ethmoid sinus. Very simple answer. Dash vein exits the skull base through the jugular foramen. That is the internal jugular vein. And which part of the sphenoid bone contributes to anterolateral skull base? The greater wing of sphenoid. And the anterior cranial fossa is an important surgical landmark in anterior skull base surgery. Okay, so that should be it. Okay, I think we had a quick recharge of your neurons. We'll get back to more of dissection. And if time permits, we will ask questions on the spot, preferably by Sir too. Thank you. We will announce the results soon in between the breaks. Okay, so please hang in.
Thank you, Dr. Rajendran Dinesh, for conducting the Super 30 quiz for our Super 30 postgraduates here. Hopefully, all of you get prizes. Let us see if you have a tie down. Just give us some time to calculate the results and come back to you. Meanwhile, until we prepare for the dissection again, you have some free time. You can visit the stalls. They have agreed to give some discounted price. And then there's a selfie board as well. So you can go and have your clicks and come back while we prepare in another 5 to 10 minutes. Okay.
ಒಳಗಡೆ ಅಲ್ಲಿಂದ ಆಮೇಲೆ ಇವ್ರು ಸ್ಟಾರ್ಟ್ ಮಾಡ್ಬೇಕು.
ठीक 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 सर साउंड बता दिया हेलो जी भी सर हेलो
check, 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 check,
यस
check.
यस
Sound
सॉरी
batela. Sound batela.
Hello?
हैं
Uh, may I have your attention, please? We'll be starting in another 10 minutes, and we will be uh, going again with the internal auditory meatus exposure by Satish Jain, sir.
Oh. Yeah, we are waiting.
Yes, sir.
बोलो ना एस्ट्रो कैसे खुलेगा? बोल इसको। हम्म। Hello. Gloves. Gloves. Hello. Satish. Yes. Hello.
Yes, sir.
Yes, boss.
Yes, sir. Good afternoon.
Yes.
Afternoon.
Good afternoon.
So,
How many centers are active?
pardon?
Mysore. So
Mysore.
many actually on YouTube about 1,700 are watching.
Very good.
Plus we have about 8 centers which are active.
Oh, good.
But currently 1,700 people are watching.
Watching.
Wonderful, sir.
Yeah. All over India.
Only India.
Of course, outside also.
Hello.
Yes, boss.
Yes, sir. So, in the first part, we saw the basic dissection of the temporal bone.
Yeah.
And now we have many procedures to show.
Yes.
So first, I will, not only the approaches, but the anatomy as well around the temporal bone.
Yes.
So now I have come to the opposite side.
Yeah.
And with the help of Dr. Madhusudan and his team.
Yes.
What we have done, let me show you. The next procedure I'm going to show you.
Yeah.
Subtotal temporal bone resection.
Which is done for
Malignancy
malignancy,
of the
sir.
temporal bone.
Okay.
This will show the anatomy all around as well at the same time.
Okay.
Rest of the translab or other approaches we'll see later.
Okay.
For temporal bone. See, this is the pinna.
Yeah.
Can you bring the external camera? So this subtotal temporal bone resection is the procedure of choice. This is the need of the time for all those poor fellows who have malignancies of the temporal bone, wherein we are forced to do the piecemeal resection, which is not standard of care at all.
Yeah.
Because of complexity of this procedure, very few people in the world are doing.
Yeah.
Remember, for any malignancy, लगाओ नहीं, इधर आओ. For any malignancy, en bloc resection with negative margins is the, desired thing to give a cure. Temporal bone malignancies are considered difficult and the outcome is considered poor only for the reason because the en bloc resection is not popular And the reason is obvious. This temporal bone is so strategically situated in the lateral part of the head. I had shown on the skull earlier how it has relationship with the intracranial structure inside and with the posterior middle cranial fossa structures, the temporal, the parietal, occipital, and the sphenoid bone relationship to make it more and more difficult. So now, the reason for opting for this procedure is to save those patients who have this malignancy, advanced malignancy.
Lighting, Satish, lighting is not sufficient. Okay.
Yeah, light is. I'm waiting for the camera. Now the camera is not telecasting now. Can you switch on to this camera?
It's coming. Too much bright. Too much bright. Yeah, now it's fine.
External camera picture.
Fine, Vishwas. Fine.
Hello.
Yes, sir. Hello, sir.
So removal of this temporal bone intact from all around calls for variety of surgical exercises. It has a close relationship. I had shown on skull the petrous bone superiorly related to the middle fossa and posteriorly to the posterior fossa. Yeah. Are you getting the external camera picture?
Yes.
Yeah, we're getting it.
See what has been done.
Sir, sorry to interrupt.
Next time we went for the lunch, this was done. Upar karo.
Sir, is it the opposite side, left side?
Upar karo.
Yeah. This is left side.
Yeah,
Yes.
left side. See, this incision was given. I will extend this further and see what has been done. This is the temporal bone. This is the extraordinary meatus. This middle fossa craniotomy is done so as to separate from the intracranial structures. And this is the posterior fossa craniotomy is done. This is the sigmoid sinus to separate from behind.
Focus.
This temporal bone has to be disarticulated from all around. And this kind of resection is always associated with total parotidectomy, assuming all these advanced, temporal bone cancers has already spread to the parotid. This is not uncommon, as the first echelon lymph nodes are in the parotid. And not only that, direct contiguous spread in the parotid is not uncommon. And similarly, the closest structure anterior to the temporal bone is the temporomandibular joint, which is almost always involved and resected as a part of the procedure. So, N blocks subtotal resection along with total parotidectomy and TM joint resection. This procedure will, help us discuss the entire anatomy all around the temporal bone. We had seen the anatomy within the temporal bone. Now we'll see anatomy all around and how this procedure can be executed. So, superiorly we have seen the exposure. Now I'm inferiorly extending the exposure. Can you increase the cautery? Increase cutting. Increase cutting. कर क्यों नहीं काम? इसका चक्कर है क्या? इसको पकड़. So now I'm extending my incision inferiorly. The reason being, this has to be disarticulated from below, posteriorly, superiorly, everywhere. And anteriorly, you have to go to do a parotidectomy as well as TM joint resection. I am extending my incision and cutting this canal now. You have seen the cul-de-sac closure earlier, the concept of cul-de-sac closure.
Yes.
Just remove this skin sleeve from the cartilage, separate from the cartilage, bring it out, and then reinforce with the cartilage layer from inside. This is the zygoma. I had shown on the model on the skull my cuts for this resection. Focus karna.
Some focusing is required, sir.
Yeah. I will reorient you again and again. Yes. Is it better?
Yes, much better now.
See, this is superior, this is inferior. This is temporal bone, this is external auditory meatus.
Yes, sir.
Above is the middle fossa, posteriorly is the posterior fossa. This is the sigmoid sinus.
Yes, clear.
And this is all temporal bone.
Okay.
Now, in order to separate it from below, anteriorly, see, this is TM joint. My anterior cut will resect the tumor. क्या हुआ? My anterior limit of resection includes the TM joint and beyond, and more anteriorly to the infratemporal fossa. The beauty of this technique is tumor removal from the infratemporal fossa is done under vision. No other approach can allow, as will remove the tumor from the infratemporal fossa from above. Inferiorly, the limit of resection is close to the vertebral artery. So we have to see and preserve the vertebral artery in toto. That's a very, very important structure to preserve in this case. Then the carotid, jugular, everything has to be preserved. The only morbidity associated in this procedure is the sacrifice of 7th and 8th cranial nerve, which otherwise are involved in most of the cases in advanced, temporal bone malignancies. So 7th, 8th cranial nerve morbidity is always there along with this process. Rest of the cranial nerve are always preserved, and this is how what I'm going to demonstrate here. This is the flap I have elevated. Now, if we see, this is the extraordinary canal, this is the mastoid process. If we see the anatomy all around, yeah, let me show you with the microscope now. I think. Yes. This will give a better picture.
Sir, one online question.
Yes, please.
Why is the temporal bone being removed from the cadaver instead of directly dissecting?
Instead of?
Directly dissecting the temporal bone. Why is it being removed from the cadaver?
For malignancies. This procedure is designed for malignancies only, so that we can provide en bloc resection with negative margins. No other procedure can offer this, access and removal of the temporal bone en bloc. Now, this is the extraordinary canal anteriorly, and this is the mastoid tip. Now, first of all, I am skeletonizing the mastoid tip. See what I am doing? One by one, I am removing the muscles from the mastoid tip. See the most superficial muscle we have divided here. What is this? Sternocleidomastoid. Underneath the sternocleidomastoid, what is this muscle with a different direction? This is splenius capitis. See this? Hello?
Yes, yes.
Yeah. Yes, sir.
Second muscle I am dividing from the mastoid tip is splenius capitis. Can you see some vessel underneath?
Yes, sir.
Yeah,
clear.
yeah.
Posteriorly.
Yes.
See, mastoid tip is here.
Yes, sir.
You can see a big vessel there.
If I remove this further layer of the muscle, this muscle is longissimus capitis, the third layer. Third layer is longissimus capitis. And now come the very common, which we, deal in our practice in and out. That is the digastric muscle. This is the digastric muscle here. So digastric we all know commonly. See this? Hello?
Yes.
Yeah. Yes, sir.
And this vessel coming from deep to digastric. See this? This is occipital artery. Can you see?
Yeah.
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 Yes, sir.
This is an important muscle. Occipital artery. See this?
Yeah.
This is an important vessel, though it is sacrificed in this scenario, but in the live surgery, this occipital artery identification and preservation is very, very important. We had seen in the morning the occipital artery base flap. This flap was based on this vessel over here.
Yes,
That's the mastoid tip here.
Yes.
See this? And this vessel was forming this vessel was supplying to the flap. This is such a robust vessel.
Inferiorly based flap.
Yeah, inferiorly based flap. So this is mastoid tip. Now, going further in this region, the most important structure which we see, vertebral artery is the key to identify and preserve in this anatomy, in this region. This axon artery canal, this is mastoid tip, and see, I am separating all these muscles from the mastoid. See this mastoid?
Yeah.
The bone of the mastoid, all these muscles. Now, let me open this anatomy. Once, pakad jaldi. I'm opening this space after the muscles have been removed. This is the space anterior to the sternemastoid. See the space anterior to the sternemastoid. This is my digastric. See the digastric muscle? This is the mastoid tip where the digastric is inserted, and this artery is coming from deep to digastric. Can you see again?
Yes, yes.
Yes. Very clear.
Very clear?
Yeah, very clear.
Yes, sir.
Now, as I said, the temporomandibular joint is an integral part of resection in this approach. This is the axonotary canal, and now see how close is the TM joint.
Yes.
This is the zygoma, and this is the TM joint, just to show you.
Yeah.
See, I'm opening the joint capsule here. See how close is the TM joint. It is always to be resected like this in this approach. Okay? What I can feel is the transverse process of first cervical vertebra. Here is the transverse process of first cervical vertebra. I'll come to it later. Now, second thing I mentioned, besides this, TM joint, the parotid gland has to be completely removed. See this? Since the seventh nerve sacrifice is the integral part of this procedure. See now, I will sacrifice the parotid gland completely. And my plane of resection would be the mesenteric muscle. See deep down to the level of the masseter. See this?
Yes, sir.
Deep down to the level of the masseter, entire this thing parotid gland has to come along with the specimen. Can you see?
Yeah.
Yeah.
That is the anterior extent of the incision.
Anterior extent of resection. This is the part of the parotid gland which extends in the neck.
Yes.
And in this part of the parotid comes the external carotid artery in the deeper part. The external carotid artery ascends in the parotid, and runs to the deep lobe. Parotid gland removal is the integral part in this technique.
The same sitting, you are correcting the facial deformity also? Facial nerve problem.
Facial nerve is sacrificed.
Okay, nerve is sacrificed.
Yeah, without sacrificing the facial nerve, one cannot remove anything completely. Now see.
Facial reanimation surgeries are there.
Pardon?
No, the same sitting
Many
can...
facial reanimation surgeries are there.
Yeah, can be done. I will discuss the
Yes.
various options for the facial reanimation.
Yes, sir. Yes, sir. Yes.
See, this is masseter muscle.
Yes, sir.
Yeah, this is a very useful muscle for facial reanimation also.
Yes.
I'll show you later the
Sure.
flap of the masseter muscle. That can be made for the facial reanimation. See, by and large for everybody, facial nerve is unique in giving spontaneous reanimation. Spontaneous, movement of the facial muscles. Facial nerve stimulate many group of muscles simultaneously to give spontaneous smile. Now, this is a unique function of the facial nerve fibers coming from the facial nucleus. And that function cannot be served by any other nerve. So, in facial nerve injuries, from lowest to the highest level, what can be done? Our protocol is, in simple injury, if decompression solves your issues, it should be the primary treatment. If the nerve is transected, if you can suture and re-establish the continuity, that is the first line answer. If there is a gap, you can use a cable graft. Reason being, in all these situations, the fire comes from the facial nucleus only to maintain the spontaneity. If there is a huge gap, you can bring in big cable graft like, in the vicinity there is the lingual nerve, this greater auricular. Otherwise, you can bring in the sural nerve. So you can bring in any nerve for that region in case required. If the primary segment or the proximal segment of the facial nerve is not available, then what to do? In that situation, you have to bring in other nerve. Now, what does the nerve do? It stimulates the motor end plates of the muscle for the function. Now, in long-standing palsies, the motor end plates gets denervated, and there is no point in even innervation with any nerve. So, if possible, if the proximal segment is not there, you have to bring in other nerve to stimulate the facial function. The problem is the spontaneity will never be there. Earlier, facio-hypoglossal anastomosis has been very, very popular. Facial nerve and hypoglossal anastomosis has been very, very popular for years together. Though for us, it is obsolete for many years now. The reason being the disadvantage of the morbidity of the hypoglossal nerve, as well as the synkinesis it gives. And more importantly, it doesn't give spontaneity. Now, what happens once you anastomose with the hypoglossal nerve? In order to stimulate the nerve function, the patient has to be trained to use the tongue mobility. He has to mobilize the tongue to get the facial function, and that looks so awkward. So it is never, for us, it is not acceptable. The nerve, which is closest to the facial nerve function, which we believe best and have been doing for years together in hundreds of the cases, finding the best results is the mesenteric nerve. Mesenteric nerve, I will show here, is a branch of mandibular nerve.
Mandibular. Anterior
It's a
region.
very, very strong motor nerve supplying one of the strongest muscle on the face, that is masseter. And the best part is masseter also is a part of smile, function of the masseter. And the cortical representation of the facial nerve and the mesenteric nerve is overlapping. So, in majority of the mesenteric anastomosis, the patients do not have to be, they do not have to undergo too much of rehabilitation. They learn easily the use of the facial muscles as the mesenteric muscles serve the same function. So nowadays, facio-mesenteric is the primary nerve we use for the anastomosis in case the nerve is required. In case the other nerve is required, our preferred nerve is facio-mesenteric. So that is our protocol. Now, in case there is long-standing palsy, even the motor plates have undergone denervation. So now you have to bring in muscle also, not only nerve. You have to bring muscle along with the nerve and vessels, free flap, and for which in this region, looking at the various aspects, gracilis muscle transplant along with the nerve and vessel is considered to be the best. So there are many ways to rehabilitate the facial nerve for various, situations. And I will show some of the procedures, commonly performed procedures we do in our practice on the facial nerve. Now, so this is what I exposed is the mandible. See, this is the angle of mandible, this is gonian, and this is the mesenteric muscle. Okay? Hello?
Yes, sir.
Yes. Yeah. क्या हुआ इसको? कट गया क्या? Now, our goal is to remove this temporal bone. So in order to disarticulate this temporal bone, we have to go all around and separate from the critical structures. Now, the muscle I am cutting through, this is digastric. See this? Digastric arises from here, from the digastric ridge, and going down as a tendon towards the hyoid and then further anteriorly. This is digastric. Then from the temporal bone, from this edge, the styloid process starts, which goes anteriorly, and there are lots of attached muscle to the styloid anteriorly. So all those muscles have to be separated in order to clear the temporal bone from below. Third is positively, positively, we have to identify and separate the vertebral artery, which otherwise can be a disaster if injured. So what vertebral artery, how to separate? I will show the course of the vertebral artery here for the sake of anatomy, and which is very commonly done in the practice as a part of the far lateral approach to address the lateral skull base lesion, which are far laterally inferiorly situated lesions. So here, this is the transverse process of the first cervical vertebra I can feel. And here is the mandible. The transverse process, immediately anterior to the transverse process is the jugular vein. See this. This is the transverse process. Artery. Immediately anteriorly, the jugular vein. This transverse process is a very, very important anatomy. This vertebral artery emerges in the lower neck from the subclavian artery. And then it goes up. This is.
So we have one online question.
Yes, please.
Is synkinesis unavoidable in transection, end-to-end repairs? How to manage synkinesis?
Synkinesis is because of the group of the nerve fibers firing together. So that is unavoidable if you suture a big nerve end to end. So synkinesis is generally unavoidable. If you suture the big, bunch of fibers end to end, that is unavoidable. That's why this hypoglossal anastomosis for us has gone disrepute. Yeah. Now, coming to the area again, I was going to show you the vertebral artery. Something is wrong. दिक्कत है इसके फुट पैड वो तो लगेगी नहीं वो फुट वाला ऑप्शन नहीं है इसलिए यहाँ चिपका दो So the principle for the vertebral artery identification and preservation. See, let me show you. This is the transverse process. Let me show you directly. Can you see the transverse process of the first vertebra?
Yes, sir.
The vertebral artery passes through this transverse process. Just for the sake of anatomy, I am showing you. It passes through the various, transverse processes of the various cervical vertebra. Up in the neck, it comes. And from there, it has a tortuous course before it enters the atlanto-occipital membrane to enter the, cranial cavity deep to the occipital condyle. So let me show you. This is the transverse process of the first cervical vertebra. Can you see? Hello?
Yes, sir.
Yeah.
Yeah.
At this point, I am skeletonizing. Give me a bone nibbler. Give me a bone nibbler. Why I'm showing my temporal bone is inferiorly related to it, and we have to prevent injury to the transverse process. See, this is the edge of the mastoid process below. Our principle is not to go 1 centimeter below and 1 centimeter deep to injure the vertebral artery. If you are within the 1 centimeter range, one cannot damage the vertical artery. I am opening to show you the vertebral artery. This transverse process is passing. हाथ स्लिप हो रहा है. दूसरा नहीं है अपना वाला.
It is very difficult and major procedure, sir.
Yes, very
It's
big
very
procedure.
difficult, sir.
Very big procedure it is.
Sir.
ये नीचे था बोन निबलर, वो चाहिए है क्या? Give me bone nibbler, other one. I cannot hold this. Yes. Hello.
Sir.
See, these are the various nerve going towards the foramen, jugular foramen. The various structures going in the depth towards the jugular foramen. All the cranial nerves, lower cranial nerves.
9, 10,
This is the jugular foramen here in the depth. This is the exonotory canal. This is the exonotory canal, and here is the jugular foramen, where all the nerves are converging. All the nerves are converging. Let me remove the soft
9,
tissue.
10, 11, sir.
Pardon?
9, 10, 11 only, sir.
Yeah, 9th and 11th. Lower cranial nerves.
Yes.
यार हाथ हैंड इस कुछ हाथ साफ करने को देना यार. चिकना हो गया. Yes. Yeah, this is my hand is slippery. Huh? Yes. That's the carotid artery. Hello.
Yes, sir.
Yeah.
That's the carotid artery in the neck. This is here. The external one ascending into the. This is ascending into the parotid. See here.
Yeah.
Yes, sir.
Can you see? Very clear?
Yeah.
This is the carotid ascending into the parotid here, which we have to. If you really want to see the posterior auricular branch, I told you, I can show you here. Cautery. Give me cautery. Oh. Quick. See, this is the carotid. नहीं चल रहा है. This carotid, as it runs, see this external carotid. See this external carotid? Going here up, and it gives branches. We have seen the occipital. Now here, it divides into two branches.
Facial temporal and
Yes.
Superficial.
internal maxillary.
This branch, see, retract like this. This is the branch which is it is short. This is the posterior auricular. I'll show from this side. Okay. This vessel is the posterior auricular. ये दिखाना.
A little bit of focusing is needed.
I'm centering
Go
also.
ahead.
Sir. Please center
Also,
the
picture
picture.
has
Latex.
to be centered.
Just a moment, I'll reorient you.
Thank you, sir.
No time, I'll reorient you again.
Yes, sir. Thank you.
Say this. Yes. This is the posterior auricular artery, which I have divided. And this carotid artery now is dividing into two branches. See this upper one going as a superficial temporal and this one going
IMAX.
behind the mandible. This is the mandible border.
Yes.
See, this is the border of the mandible. See this bone?
Yes, sir.
Yes, sir.
The other one going deep to the mandible. That is the maxillary artery, which
Yes.
is going deep to the mandible here. The maxillary artery goes deep to the mandible there. See this mandible?
Yes, sir.
And in this, I told you, we remove the parotid. Parotid is here anteriorly. This is the condyle. This condyle has to be removed and the cut would be here, just underneath the condyle over the ramus. So parotid, condyle, this is the external carotid. This is giving the superficial temporal and the maxillary artery going deeper. See this maxillary artery. This maxillary artery going deep to the neck of the mandible. Can you see anteriorly?
Yes, sir.
And here it gives off a superior branch we will see later at the middle meningeal artery going into the foramen spinosum above. So this is anterior separation. Now we have seen the external carotid. Now where is the internal carotid? In no time you can follow the internal carotid, which is again a very, very important anatomy as we have to follow and preserve this.
Opposite C3, C4 vertebra.
Pardon?
Opposite cervical C3, C4 vertebra junction.
Opposite? I didn't get
C3,
what?
C4 vertebra, cervical vertebra, sir.
So? Hello?
He means you can find it opposite C3, C2.
C3, C4.
3, C4.
Okay, the bifurcation.
Yes, sir.
You mean to say the bifurcation of the
Yes, sir.
carotid? Yes, this is there. Opposite the C3, C4, you can say the bifurcation is there. See, this is the internal carotid here.
Yes.
That was the external carotid.
Very nice.
And here is the jugular, it is collapsed. This temporal bone, this is the jugular foramen here. And this temporal bone has only this bone holding the jugular foramen from behind. So we have to separate from the jugular foramen behind. See, the jugular foramen is here. It was unavoidable.
Yes, sir.
If I elevate this, see, the bone is already, see, the brain is already. So we have to see here some of the important. Give me suction to suck the brain. Doesn't matter. See this brain, Dr. Madhu.
Yes, sir.
See this brain. We have no option but to suck it out. See this? Now there are when you come from the middle fossa side.
Sir, can you show the arcuate eminence, sir?
Yes, that's what I'm coming to.
Yes.
When you come from the middle fossa side, there are certain anatomy you intend to look at before going deeper. One is the arcuate eminence and other is the GSPN.
Yes.
Now, these are two anatomies which orient us from the rest of the structures. So this was the intradural, suction periosteum there.
Yeah.
Now I elevate the dura. See the dura is intact here?
Yes, sir. Yes.
Pakadna, sir, pakadna. Dura is tightly adherent. See this?
Yes, sir.
Because already punctured, so it is so difficult now.
Sir, we have one request.
Yeah, please.
What time we are going to, audience wants to know when are you starting anterior skull base dissections?
Yeah.
After this,
You want the anterior skull base dissection now?
no, just want to know, audience wants to know what time you are starting.
Yeah, after this. Wait.
Yes,
sir. In live situation also, the dura is adherent like this, sir.
Dura.
Yes, sir. Yes, sir.
Oh, adherent, my God.
In live situation, sir, it is adherent like this?
No, 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 no.
No. That is
Actually, during craniotomy, it was adherent, so it was torn.
Sir.
That was inevitable. And this should be elevated from posterior to anterior to preserve the GSPN sometimes, otherwise the GSPN may get injured. This looks like the arcuate eminence here.
Sir, before performing, are we draining the CSF, sir?
Pardon?
Are we draining the CSF before, or because we are going to
No.
retrieve the
This is
temporal lobe?
purely extradural approach.
Okay.
Don't need to drain the CSF or anything.
Okay.
See this, I'm just elevating the dura.
Okay, sir.
This is the eminence which can correspond to the arcuate eminence. And see, this is anteriorly. Can you see some vessel coming from inside?
Yes,
coming
sir.
inside from outside? Can you see this?
Yeah.
This is middle meningeal artery. I told you it enters.
First branch of
I told
macular
you, I had shown you on the skull, the
Yes,
middle
sir.
meningeal
Yes.
artery, foramen oval, all those
Yes.
structures cross the carotid artery.
Yes, sir.
Remember?
Yes, sir.
Hello?
Yes, sir.
Yes, sir.
Yeah.
All those structures cross the carotid artery.
Yeah.
Here, this is middle meningeal artery here.
Yes, sir.
I am going further anterior.
It is extradural, sir. Middle meningeal artery.
Yeah.
If you go further anterior, you will see the V3. Oh my God. It's all autolyzed. See, the brain is all autolyzed.
It's all autolyzed.
Not good to show here. Brain is all autolyzed. An intact structure, the brain, would help us showing the structures better. Hello?
Yes, sir. Yes.
But you see the brain is autolyzed?
Yes,
Yeah.
sir.
Yes. Yes.
What I can see in the floor,
Yeah.
in the middle meningeal artery and the V3 here. I'm quite anterior. This is the V3 here.
Yes, sir. Yes.
See this?
Yeah.
Yes, sir.
That's the nerve. This is V3. This is the venous plexus.
Yes,
Huge
sir.
venous plexus around the V3.
Yeah.
It is always surrounded by the huge venous plexus, the trigeminal branches. See this?
Yes, sir.
So this is middle meningeal.
Yeah.
These are trigeminal branches. Not good a picture. See this? This is the biggest of the nerve in this region.
Yes.
See the trigeminal nerve?
Yes, sir.
Yeah.
Yes.
I am elevating
Yes, sir.
at the petrous apex. Here is the petrous apex region where this trigeminal is crossing this trigeminal. And underneath the trigeminal nerve, I had shown on the skull, if you remember, is the carotid artery. See the carotid artery. Here is the carotid artery.
Yes,
Yeah.
sir.
Yes.
That's the carotid artery.
Yeah.
That's the horizontal petrous carotid. It is crossed by the middle meningeal here.
Yes, sir.
That you have to sacrifice, crossed by the V3 here.
Yes, sir.
In infratemporal fossa approaches, you have to sacrifice this V3.
Yes. So that is the area of Kawasi triangle, sir. Is it?
Kawase triangle is not exactly this.
Yeah.
Kawase triangle is the area
Yeah.
between this carotid artery
Yes.
and the intracaustic meatus here behind.
Okay. Okay, sir.
See, behind this carotid,
Yes, sir.
this is the rhomboid bone.
Yeah.
Here is going to be the facial nerve and the internal acoustic meatus.
Yeah.
That's a pure neurosurgical approach by the subtemporal approach.
Yes,
They
sir.
elevate the middle cranial fossa,
Yeah.
like I've elevated,
Yeah.
and defining the carotid and the cochlea and the intra-aortic meatus behind.
Yes.
In between them, they drill away.
Yes.
That is the Kawasai's approach.
Yes.
That is the open approach. This is the Petrus ridge, which I am retracting.
Yes, sir.
And that's a narrow approach. You see, this bone, entire bone is drilled away to reach to the posterior canal fossa from
Yes,
the
sir.
middle canal fossa. That is what the Kawasai's approach is. So
Yes,
you
sir.
can reach the anterior part of the brain stem by
Yeah.
this Kawasai's approach. That's the Petrus ridge.
Yes.
See, this is the Petrus ridge. This is behind the posterior canal fossa here.
Yeah.
And this is the middle canal fossa. That's the carotid artery.
Can we identify superior petrosal sinus here, sir? Is it?
Superior petrosal sinus is right at this Petrus ridge here.
Yes.
The bluish one is the superior petrosal sinus here.
Yes, sir. Yes. Yeah.
That runs on the Petrus. See, this is superior petrosal
Yes.
sinus.
Yes, sir.
Running
Yes.
on the Petrus ridge.
Yeah.
If I drill this will require long drilling.
Okay, sir.
I think time is the constant is the big issue. This is here where my instrument is going to be the intra-aortic meatus.
Yeah.
This is going to be the region of the intra-aortic meatus.
Yes, sir.
And if I drill this thick bone, you will see the 7th, 8th nerve complex.
Yeah.
And then between this 7th, 8th nerve complex and the carotid artery here,
Yes, sir.
if you drill away this bone, you can reach the brain anterior part of the brain stem. If Dr. Madhu is there.
Yes.
Okay, left over
Sir,
there.
this requires some degree of temporal lobe retraction.
Yeah,
What is
a
the-
lot of
what is-
temporal bone retract. That's
Yeah, what is the
disadvantage
retraction?
of this approach.
Yeah.
That's why this approach is not designed for elderly people.
Yes,
Where
sir.
the dura is too flimsy.
Yes, sir. Yes.
See this? This is the Petrus ridge. Can you see the superior edge of the Petrus bone?
Yes. Yes. Yes,
This is
sir.
the superior petrosal sinus.
That's
and behind this is the tentorium.
Yeah.
And behind that, see this?
Yeah,
Behind that is the posterior canal fossa. Here. Here is the posterior canal fossa. Here.
Almost towards the CP angle, sir. That's
Yeah. That is the posterior canal fossa.
yeah.
All these are the posterior canal fossa neurovascular structure if you see.
Yes.
See that? So
Yes, sir. Very
the goal is, the biggest task is to drill away this bone.
Okay.
I think this will take long, otherwise we will not be able to do the endoscopic dissection. The concern is the endoscopic dissection. Can you see this?
Yes, sir. Yes.
I was coming from anterior to posterior. Now, this is your GSPN here.
Yes, sir. Yes.
This is your GSPN. If I follow this, I can follow the...
Little bit focus is required, sir.
See
Focus.
this? This is the GSPN emerging out. If I follow
Yes,
it, I can find the facial nerve in the middle ear and then follow the labyrinthine segment and the intracaustic meatus down here.
Yes.
So once you see the intracaustic meatus, this entire bone can be removed.
Yes.
So one cannot be this bone removal, one from here all around. Anteriorly, we have already elevated the TM joint and all that. This is the sigmoid sinus behind. See this?
Yes, sir. Yes.
Leaving the sigmoid sinus, if you elevate this bone, after drilling this bone, this entire temporal bone can come out.
Oh,
Yes.
my God.
Sir, I have a question.
Yes, please.
Sir, when we are doing this procedure, they say theoretically, some important veins like vein of Labe, vein of Trollant.
Vein of Labe is a different vein. See, can you see on surface of the temporal lobe here?
Yes, sir.
Yes,
Yes.
sir.
This is vein of Labe.
Okay.
Vein of Labe is an anastomotic vein.
Yes, sir.
Superior petrosal sinus and
It traverses through the temporal lobe, through the sylvian fissure. All that. This is nowhere coming in this way. See, this last cut would be on the zygoma here till the carotid artery here. This entire bone has to be disarticulated. This already disarticulated, and then you remove this part of the temporal bone out. This is the extensiveness of this procedure I was showing just quickly so that we can show the endoscopic dissection further. Can you, if you got the idea, how all around the temporal bone we have to go and remove it completely. Okay?
Yes, sir. Yes.
So do we go ahead further with some other procedure?
Yes, sir. Please.
See this broad view, this temporal bone.
Yes, sir.
This has to be separated from above.
Can you
This
show?
bone has to be.
Sir, can you please show it under low magnification, sir, so that we can have a aerial?
This is lowest. This is lowest in the microscope, sir.
Okay, sir. Thank you.
Just quickly, just to give you, this is the temporal bone. This is the external acoustic meatus.
Yes, sir.
This is the zygoma.
Yes.
This is the TM joint we have already separated. See this?
Yes, sir. Yeah.
We have to make a cut over the zygoma right to the carotid artery we have seen below.
Yes. Yes.
And then would be the infratemporal fossa. We can remove the cut from the infratemporal fossa from here under vision. One.
Yes.
Second is this at the rhomboid space, the anterior petrosectomy.
Yeah.
See this bone you have to drill.
Yes, sir.
To separate. Third would be, this is the sigmoid sinus. You have to remove this bone till the jugular bulb here. This bone has to be removed and this entire bone can be taken out.
Okay.
This entire bone will come and block. That is the goal of en bloc resection. Just to give you an idea of the extensiveness of this procedure. So you can carry out. But since it will take long, so I am not going further at this stage. Okay?
Thank you, sir. Thank you. We could able to see the temporal bone from multiple perspectives. We could able to appreciate the temporal bone from multiple superior view, middle cranial fossa view. Thank you very much. It's an excellent.
Yeah. Now coming to the previous side, temporal bone, before moving to the endoscopic, a couple of things people ask just to throw a light. How is the jugular bulb and all that? Just to reorient you with the previous dissection.
Yes, sir. We got.
Remember that cochlear dissection?
Yes.
If you remember, in the same specimen on the opposite side we did in the morning.
Yes, sir. Right
this
side.
was the cochlear dissected. This is carotid artery. This is jugular vein.
Yes.
Okay, this is tympanic bone.
Focus.
Now,
focus. Sir, please focus.
Not focused now.
Not focused. Little bit of fine focusing required.
Yeah, quick. So I will just
Yes,
take you to the jugular foramen and some important areas before we go further. Better?
Yes, sir. Yes. Now clear.
Just reorienting you. This is the mastoid tip here.
Yeah.
This is tympanic bone. This is the jugular bulb.
Yes,
and
sir.
this is the carotid artery.
Yes, sir.
So from here, quickly. See, this is the stylomastoid foramen here. Here where the facial now comes out.
Yes, sir.
See the facial now below. See this facial now.
Yes, sir.
Partners. This facial now from here ascends in the parotid. This is the styloid process. See this styloid process here. It is deep to the facial now. This facial now is here. The styloid is here. Can you see?
Yes, sir.
And this is the facial now. So this facial now, if you trace, are you oriented?
Yes, sir. Yes,
This
sir.
is the facial now out of the stylomastoid foramen. See this?
Yes.
Ascending into the parotid. See this facial now ascending in the parotid.
Yes, sir.
That's the facial now. Okay? That's the facial now. Stump here. It was probably cut here. That's the facial now stump here in the parotid. Can you see here? That's the facial now and the bifurcation.
Yes.
See this?
Yes.
I don't know when it was cut. That's the facial now. And this is the facial now emerging from there.
Yes,
that
sir.
was the cut section. Yes. See this facial now.
Yes,
Yes,
sir.
sir.
Now, this is the styloid process. What I am, isko pakadna. Why I am showing this? I had shown in a model styloid is lateral to all the great vessels. Remember,
Yes, sir.
all carotid, jugular, styloid is always lateral to them. चल क्यों नहीं रहा है? बहुत धीरे चलती है. टाइम नहीं है इतना.
फुल करना, कोर्ट बढ़ाना भाई.
टाइम नहीं है इतना भाई. See, I'm just quickly entering into the neck here to show you the relationship of the styloid. I am in the neck here. See, I am in the neck. And this is the styloid. See this styloid?
Yes, sir. Yes.
Yes, sir.
Along with the muscles over it. See this styloid? I am separating. See the styloid tip?
Yes, sir.
Sir.
Remove. Once you remove the styloid, all the critical structures are in the depth.
Yes.
Just in no time to finish it quickly. Retract. Now, once you remove the styloid, there are the deeper structures. Quick. Hello?
Yes, sir.
Yes,
Yes.
sir.
Very well.
That's again the transverse process. See this?
Yes, sir. Transverse process of
That's the same
Atlas.
we saw on the opposite side. There, वो हट गया था. चिपका. Just want to show you the jugular foramen and its relationship quickly. Quick. Retract. Yes. Give me more nibbler. Hello?
Yes, sir.
sir.
Now, see, this is temporal bone here.
Yes,
and
sir.
this is neck.
Yes, sir.
What was separating these two were the tympanic bone and the styloid, which
Yes,
we
sir.
have removed. So now this temporal bone and neck comes one structure. And deep to this is the jugular foramen. Now, uncovering the jugular foramen in a minute.
Yes, sir.
See, quickly removing, little crude,
Yeah.
but no way but to go. Can you see the jugular
Yes.
Yes, sir.
vein?
Yeah, yeah.
Yes, sir.
And this is leading to the jugular foramen. No, they're not quadri. In
That's
no
the
time, I am opening
occipital
this.
artery, sir.
यार वो देखो हिल गया.
पकड़ो भाई प्लेट को.
पकड़ो. Can you see the IJV?
Yes, sir.
Yes, sir.
And here is the jugular bulb. This is the jugular bulb.
Yeah. Yeah.
So in order to widen it open, see this why the sigmoid sinus forming the jugular bulb.
Yes, sir. Yes.
I am little faster here to show more.
Yes, sir.
I'm using bone nibbler. See the jugular bulb.
Yeah. Now it's very
So
clear.
here, this is a lot of latex inside. See this full of latex. Full of latex.
Yes, sir.
See, am I removing this latex? Can you see?
Oh, okay, sir.
This is the jugular foramen.
Yes, sir.
This is the jugular foramen. Can you see in the depth?
Yes, sir. Yes. That's a lateral wall is removed, sir.
Yeah, that's the jugular foramen. Quickly.
That is a jugular bulb area, sir.
Yeah, and see in the medial wall,
Yeah.
there are a number of openings.
Yes, sir.
Inferior pectoral sinus, sir. Where is it?
Yeah, these are openings of the inferior pectoral sinus anteriorly.
Yes, sir.
And the condylar vein posteriorly.
Sir.
See what happens. The blood from the brain, there's a significant, very big vessel to drain the blood from the brain.
Sir.
Coming to the jugular bulb and then going in the IJV in the neck to the heart. Here there are collateral channels in the medial wall for the alternate, transfer of the blood. Condylar vein are part of the vertebral venous system. So in case the sigmoid sinus is blocked, in case the jugular vein is blocked, this is affected, the venous return is affected. If you ligate the jugular vein, it doesn't affect much because the blood can pass through the vertebral canal system. If you ligate bilaterally the jugular vein, this is not going to affect much because we have an alternate connection of the blood venous drainage to the vertebral veins in the jugular bulb. But if you ligate the bilateral, jugular bulb, then it's a disaster and it will give rise to the, the blockage of the venous return from the blood and intracranial pressure, and the patient even may die. So ligation of the jugular vein is safe as compared to the ligation of the jugular bulb. This is carotid artery now. Can you see? Jugular
Yes,
one, cochlea, carotid artery. I hope you are oriented.
Yes, sir. Yes.
Now quickly, we have seen.
Even that bone separating the artery from vein is very clearly
Yes,
seen.
that bone is intact. See this bone?
That crotch. Yes, sir. Yes.
That crotch is lost in jugular paragangliomas.
Yes.
Now this artery has a very, very important course. See, this artery comes from the neck. We know.
Yeah.
This artery is coming from the neck. See this?
Yes, sir. Yes.
This is the vessel coming from the neck.
Yeah.
And here, this is vertical Petrus course here.
Yes, sir.
Then here is the genu. See, this is turning anteriorly.
Yes.
Can you see here?
Yes, sir. Yes.
This is turning anteriorly.
Artery
Here.
anteriorly, vein posterior.
And here is the, the middle fossa dura.
Yes, sir. Yes.
This vessel turns anteriorly. And this lateral bone is the greater wing of the sphenoid.
Yes, sir.
So if you follow this vessel's course anteriorly, you can see how this vessel, I had shown you the foramen lacerum and how it goes in the cavernous sinus. See this? This is the horizontal carotid which is turning laterally. Can you see very clear?
Yes, sir. Yes.
Now, give me the drill, quick.
Skull base anatomy is very difficult.
Pardon?
Skull base anatomy is very difficult, sir.
Hello?
Skull base anatomy is very difficult, sir. Lateral skull base.
Not difficult. We have to explore it and have a three-dimensional, orientation. Obviously, it is difficult, but once you get used to, this is very important in your surgical practice to understand. Now, this is the bone of the Eustachian tube. That's the bone of the Eustachian tube. See the Eustachian tube there. Give me a probe.
Hello?
See this carotid artery?
Yes,
and
sir.
lateral to the carotid is this Eustachian tube.
Yes,
sir.
See my instrument in the Eustachian tube here.
Yes, sir. Yes.
See this? Very clear?
Yes, sir.
That's the Eustachian tube. And that is the carotid turning anteriorly. Here, yeah. So here, if you follow the carotid anteriorly, it goes to the foramen lacerum, and from there it ascends in the cavernous sinus. And if you follow it further, you can explore how it is related to the, see this?
That's
It goes more and more deeper. See this?
yes.
Yes, sir. Yes.
That's the carotid artery going far anteriorly. So in infratemporal fossa B approach, that was the A. In B approach, you can, control the entire course of the carotid. You can go right up to the foramen lacerum and you can transpose this carotid artery anteriorly.
Yes.
If I elevate and transpose this carotid anteriorly,
Yes,
what
sir.
is there deep to it? Remember what I drilled. This was Peter's apex I was drilling.
Yeah.
The infracochlear approach.
Yes,
See
sir.
this? If I elevate, the entire bone of the Peter's apex and the clivus is exposed.
Clivus is, yes, sir.
See this?
Yes, sir.
The clivus Peter's apex is here and one can easily.
Sir, in the process,
this bone can be drilled now. This is the entire Peter's apex now.
Satish,
At
sir.
the Peter's apex behind is the cochlea.
This is paraclavian.
Yes.
This is horizontal Peter's carotid.
Yes, sir.
Yes, sir.
Horizontal Peter's carotid. So one can elevate and drill this. And this is the Peter's apex. See this cochlea we drill is right at the
Petrolingual ligament, sir. Petrolingual ligament is
yeah, this
Petro.
cochlea here
Yes.
is right at the Peter's apex, and here's the
Yes.
entire bone at the Peter's apex.
Yes.
So elevating the carotid, and you can see. So this is infratemporal fossa B,
Yes.
which controls the carotid artery. See, with both
Yes.
hands, both eyes, binocular
Wow.
vision, one can control the carotid artery all around. So
Sir.
this gives the best opportunity to remove the
Yes.
tumors all around the carotid artery.
Yes.
Infratemporal fossa B.
Yes.
See,
Sir,
I am going
any
little faster because of the time.
Yes. Sir.
sir, any risk of internal carotid artery undergoing spasm when we are handling the
Yeah, so you
artery
have
like
to,
this?
yeah. It is not handled like this. See,
Yes.
after the full exposure,
Yes,
you
sir.
can, pour some papaverine over it to prevent the spasm, number one.
Yes, sir.
And you have to work on the periosteum all around. See this?
Yes.
That's
Okay,
the
sir.
periosteum. Though this horizontal portion doesn't contain periosteum.
Yes, sir.
You have to be a little more cautious.
Yeah.
But once you get a plane in
Yes,
the
sir.
vertical portion, you can follow the plane and elevate. So
Yes.
this is the, the technique infratemporal fossa B, though this is, I am not the ideal one. In order to complete, I have to drill this complete and remove the TM joint. This is TM joint.
Yes,
If
sir.
I
Yes,
drill
sir.
this complete and separate the TM joint,
Yes,
I'll
sir.
be right at the, following the course of the carotid artery,
Yeah.
right in the sphenoid sinus. I can see everything.
Okay, sir.
Got my point? But
Yes,
that
sir.
will take time to drill away, which we cannot afford now. See this?
Yes, sir. There's a
Yeah. So this
vertical.
is the artery one can elevate. This the just giving you an idea
Yeah.
where one can elevate the artery.
Yes, sir.
The relationship, the close relationship of the vessels and the structure. This is vertical petrous, genu, horizontal petrous. Can you see?
Yeah,
Yes,
yeah.
sir.
That's the cochlea which we have drilled out, and that's the jugular bulb which we have seen just now. So this is the anatomy in this region,
Yeah.
which is very, very relevant to us in our practice. And this is the Eustachian tube here. That's the Eustachian tube
Yeah.
laterally.
Yes, sir.
In order to complete this type 2, I have to remove the TM joint and this greater wing of the sphenoid.
Yes.
And then we can follow it anteriorly, which I am skipping here, because we have to go to the
Yes.
endoscopic part. So when can we start endoscopic? You want me to show something else?
I think we are.
I rushed very fast.
That
Yes,
was
sir.
always, sir. We are.
you can show
Thank
the-
you.
Anything from the audience you want me to show here?
Anything sir, from audience? Oh, once.
Sir, what do you do when this paragangliomas are attached to the carotid wall, sir? Like
What?
medially? The paragangliomas which are adherent to the carotid wall medially.
Yeah,
What is your approach when you have
to
a
make a plane.
okay?
You have to make a subperiosteal plane following from below. Following from below means the carotid parapharyngeal is here.
Yes, sir.
As it enters the temporal bone, it is thickly covered by the periosteum.
Yes,
See here, at the
Yes, sir.
level of the carotid foramen, it is thickly covered by the periosteum. See here?
Yes, sir.
And then you have to, make a subperiosteal plane and then follow superiorly to follow and dissect the tumor. So tumor has a capacity to adhere to the periosteum. See this, like this.
Yes.
You have to develop the plane. See what I'm doing?
Yes, sir.
Can you see?
Yes, sir.
This is subperiosteal plane. Can you see?
Yes, sir. Yes, sir.
Here like this. You have to develop the plane and remove the tumor, which is adherent to the carotid artery. Any tumor adherent to the carotid artery, we must do the cross flow studies to, deal with any eventuality in case the vessel need to be sacrificed or injured. See this? See what I'm removing is periosteum.
Yes.
So while tumor removal, you have to go in this subperiosteal plane,
Yes.
Subperiosteal plane is required to dissect the tumor from all over. And this is possible till vertical segment. In the horizontal, the periosteal plane is lost. So in horizontal petrous carotid, you attach to it, you bipolarize and minimize the tumor which is attached rather than trying for the subperiosteal dissection.
Okay.
You call it a subperiosteal.
Pardon?
Subperiosteal plane?
Subperiosteal plane. See the carotid here at the skull base is covered by the thick periosteum. So you have to, I showed you the artery here. See like this, you have to develop a subperiosteal plane like this. Okay? And then you can, paragangliomas are mostly attached to the periosteum.
So do you dissect or stent such carotids like before you do dissection?
Pardon?
Do you prefer stenting of the carotids or before such dissection? Like
It depends upon the pre-operative studies. See, stenting is required once you have a tumor which has compressed the carotid. It has a huge vascularity coming from the carotid artery itself. Has a, the tumor has given kinking of the carotid, and the cross flow is not good. If the cross flow is good, you can sacrifice the vessel by means of balloon occlusion or whatever, coiling or whatever. But if the cross flow is not good, but then you are not left with any option than to keep the lumen intact by means of stenting. So
Sir,
cross flow studies are important to take the final call.
Delegates are asking, sir, antry skull base.
Pardon?
Most of the delegates are waiting for antry skull base.
Okay.
Eagerly waiting.
Yeah, so
Eagerly
now
waiting, sir. And they are.
I know the time
Sir.
is more endoscope. So much we have less time left for the endoscopic work, but we'll go.
Yes, sir. Yes, sir.
Sir, thank you very much, sir, for the lateral skull base dissection. It's an excellent demonstration. You could able to appreciate the temporal bone from multiple angles, from superior, lateral, basal view.
Wonderful demonstration, sir.
Thank you,
And
sir.
we are very thankful to Dr.
Sir.
Deepak sir also, sir, for excellent arrangements.
Hello.
Thank you, sir.
Endoscope.
While sir prepares for the anterior skull base, I'd like to request Dr. Rajendran Dinesh Kumar to come and announce the prizes for the postgraduate quiz. And I'll request Satish Jain sir to give the prizes to the postgraduates winners.
Thank you, Satish Jain, sir, for your demonstration. Today afternoon, we had conducted a PG quiz, a short quiz, and we have shortlisted 5 winners. We had a good number of participants. We would just call upon postgraduates to come on stage, and they will be awarded a prize.
Any idea? Time, sir. How much time we have? 2 hours.
So just we'll get things organized.
All fine. Yeah. This was too complex. I have to go fast.
All right, we will just announce the names. We would like the winners to come on stage. Dr. Lakshmi. Dr. Lakshmi. Dr. K.M. Biradar. Dr. Abhishek Singh. Dr. Suma. Dr. Shreya Prabhu. 5 winners. Please come forward. Just please be assembled there. The scores, Dr. Lakshmi, I don't want to embarrass, but there were positive and negative markings. I don't want to announce the scores, or it should be okay if I announce the scores. All right.
So you
We'll
can
just award the winners. That should be fine.
Dinesh.
Yes, sir.
You can tell their marks privately so that they will improve.
Yes, sir.
They
Sure,
will
sir.
know where they have gone wrong and they will
Noted,
improve.
JP, sir.
Yeah,
Noted,
that's
sir.
always
Thank you.
better. Yeah.
Yes, sir. Yes, sir.
Thank you. Thank you.
Certainly.
So these students are from which college?
What is your name, doctor? Dr. Suma. Please come forward. Okay. I'm sorry. Dr. Stuti also scored well, but being a consultant, we would just give an applause. Well done. Dr. Shruti happens to be doing her fellowship in facial aesthetics under Dr. Vishwas. Yeah, totally. Right. Can we have the winners on stage? We'll give up the mementos, right? Sir. Dr. Lakshmi. Dr. Lakshmi is here. Dr. K.M. Biradar. Dr. Abhishek Singh. Dr. Suma M.R. Dr. Shreya Prabhu. Dr. Lakshmi is here? Okay, fine. Dr. K.M. Biradar? Yeah. Dr. Abhishek Singh? He has not written any details. Dr. Suma M.R. Dr. Shreya Prabhu.
Should have said which college they are from.
Dr. Lakshmi, name not written. Dr. K.M. Biradar from Command Hospital. Abhishek Singh from Rajarajeshwari. Dr. Suma M.R. name not written. Dr. Shreya Prabhu, Rajarajeshwari Medical College. Thank you. That's it. Yeah. One is absent. I think they have left. I think. Yeah, they have left. I think. We'll. Yeah. Dr. Stuti gets a prize. Consolation prize. Thank you.
So meanwhile, if there are any questions to the audience who have joined online, or if there are any questions for the people here in the audience, please feel free to ask, because we are still preparing for the anterior skull base session and it'll take some time. We still have 2 hours left and we will keep up pace. That's what Satish sir has told us. Bhaskar?
Hello. Hello.
First of all,
Hello.
my name is Bhaskar. Thank you for the Trustwell Hospital giving an opportunity to participate in this scientific workshop. And it's our honor to invite the moderator to for a small felicitation. That I request Dr. Apparao sir, please come. And I request Vishwas sir to hand over the momentum for the Apparao sir. Yeah, he all three traveled from Andhra Pradesh to Vizag to here. Thank you, sir, for considering. And also I request Sharunamalli Patil sir. Sharunamalli Patil sir traveled from Bijapur. I request and I request Kumar Swami sir to please come. And also I request Shushen Dutt sir for moderating this workshop. Shushen Dutt sir. Also I request Parhalat sir, please do come. I request the audience to give a big round of applause. Thank you, sir.
Moderators, you can join. Go down there.
Hello, auditorium.
So quickly we'll show
Yes.
all the basic procedure first, and then whatever advance we can show in till 7 o'clock. Okay. This is the anatomy of the nasal cavity on this side with certain important structures in the lateral nasal wall. Lateral nasal wall is the area of interest for us. What we see inferiorly is the inferior turbinate, and this is the inferior meatus. In the roof of the inferior meatus, here is the opening of the nasolacrimal system. Here at the anteriormost part of the roof, see that part which is mobile.
Yeah.
That is where the nasolacrimal duct opens to the wall of Hessner's. Then this is the middle turbinate, and there are lots of prominences and depressions in the middle meatus. The most anterior one, the mobile one in the uncinate process.
Yes.
Then the bulla ethmodalis, then this turbinate goes up.
Yes.
So quickly, let me show you the sinus surgery steps.
Yes.
And also back. So in sinus surgery steps, the first step is uncinectomy.
Yeah.
In uncinectomy, there are many ways to do. Here I am going to show with the reverse biting. Engage your instrument in this hiatus. Hiatus is what? Between the uncinate and the bulla ethmodalis, this two-dimensional space. Engage your instrument in the hiatus, turn little down to stay away from the nasolacrimal duct, and keep coming anteriorly, biting through. Keep coming anteriorly. Till you reach the hard bone. See here, hard bone anteriorly is what? This is the prominence of the nasolacrimal duct, which we are not supposed to bite through.
Yeah.
Now, this is the lower part of the uncinate. 40. See this? And what I've opened is the maxillary sinus.
Yes.
Can you see?
Yes, yes.
That's the maxillary. I'm going quickly at this point. We have discussed in various webinars again and again. Pedal. Give me the pedal, micro debrider pedal.
Any tips and about the debrider uses and
Pardon?
Debrider uses and precautions.
Debrider is a useful tool. It has to be used the cutting edges, keeping under vision.
Under vision. Okay.
Funny though. Boss, can you give me this? ये दो ना ये. हाँ, रख दो. नहीं चल रहा. Debrider. Debrider not working. Yes. Hello.
Yes, yes.
See this?
Yeah.
I am debriding this lower part of the uncinate. We always keep the cutting edges under vision.
Yes.
To make it safer. This
is oscillation mode. No?
See, this is the uncinate bone. सोचने की बात ही नहीं है. Best तो लगाना यार.
I think suction is not that effective.
See the uncinate bone?
Yes, sir.
One can remove and widen this middle meatus. This is the first simple step at this stage. This is middle meatal antrostomy. You can see, you can widen according to the needs. There's nothing hard and fast. In a massive disease, you can widen it further. Okay?
Yes, yes.
This is middle meatal antrostomy card. Give me the brider again.
Okay, M2
Hello?
Yes, yes.
At this point, this upper part of the uncinate is a very, very important structure.
Yeah.
Quick.
M2 दे दे भाई.
1 minute भाई.
रिमूव कर दो, M2 को कनेक्ट कर दो। सारे M2 कनेक्ट कर दो। M2 कनेक्टेड है, M5 यूज कर रहे थे। M2 थोड़ा सा एंट्री का है। एंट्री दे दिया ना आपको। तो ये तो है एंट्री। चालू। Hello. Now, so the equipments were being set up. So this was the middle metal anthrostomy required for this patient. The initial, this was the, the blade was not cutting earlier. It changed to, anyway, this is the upper part of the uncinate.
Yes, yes.
This is a very, very important anatomy at the beginning of the procedure. While doing the upper uncinectomy, if you go carefully and see in the lateral relationship, see this? I'm going behind and fracturing it out.
Yes.
The immediate lateral relationship of this uncinate is what? The lamina pepracia. Very early in the course of the dissection or the surgery, you reach your lateral limit. See this? Fracture it anteriorly, section नहीं चल रहा है, नहीं काम कर रहा. See, that's the uncinate plate of the bone.
Yes, yes.
I'm waiting for the section. दूसरा लगा दे. बेकार है.
Sir,
At this point of time, one must ascertain your lateral limit.
yes, sir.
This is very important point for your orientation. See now, at this point, I am going to show you my lateral limit.
Yes. Sir, please fast
This
and
is the
deep.
lamina pepracia. Can
Yes,
you
sir.
see?
Yes, sir. Yes.
This is the lamina pepracia. See here.
Yes, sir.
Can you see this
Sir.
bone?
Yes, sir. Very big.
This, at the beginning of the surgery,
Yes, sir.
one can reach the lateral limit of the entire dissection.
Yes, sir.
Now I am going up and skeletonizing the axilla.
Yes.
See this axilla?
Yes, sir.
I am going to show you a very, very simplified approach for the frontal sinus.
Yes, sir.
For all junior guys, whoever is finding difficulty
Yes.
in frontal sinus,
Yeah.
I am going to show you the very, very simple approach today. See this, all upper uncinate being removed.
Yes.
And open the axilla till limit. Limit is what? This bone. See this?
Yeah.
Frontal process of maxilla. 70. This is the time. See this with the 0 degree.
Yeah.
Remove, then a middle metal anterosmy is removed till lamina laterally. The uncinate process. And above is the agarnage cell. See?
Yes.
This uncinate goes to the medial wall of the agarnage. See that?
Yes, sir.
And this space medial to the uncinate attachment is the space for frontal sinus drainage pathway.
This is otherwise called intact bulla techniques.
Yeah, still the bulla is intact. Intact bulla
Yes.
is a good proposition to
Yes.
protect your posterior structures. Like many a time we
Yes.
discuss about many a time we discuss about antithyroidal artery and all that.
Yes.
Intact
Yes.
bulla is a technique. I'll show you the reason why intact
Yes.
bulla as we go behind.
Yes.
Now I change to 70 degree to show you something.
Wonderful. Sir.
See this?
Yes, sir.
Ejaculate. See this? 70 degrees showing you the anatomy in this region to enter into the frontal sinus safely. See, this is the beak.
Yes,
If
sir.
you follow the beak forms the floor of the frontal sinus. See this? I
Yes.
told you this is the agarnage and this
Yes.
is the frontal sinus attachment. And if you follow the beak at this spot, and go underneath the beak. It cannot go anywhere else than the frontal sinus. Simple.
Was.
Find the axilla. See the lateral limit. See the medial limit turbinate. This beak has to be skeletonized. See this beak?
Yes, sir.
If you follow the beak and go underneath the beak, you cannot go anywhere else than the frontal sinus. See my frontal opening?
Yes, sir.
This beak forms the floor as well as the anterior wall of the frontal sinus. Not cutting.
Yes.
Instrument. Can you see my frontal sinus?
Yes, sir.
See the scallopings. See this.
Yes, sir.
See the frontal sinus, the suprabular cell. Can you see that?
Yes.
The bulla was going till here. See this. The cellularity in this region sometimes complicates the situation a lot. See the anterothoracic artery here.
Yes,
The
sir.
bulla was attached to the here to the skull base.
Yes.
Yes.
This is the suprabular recess. And since this suprabular recess many a times is over pneumatized to give variety of, situations there. If this suprabular recess, this pneumatization extend above into the frontal sinus, that is frontobular cell. This if pneumatizes above and lateral to the orbit, that is supraorbital pneumatization. So variety of pneumatization of the suprabular recess can be seen, which can complicate. Okay? And this is always of the suprabular recess.
Yes.
This is the anterothoracic artery. See this?
Yes.
If there is supraorbital pneumatization, the anterothoracic artery is pushed behind.
Hello?
So the frontal sinus, suprabular, anterothoracic artery, it is very, very clear. Now,
Yes, sir.
why we had to use the 70 degree for the frontal sinus? Yes, sir.
Sir, do we require any special instruments apart from 70 degree and a RAD 120 blade? Any other forceps or any curettes do we require to open the frontal sinus in a normal scenario?
Sinus, yes. A lot of long instruments are required, namely the
Frontal
side
muscle.
punches of the frontal sinus, curved
sir.
side punches,
Okay.
articulated punch.
Okay.
Then you need the long curved malleable suction sometimes to flush and suck the various parts of the frontal sinus. So frontal sinus needs some specialized instruments, to work in the depth at this angle. Okay?
Yes,
now,
sir.
why we had to choose the 70 degree for frontal sinus? See where it is located. What is the obstacle with the 0 degree? If you see with the 0 degree like this, we are not able to see frontal sinus. What is this? This is the beak. So beak forms the anterior wall. See the frontal is behind?
Yes, sir.
At the same time, beak forms the floor as well. See this?
Yes, sir.
If this beak is removed, your frontal sinus axis would be head on. What my point?
Yes, sir.
That's what I wanted to show you. Just ask me about the
very
draft
clear.
procedures.
Yes, sir.
See now. Now my work would be with the 0 degree now. See head on axis now. 0 degree back.
Yes, sir.
And we are not able to see the frontal now. Can you see?
Yes, sir. Yes,
What
sir.
is the obstacle? This one.
Yes.
Frontal beak.
Sir, can we advocate to do this Caroline window or some kind of axillary flap technique routinely in all the patients? Or do we don't
Caroline
require to do it?
window, auxiliary flap are just, some shortcuts to enter the floor of the frontal sinus by biting through this bone, the overhanging bone of the beak.
Yes, sir.
Here the procedure I am going to show is the head-on approach to the frontal sinus in any given situation.
Yes, sir.
See this, I have elevated this flap over here.
Yes, sir.
It is much easier in live surgery. You can do this with a cobbletter in no time. See this bone I have exposed. Can you see?
Yes. Very clear, sir.
Draft is a very simple procedure if carried out properly, because the entire procedure is done with a 0 degree. See this flap being elevated. Can somebody hold the head? Can somebody hold the head, please? See this flap being elevated. Yes. And coming from anterior to posterior. Can you see this?
Yes. Yes, sir.
Only concern in this procedure is posteriorly. What is that?
First
The
olfactory
skull
neuron.
base. The skull base.
Yes.
So only concern in this draft posteriorly where you can give damage if not oriented is the skull base. Anteriorly it is safe, only the outside skin is there.
Medially, sir.
Pardon?
Medially, is there any chance to injure the cribriform plate?
What? I didn't get your question.
No, sir. No. When exploring the frontal sinus by a beginner, what are the chances of he injuring the skull base medially?
The skull base.
Yes,
yeah,
sir.
that's what I'm coming to. See what I'm doing? I made this inverted flap.
Yes, sir.
See this inverted flap?
Yes, sir. Very
I
clear.
made this entire area raw.
Yes.
Now I am coming from anterior to posterior to define my skull base.
Yes.
So our policy is always to define the skull base. See this first opening. Can you see this?
Yes, sir.
This is the branch of the anterothoidal neurovascular bundle.
Yes, sir.
This is not the skull base. This is not the olfactory neuron.
Sir.
See, the anterior most structure is what? This opening. This is the anterior ethmoidal neurovascular bundle. One of the branch of the anterior ethmoidal system, which I can cut. See this?
Yes, sir.
This is not the skull base. See this?
Yes,
branch
sir.
of the anterior ethmoidal artery.
Yes, sir.
Branch. Now, when you go behind, see this?
That is first olfactory tuft.
See medially.
Yes, sir.
Yeah. Yes. See medially now, that is the first olfactory neuron.
Yes.
Yes, very clear.
The medial one.
Yes, sir.
That is the beginning of the cribriform plate. Can you see?
Yes.
Yes, sir.
So if we come from anterior to posterior, this is the beginning of the olfactory, neuron. That's the beginning of the cribriform plate. See now here. So that is my area of concern. See, this is the anterothoidal artery.
Yes, sir.
This pierces the cribriform plate here anteriorly, here.
Yes, sir.
And that here is the cribriform plate in relationship.
Yes.
At the same level, you can see where the artery pierces at the same level is the cribriform plate. So this is going to my posterior limit. For my junior colleagues, believe me, this is the simplest of the procedure if you carry out and the safest of the procedure in the skull base here. This draft, what I'm doing, I'm showing is a regular draft 2. If you combine the draft 2 on both sides with removal of the intersinus septum and upper part of the septum, it is draft 3 or modified endoscopic Lothropes. So here,
yes, sir.
And I told you, this is the bone which I have uncovered. This bone is something which is prohibiting our visualization of the frontal sinus coming in the way.
Yes, sir.
Look. Yeah. This bone is coming in the way to the frontal sinus. Yeah. And I am going to remove this bone head on. So what I'll do, I'll start. I'm using my high-speed drill. See, I'm starting from below the level of the axilla and defining my lateral limit.
Skin.
Yeah. My lateral limit is what? Skin. See this?
Yes,
Again, started below the level of the axilla. Can you see?
Yes, sir.
The beauty of this drill is the shaft doesn't come in the view.
Yes, sir.
Yes.
And define first lateral limit. See, I'm defining my lateral limit first.
This is a zomed intranasal drill, sir.
Pardon?
It is a zomed intranasal drill.
What is? Yeah, this is the geomet drill.
Yes, sir.
See this, I'm defining my lateral limit. Lateral limit will show the change of color. See the change of color?
Yes, we can.
That's the outside periosteum. Can you see?
Yeah. Yes, sir. Very
the
clear.
periosteum.
Movement also.
Yeah. So now I have ample of space to Go laterally safely. See this?
Yes, sir.
Yes, sir.
I have defined my lateral limit here.
Yes, yes.
Everybody watch carefully. This is a simple operation. If you do, see this. My lateral limit has come and I have seen with the change of color the periosteum. I can go till there without any problem. See this everywhere?
Yes.
Yes, sir.
Once you define this, you keep going anteriorly. Now see,
Yes.
Safe
this
zone.
was the obstacle.
Safe zone.
This was the obstacle
Yes.
to see the frontal sinus head on, which now I am removing.
Yes.
And in no time you will be able to see. I am using 0 degree only.
Yeah.
No time. See this drill is cutting like butter. This is diamond.
Yes.
Course cutting diamond.
In our live surgery, we finish this in 10 minutes. See, this is cutting like butter.
Yes.
Till you reach the anterior skin. Like outside skin,
Yes,
same
sir.
you follow the anterior skin. See this?
Super, sir. Excellent.
This is my lateral skin. See this?
Yes.
Follow this skin anteriorly. The same skin is coming anteriorly.
Sir, now at this point, are there any important structures that one can damage and create a complication here?
Not really,
No,
nothing.
no.
I have defined. Let me show you again.
Other than
Where I
buttonholing
don't
the
need
skin,
to
no
I will-
important structures here.
Yes, sir.
Yeah, see, my important
Yes,
structure is here. See this?
first olfactory neuron, yeah.
Yeah, I don't need to go behind that. Okay?
Anterior to that, you can remove anything and
Anterior
everything.
to that, I can play around like anything. See, I am removing everything anterior to that.
What are the chance of osteitis, post-op osteitis?
This used to be the big concern in the past.
Yeah.
You know, because of this nature of the eosinophilic disease.
Yeah.
Yes.
But nowadays, with the steroid irrigation in practice, this is unlikely. Uncommon nowadays.
Good.
See now the frontal sinus coming in picture.
Yes, sir.
Yes, sir. Very clear.
See more and more frontal sinus coming.
Yes.
See, no time we have been
Sir,
able
can
to see the
we
frontal
just remove
sinus
this?
head on. Can you see?
Sir, there is one basic question.
What is the ideal diameter or what is the measurement we expect?
Measurement of?
No, what is the size required for a proper drainage of the frontal sinus?
No, you have to go to the limits. No size
Yes.
concept works. You have to see now this entire frontal sinus
It's
coming
exactly
into the
like a
picture.
canal wall down mastoidectomy, Apana.
Yes,
You
Deepak
just
sir,
have no
exactly.
overhangs and no shelves.
There
Once
we
upon a
do-
time, all that theory of 9 mm anteroposterior and all was there.
Yes.
Give me the
Now it is no
debrider.
longer
See now
relevant.
with 0 degree debrider.
Yes, sir.
See now with the 0 degree.
Thank you, Deepak, for your answer.
Sir, suppose if you don't have a drill, can the same job can be done with a backbiting Rohingya, sir?
No, boss. This requires a good drill.
No, this bone is real hard bone.
This is a very
You can
hard
take
bone.
the autology drill with the modification that you can do,
Okay, sir.
which
Yeah,
our
but see,
Jyoti Ambrose she has got.
what we are showing is the state of the art.
Yeah.
But this Midas Rex is amazing. See the way,
See this?
the speed and
This
the
is
ease at
entire
which he has
frontal
done.
sinus coming head on.
Yeah.
Okay.
I'm going to show more and more further going anteriorly and give
This
the
is-
largest
So he
possible
is-
entry opening. Like
He
Appana
has
asked,
finished
what should be the
draft
size
2A.
largest possible?
Yes.
Sir, the
Sir.
drill what is being used is a Midas Rex one, sir.
Yes. Midas
Pardon?
Rex. MI6.
Sir, till
All
now,
right.
is it draft 2A, sir? This is draft 2A.
Draft 2A. This draft
Yes.
2A.
Yes.
See now.
When he
more-
combines both, it becomes draft 3.
Yes, sir.
Yeah. See this. My posterior limit. This is my turbinate.
Yes, sir.
Medial to the turbinate is the cribriform. And this is the beginning of the olfactory neuron. Can you see here? Posteriorly here.
Yes, sir.
Staying anterior to it, I can remove anything. And give a
Yes.
wider. See now, so far what I have done with the 0 degree. This entire procedure is done with 0 degree. And this is in the safest region. I did not come across any important structure. See, so far I did not come across any critical structure. My critical structure is here in my view, which I am not supposed to violate. Okay? Is everybody oriented?
Yes.
Now see, I am further removing this bone.
Yes, sir.
Keep removing, keep following the skin. See my skin?
Yes.
See, this is the skin. See, this is skin.
Yeah.
Keep following. This is your anterior limit.
Yes, sir.
See my anterior limit. See the frontal.
Superior limit, anterior limit, medial
Everywhere
limit.
is the skin.
Yeah.
See, everywhere is the skin as your last limit. Now I am
Hello.
turning medially. See this? See this cuts like butter.
Yes, yes.
That's the beauty of this
Oh.
drill.
Hello.
Yes.
See now going medially?
Yes,
Yes, sir.
And my limit. Every time you have to keep this olfactory neuron as your limit.
Yes.
In your view. You can remove all this bone anterior to it to give the widest possible anterior-posterior diameter. See this?
Sir.
See this?
That is opposite side.
Yeah.
That is
See
opposite
this?
side. Interfrontal sinus septum.
Yeah.
Interfrontal cell, Satish?
Yeah. See this? Widest possible opening one can think of.
Yes.
Drill is amazing, sir.
I hope everybody in the audience can do this procedure safely. There's
Sir,
nothing.
can you ask the external camera to focus the drill, sir, once?
Drill and Satish both are amazing.
Yeah. There is no challenge for you, Deepak sir. Deepak sir, you have done so many hundreds.
No.
No challenge. See the
Amazing
frontal sinus
work.
from inside.
Yes, sir.
The frontal sinus.
Hello.
Yes, sir.
Hello.
Yes. Hello.
See the frontal.
Hello.
You can further widen if you want.
Yes,
Till
sir.
the skin. Till the skin. Now let me give you modifications and
Yes.
their indications we have been doing in our practice. See, this is the frontal now. Okay? This is regular draft 2. Now,
Sir. Hello.
Hello. Hello.
let me know when they come in.
Hello.
Let me know. Let me know when auditorium is connected.
Auditorium.
Hello.
I want to show some important variations.
Yeah, we are connected, boss.
Yes, boss, sir.
Yes.
See, this is draft 2.
Yes,
Yeah.
sir.
Suppose we have to work far laterally in the lateral part of the frontal sinus. And this approach is not giving you full access. What you can do?
Yeah.
With this draft 2. With this draft 2, you come from the opposite side. See the opposite nose. You come to the opposite nose.
Yes.
That is step 3.
You come to the opposite nose and do a septotomy and then work far laterally. See this? If I do a septotomy here and from that angle see into the frontal sinus, so that will be adding a septotomy to go far lateral would be modified hemilothrops. Okay? So in far lateral regions, you can add on this. Okay? Now, if at the same time you have a limited disease in the opposite side and you don't want to violate the opposite frontal recess, what you can do?
Mini lateral.
You open up the intersinus septum.
Beside this, remove the intersinus septum. Remove the intersinus septum and then allow the opposite frontal sinus to drain through this. That is called modified
Mini
Subtotal Lothrops. Okay.
Yes.
Now, I tell
Sir,
you one
please,
of the very, very important indications.
sir, please explain
Suppose,
again, sir. Hemi and total Lothrops.
pardon?
Please explain. Please explain again what is hemi and what is total Lothrops, sir.
The same concept, just repeat.
Okay. Do I repeat this?
Yes, yes. Point.
Yes, sir. Yes,
See,
sir.
let me tell you again. This is the regular draft to address the frontal sinus. Okay.
Yes.
Now, if I really want a more lateral access to, address some lateral pathology, I can do a septotomy here and come from the opposite side with a different view, angular view to far laterally.
Yes.
That is modified hemilothrop. Okay.
Yeah.
Along with
Okay,
that,
sir.
if I have a limited disease on the opposite side and want to drain without violating the opposite frontal recess, along with this, you can do intersinus septotomy and allow the opposite frontal sinus to drain through it.
Yes.
That is modified subtotal Lothrops. Then, very, very important indication. We have done many as we get revision cases. Suppose somebody did the sinus surgery on one side and happened to give fibrosis at the frontal recess, has given orbital fat prolapse and complicated the situation. And frontal sinusitis persisting. What you can do going back into the same field is very, very difficult in the fibrosis area. Got my point?
From opposite
If
side, we will have
opposite frontal sinus is normal, better go to opposite side, do a draft and do an intersinus septotomy to drain the diseased sinus into the normal side.
This
That
is mini
is modified
Mini
Lothrops.
Yes.
Okay? And suppose you have a disease not involving the frontal recess on either side and lying in the central part like encephalocele tumor or something, and you really don't want to violate the frontal recess on either side, just do the superior septotomy here and work in the midline without violating the frontal recess on both sides. That is modified central Lothrops. So variety of Lothrop procedures can be done. Another is if you have a disease in the orbit.
Yes.
If you have a disease in the orbit in the lateral part of the frontal, what you can do the orbital transposition. What is that? See this. See this. I fracture the lamina papracia and now I am elevating the periosteum. Can you see?
Yes, yes.
And if I keep removing this bone, I will be keep going laterally and laterally. The only thing is keep the periorbita intact.
Yes.
This is
That gives a
orbital
very good lateral
transposition.
access.
You can keep pushing the, keep pushing the periorbital laterally and keep going in the superior part of the orbit and the superior part of the frontal sinus like this. Keep pushing, keep going. That is orbital transposition, keeping the periorbita intact. So that is another useful variations. Many a time we have disease or frontal sinusitis or mucocele in the upper part of the orbit, not draining into the frontal sinus. Got my point?
Yeah.
So that is for that. You just keep elevating this periorbita, keep removing this bone after the draft, and you get, see this?
Yes.
You can keep removing this bone. See this? I can remove this entire bone. I am in the orbit. See this?
Yeah.
Yes, sir.
If I remove this bone, my orbital axis will increase like anything.
Yes, sir.
Can you show optic nerve decompression?
Optic nerve decompression you want me to show?
Yeah.
See this bone? Now I can punch. See this?
Yes.
Yes, sir.
I can easily punch, I can drill and keep pushing my periorbita. In live surgery, we keep, coagulating the periorbita so it doesn't fall back. This way you can keep going. See, now I'm going laterally and laterally
Yes,
to the
sir.
far most lateral areas and the superior part of the orbit. See this?
Yes.
See, this is the superior part of the orbit.
Yes, yes.
The principle is keep the periorbita intact, and you can go
Sir.
far laterally even into the pterion by
Sir.
keep removing the bone. Okay?
Yes, yes.
So these
Sir.
are the various variations of the
Sir,
draft
sir,
procedure.
if the frontal sinus pathology beyond the mid-pupillary line, what is the procedure of choice?
Yeah. So earlier was the concept that the frontal sinus pathologies can be addressed endoscopically or
Yes, sir.
cannot be addressed beyond the mid-pupillary line, going
Yes.
laterally. But now with the advancement in the surgical technique and these advanced procedure, we can go far laterally, even up to the level of the pterion endoscopically.
Yes, sir.
See, this is your orbit.
Yeah.
Yes, sir.
Now, Apparao asked about the optic nerve decompression. See, Apparao,
Yeah.
I remove this.
Anterethmoidal.
Anterethmoid artery.
See, that's the anterethmoidal artery emerging from the orbit, from the ophthalmic artery branch. See this running in the bone. And then it is piercing the cribriform plate. Such a beautiful anatomy here.
Yes.
Okay. Now, 0 degree on. Give me 0 degree. Let me do the post-sigmoidectomy quickly, straight, to show what Appa has asked about the optic nerve decompression. See, when you go behind in the sphenoid sinus, you have to exert some special care so as not to disorient and damage the structures behind.
You are doing a surgery without
Sir,
CT scan.
what is the maxillary line, sir, here?
ये नहीं लगा हुआ, ये चल रही है. Hello.
Yeah.
What is the maxillary line and its importance?
Satish.
Pardon?
He's asking about
Maxillary line and its
Okay.
importance.
Okay, sir. See, maxillary line is a terminology used for various references, but here, what you're asking in the reference you're asking, that is the level of the roof of the maxilla.
Yes, sir.
See this level of the roof of the maxilla?
Yes, yes.
This is a very useful landmark to protect our, avoid our disorientation while going behind. Let me show you. See, these are the anterethmoidal cells. I'm little going faster because of the time, so that we can show maximum possible. See now, while going behind, I am going in the post-sigmoid. See this? See, the question is, opening in the post-sigmoid, opening the sphenoid, you should not go above the level of the maxillary line. See the roof of the maxilla.
Very good.
See this. This is middle turbinate. As you go behind, we go inside the middle turbinate. See this. You make an opening in the middle turbinate. See this?
Yeah.
I am going behind. That is the septum there medially. Can you see the superior turbinate medially?
Yes,
Yes, sir.
And here I will go between the septum and the superior turbinate before doing the post-sigmoidectomy. See this here.
Yeah.
To open the sphenoid sinus, the best landmark is go along the septum. Go along the septum and not to go above the maxillary line. See my maxillary line? At this level. Can you see this?
Yes, sir.
This is the level of the roof of the maxilla.
Sir.
And I made this opening here. If I don't take this into consideration and happen to go above, little above is the skull base. Got my point?
Yes, sir.
So if you don't take the maxillary line in consideration,
Yes,
one
sir.
can get disoriented because
Yes.
this sphenoid sinus is never ostium is never close to the floor. It is
Yes.
close to the roof.
Yes, sir.
Suppose I don't take into consideration this maxillary line
వదిన మీద కోపం
Sir.
ఈ మన అమ్మాల మీద చూపిస్తున్నారు వీళ్ళు
and go above, I can easily
ముందు
destroy the
ప్రయాణించు
skull base.
ఇంతకన్నారు
See this, I can violate the skull base above.
Yes,
నాతో
sir.
మీ ఇద్దరు మాట్లాడుతున్నాం కదా
So once I have seen the sphenoid sinus,
వదిన
I
మీద
can remove
కోపం
the
అమ్మ
lower
మీద
part of
చూపిస్తున్నారు
the
వీళ్ళు
lower part of the superior
మాట్లాడుకుంటారు
turbinate.
మాట్లాడేస్తారు మాట్లాడకపోవడం
See this,
కొద్దిగా
I am removing the
దూరంగా
lower
చూడటం
part of the superior
చేస్తున్నారు
turbinate
Sir. Sir, Deepak
and,
sir, please
Kada.
ask someone to mute.
and completing this post-sigmoidectomy now.
Yes, yes.
Now having seen the ostium, Staying anterior to the ostium, I can excentrate all these cells without any fear.
Yes, sir.
Yeah. Now,
Deepak sir, some
staying
disturbance is
anterior to
going
the
on, sir.
sphenoid osteum, see this?
Yes, yes.
I can remove
బ్యాలెన్స్ అయిన
all the
ఎప్పుడు లేదు
cells.
కానీ ఏదో ఒక రెండు
Yes, sir.
కేసులు
This
అయి
is
ఉంటారు
my
కానీ
lamina.
వెళ్ళకపోవడం
This
ఉండదులే
is
రెండింటికి
anterothoidal artery.
Yes, sir.
This is posterior artery. You can see.
Yes, yes, sir.
Can you see?
Yes, sir.
Somebody is speaking
This
in
is
the background.
anterothoidal artery. This is posterior artery.
Very good.
This is sphenoid ostium.
Okay.
Yes, sir.
Widening the sphenoid sinus.
Somebody is speaking in the audience. Somebody is speaking in the
Sir,
background.
somebody is disturbing, sir.
Now, quickly, I'm going little faster. Let me know if I need to repeat anything, explain anything again. See this.
Hello.
Deepak sir,
Hello.
somebody is disturbing, sir.
Somebody is speaking in the background.
Somebody is disturbing, sir. Please.
Now, this is the interior of the
Sphenoids.
sphenoid sinus.
Yes, sir.
See this?
మా పేరెంట్స్ అలా నీకు అన్కోఆపరేటివ్ గా
I'm
ఉన్నారు
removing
కదా
this mucosa to show you something important. Yes. See this. Very important structures. This is the sphenoid sinus. This is the clival recess.
Yes.
Yes, sir.
Both sides, this is the carotid artery.
Optic
That is the optic nerve.
Yes, sir.
That is the
LOTS.
opticocarotid recess.
Yes.
And behind it, in the midline, is the sella.
Yes, sir.
ఏ ఫోటోలు
See, in the midline, this is the sella.
Yes, sir.
Can you see the sella?
Yes, sir.
This in the midline is the sella, and this is the prominence of the carotid artery.
Yes, sir.
This is the carotid which I referred there
Yeah.
during the dissection.
Yes, sir.
Here, see this? Can you see the prominence of the carotid artery?
Yes, sir.
About is the optic nerve, and what Appara was asking about the optic nerve decompression. Similarly, remove your lamina preparation. See that? Avoiding the removal of the lamina close to the frontal sinus ostium, that the fat may prolapse there and obliterate. So, just removing the lamina here. See this?
అంతే కదా
I'm doing little fast, so little crude, but this is what you can do. See the lamina.
Yeah.
Yes, sir.
Lamina. This is the posterior artery.
Yes, sir.
The best, landmark, if you ask me, for the posterior artery is a couple of millimeters anterior to the optic nerve.
Yes, sir.
Optic nerve is a more, bigger structure which is almost always visualized in the sphenoid, not
And
the anterior
constant-
artery, unless
Yes.
the skull base is very thin and the artery is
normal.
prominent. In this case, it is. This is a posterior artery. This is the anterior artery.
Yeah.
Yes.
And this posterior is see couple of millimeters anterior to the optic nerve.
Yes.
See this? This is the best landmark for the posterior artery.
Mm,
In relationship to the optic nerve. And now see here. This is the beginning of the optic nerve. See this?
Yeah. Bone is thick.
Yeah. If you really want to decompress it, then I drill.
Your drill.
Sir, where do you decompress
Simply,
it? Is it inframedially?
there
or
are various
superior?
ways to decompress the optic nerve, but you
Sir.
can thin out and then see this. I am thinning this bone and then
Yes.
slack off this bone rather than going all the way with the drill onto the nerve. Be careful, below is the carotid artery.
Yeah.
Sir.
And you can remove, let me remove this to show some more structure behind at this point of time. Let me know what else to be shown. And we have planned the dankers as well. Danker is one approach which I believe everybody should know.
Yeah.
Yes, sir.
Yeah, carotid artery I am showing.
Course of ICS.
Yeah, ICA course will show. Okay, let me show. आता नीचे कर.
It's like a live surgery, but hypotensive anesthesia.
See, I'm removing this bone to show you more and more.
Means, sir, this vary the ophthalmic artery, sir, in this canal, optic
Yes.
canal.
See now, this is your optic now.
Yes, sir.
Can you see?
Yes.
Yes, sir.
And this is the optic chiasma. This optic nerve is going in the intracranial part like this. Suction karna.
Sir, if you remove the keel, I think it will be easier, sir, for you.
What? The sphenoid keel?
Yeah, sir.
Yeah, we'll remove. See, this is the optic chiasma. That's the carotid artery. That's the sella. This carotid artery here. See this carotid here in the floor of the sphenoid here laterally. This emerges as the foramen lacerum.
Suction.
Crowd section.
The monopolar suction?
Yeah. See this. This carotid artery, here it emerges as the foramen lacerum. Then it has a vertical course. Okay? As it comes vertical, then it has a posterior band and come anterior. So it has a horizontal course. It has a horizontal course coming here anterior, and then is an anterior band, and this is the anterior band of the carotid artery. What you see here. Okay? So this is the periosteum, and this is I remove the periosteum. This is the carotid artery per se. That's the carotid artery.
Yes.
That's the carotid artery wall. This is the bone I can remove from the opticocarotid recess. That's the prominence of the carotid artery, and this is the optic nerve. And let me remove this bone after the dankers to show you some more anatomy here. So this is the basic face and some of the extended procedures like draft. You have seen the optic nerve decompression. I hope the picture is good there.
Yeah,
Very good, sir.
Yeah,
Very
and
good.
that was the first olfactory neuron. See,
Picture is
respect
very
this
good.
first olfactory neuron.
Yeah.
Excellent.
See the wide exposure of the frontal sinus.
Yes.
Excellent.
Can do anything to the frontal. This has enabled us, see this extended approaches enabled us to use this approach for many of the advanced lesions, including the tumors, CSF leaks. For anything now in the frontal sinus, endoscopy is the preferred approach.
Yes.
As simple as that. Now, this limits the lateral exposure and the lateral paramedian route. So quickly, to address the lateral, part, what I am going to do, I will do the dankers. So dankers, we must know, in the COVID times, probably everyone has done a lot of dankers. So dankers, basically the approach which open the paramedian highway. What you need to do is, you have to remove this medial wall of the maxilla as well as the part of the anterolateral wall. This was described initially long back by the dankers, by the sublabial route, and then it is modified now by the Stunman and Canfield by purely endoscopic, which I am going to show you. See this anyway. This is easier in the live surgery with the help of cobblator. It is much easier in the live surgery with the help of the cobblator. So simply, if I remove this medial wall, our obstacle to the paramedian access will be removed, and we can go paramedian. This is like a paramedian highway to address all the paramedian areas. See, first removing this mucoperiosteum.
What is prelacrimal approach,
Involve the
sir?
removal of the inferior turbinate also, which is a separate bone, along with the medial wall of the maxilla. See, the inferior turbinate also will be removed like this. See that inferior turbinate? बंद हो गया. So we'll remove the medial as well as the anterolateral wall. Anterolateral wall, you can go easily up to the infraorbital foramen. And if you want to go further beyond that, then you have to transpose the infraorbital foramen. Infraorbital now. See, this is the pyriform aperture.
Yes, yes.
This is the pyriform aperture.
What is prelacrimal approach, sir?
From there, I am going to the anterolateral wall. Can you see?
Yes, yes.
This is the anterolateral wall. I am elevating the periosteum. See, you can go easily up to the. See this neurovascular bundle. That is the infraorbital now. And flush with the floor. Flush everything with the floor. Periosteum, you look periosteum. Can you see the pyriform aperture all the way?
Yes, sir.
Hello?
Yes, sir. Yes, sir.
सिर पकड़वाने किसी को. This is the inferior turbinate mucoperiosteum. Can you see? It I am elevating. See, for the bone removal, everything this has to go. Now, retract this.
Sir, any chance of stenosis of
See,
the
this is the
nose?
anterolateral wall of the maxilla.
Yes,
Yes.
In cadaver, I am doing everything with a debrider to, because in live surgery, we do most of the thing with the cobblator.
So, sir, what is difference between Denkers and
Prelacrimal approach. Sir,
Now,
stenosis of
I
the
will
nasal
enter
vestibule, sir.
into the anterolateral wall. Let me show you.
Yes, sir.
My upper limit of this, removal of this bone, upper limit would be the roof of the maxilla or the floor of the orbit.
Yes,
Yes.
So, how to see this? You can ascertain by making an opening. Your sir pakadna yaar.
Sir, to save the time, use goose and hammer, sir.
नीचे से कर. See, I am entering into the maxillary sinus head on. Section to कर. Section. See, I am entering into the maxillary sinus head on. See this entry? Hello?
Yes, sir.
That's the maxillary sinus. And see how superiorly is the roof. Go to the level of the roof. See that?
Yes.
Yes, sir.
You can see the glimpse of the roof
NLD.
there.
NLD.
What a drill it is.
Wow.
You cannot do skull base without this.
What anesthesia, Satish? Anesthesia. No bleeding.
Little bit bleeding. See
Sir,
the
can you
level of the roof.
Yes,
Can you
yes.
see?
Yeah.
Laterally, depends upon the pathology, you can widen it. Huh?
Can I
Sir,
show
can
you
Supraruptal
Sir,
nerve.
Wash and section.
sir, can they show the
Wash and
outside
section.
camera of the drill, sir?
No.
Hello?
Lux.
Hello?
See the interior of the maxilla.
Yeah.
Yes, sir.
Yes, very
Can you
clear.
see?
Yes,
Yes.
sir.
Pardon?
Sir, can they show the
Pre-lacrimal.
drill, sir, from the external camera?
Pre-lacrimal approach is this one.
What are you talking, Sandeep? Yeah. See now, I have gone right,
Yes.
defining my roof. इधर करो मैं, इधर नहीं. See now, this bone I have thinned out.
Yes.
I can punch out.
Sir, can
Still
you
a
ask
little thicker,
the
but
drill,
still
sir? You want to see the drill, what you are using?
I can punch out. See now?
Yeah.
It's quite thick. Can you see the nasolacrimal duct now?
Yes.
This is the duct.
So in pre-lacrimal approach, we don't remove this bone,
I'm going
sir.
little faster with the punch.
Yes.
So
Hello,
we can show more procedures in less time.
Pre-lacrimal, we don't
See the
remove this
inferior
bone, sir.
turbinate,
Yeah, duct is
which has to
visible.
go. This is the nasolacrimal duct, everybody.
Yeah.
Yes, sir.
But I'm removing the bone all around the duct. To prevent the epiphora, once you ligate this duct, it should be done at the level of the
Floor.
orbital floor. Give me the debrider first. Let me show you. See this?
Yeah. Should be under.
What is this projection in the roof? Anybody?
Is it Haller
Anybody?
cells?
Yes, I had the glimpse.
Yes.
I heard something, somebody saying.
Ellerson?
Yes.
I told you,
Hit
sir.
this cell here. Here is the big cell.
Yes, sir.
See this cell?
Medial and lateral Haller
This
cells.
LR
Sir.
cell. See this?
Yes.
Yeah.
And the answer is remove the party wall with the maxillary sinus so that it start draining in the maxillary sinus.
Okay.
Blocked. See this? Now focusing on the
Where to cut the sac? No,
sac is above.
Okay, wait.
Dil, 1 minute ke liye.
Which instrument you use?
Pardon?
Any blade, 15 blade. For cutting the
duct.
Duct and sac.
Just wait for a minute, you will see.
Okay.
See, I am flushing the floor.
Yes, sir.
See the level of the floor?
Yeah.
This is the point. I am removing all bone around and flushing with the.
Okay.
This is the catch point. We have to cut it flush with the floor. If you leave it overhanging, it can get fibrosed.
Yes.
So cut, little pull and retract, pull and cut so that it retracts a millimeter or so inside.
Okay, I got it.
In the bony canal. That's it. Arey, kya scissor
For
kiya?
patency.
Yes, sir.
Yeah. See the nasolacrimal duct. See that? Now it is no more in our field. See this?
Yes, yes.
So further dankers, it doesn't come in our field. That was the Heller cell which we communicated. See this?
Yeah.
See, this is Heller cell.
Spinopaltar artery.
Yeah, I will show. See this Heller cell.
Yes, yes.
Such a big Heller cell. So I'm leaving inferiorly like this. Otherwise, it has to be flushed thoroughly.
There are two Haller cells, sir. Medial and lateral
Now,
Haller
this is the
cells, sir.
posterior wall. See this?
Yeah.
Yes, sir.
I'm elevating this, mucosa. elevating all this mucosa from the posterior wall. See this?
Yes.
This is the posterior wall of the maxilla. See the thin posterior wall. See the thin posterior wall. This is halar cell. See the halar cell?
Yes.
Completely marsupialized into the sinus. Can you see this prominence of the infraorbital nerve? Can you see this section? Now, where is this sphenopalatine foramen? Ye de wapas. Let me show you the sphenopalatine foramen and the area of this internal maxillary artery. See this, that is the middle turbinate posterior end.
Yes.
Let me show you something to orient you. This mucoperiosteum, which is after the bone removal, I am removing. See this mucoperiosteum and see something there. Can you see something?
Yeah.
Yes, sir.
See, in the vicinity of the attachment of the middle turbinate. See middle turbinate? Just close to it. Can you see this vessel?
Yes, sir.
This vessel?
Yes, sir.
This is sphenopalatine.
Yes, sir.
See this vessel. This is coming out here. See this? Now, if I remove this bone, you can see how this artery is coming out of the pterygopalatine fossa. This is a very important vessel, which is a area of interest in skull-base surgeries, JNS surgeries, in intractable epistaxis. We should be able to find and clip this vessel. See the posterior, this medial wall, I am flushing with the posterior wall. See this?
Yes, sir.
See this? And now this is the posterior wall, which is very thin, which I already partially fractured. See this?
Yes.
I'm going to remove this. See, more and more, more and more the pterygopalatine periosteum is exposed. See the pterygopalatine fossa periosteum here. After removal of this bone, I can remove some more bone, little more laterally.
You can use the ear canal knife, sir.
See some more bone I am removing.
Yes.
Yes. See this entire area behind is?
Yes.
Pterygopalatine fossa.
Is the infratemporal fossa. Here medially it is
No, no.
pterygopalatine fossa.
Yes, yes,
And immediately lateral to the lateral pterygoid plate is the
yes,
infratemporal fossa.
yes, sir. Yes.
So pterygopalatine is a narrow space. See in this, the architecture of structure in this fossa, most anteriorly the fat, then the plexus of
vessels.
internal maxillary. See this?
Next narrow.
Tortuous coarse plexus means variety of branches.
Yes.
This pterygopalatine fossa is like a crossroads. It communicates with the surrounding, cavities, fissures, foramen, and in every fissure and foramen, it gives off a branch. What is it? Branch from the nerve V2 or the sphenopalatine ganglion, and a branch from the artery, that is internal maxillary. So all foramina are traversed by some or other neurovascular structures. See this quick. Here medially, this is greater palatine artery. Can you see?
Yeah. Yes, sir.
This is tortuous imax. Let me remove some fat to show you some good structures. And see, this is the imax.
Yeah.
See this tortuous.
Yeah.
In JNA, you have to clip it thoroughly to prevent further bleeding. Give me. So let me remove this little bit of the fat and periosteum to skeletonize these structures. See, to orient you, this was the sinus surgery done.
Yes, sir.
This is the medial wall and the anterolateral wall of the maxilla removed. And we are right at the level of the pterygopalatine fossa.
Yes.
I hope you are oriented.
This is
Very much.
model, post model, and
Absolutely.
in a row.
See, I am just taking away this fat.
Which is Bechet's pad of fat, sir?
This is all infratemporal fossa fat, and then you'll see laterally the muscle.
Yes.
Just to show you something. Can you see the vertical muscle?
Yeah, yes, yes.
Yes, sir.
That is temporalis. That vertical muscle. And see,
Yes,
this
sir.
is the vessel.
Yeah.
Vessel and its network.
Yeah.
The huge network. See this?
Yeah.
Everywhere are the tortuous branches. Everywhere it is giving off branches. This one going down is the posterior superior alveolar artery. That is coming on the surface of the muscle behind. This vertical muscle is the temporalis. That's the lateral limit of the infratemporal fossa.
Yeah.
See this muscle? And here, see how this vessel is giving, this is greater palatine given off. And see how this vessel is coming out to the sphenopalatine foramen. Now see behind the vessels. Can you see some nerves?
Yes, yes.
Yes, sir.
See this?
Yes.
Bunch of nerves. Now let me remove some of the vessels. Once you remove the vessel, you'll see the nerves behind. See which nerve is this?
Maxillary.
There are group of nerves medially are the median, the principal nerve, laterally and above is the V2, which is the continuation of, see this. Can you see the V2?
Yes,
Yes,
Yeah.
Infraorbital nerve, can you see?
Yeah.
Yeah.
Above,
V2.
above, see here.
Yeah.
That's the infraorbital nerve.
Yes.
And here medially, let me follow whether it is a median nerve or what. See behind, let me show you something. Behind is a bone. Let me show you this bone. Can you see the bone behind?
Yes, sir.
Can you see this?
Yes.
Yes.
This
Yes.
is the pterygoid process.
Yes.
Yes.
This pterygoid has various foramens through which various neurovascular structures are connected.
So that is the pterygoid wedge, sir.
This is pterygoid wedge.
Yeah.
And see here, there are
That's
two nerves. The most medial one is the pharyngeal nerve, and this is the median nerve.
Median nerve.
Let me clear it.
Medially, median,
The
laterally.
medially is the pharyngeal,
Medial is
passing through
pharyngeal.
the palatovaginal canal. In this medial portion.
Yes, sir.
Give me the brighter. Can you see the foramen?
Yes, sir.
Hello?
Yes, sir.
Yeah, yeah.
So, yeah.
Very clear.
In this foramen, the nerve which is coming from out. See there behind? Can you see this?
Yes, sir.
That's the median nerve.
Yes.
And here medially is a thick nerve. See this? This is the pharyngeal nerve.
Yes.
Which runs between the part of the medial pterygoid plate and the sphenoid bone. See, this is pharyngeal nerve and this is median nerve. Now, following this above, see the same pterygoid process. Another opening. If you follow above, see this? Above, I am trying to follow. See this pterygoid process?
Yes, sir.
And follow this nerve. That's the V2 coming out of foramen rotundum. So, let me show you the V2. Yes. See this V2?
Yes.
Yeah.
Give me the brighter. See, this is the artery, which is the sphenopalatine artery.
Yes, sir.
Yeah.
So I am separating this. See this? The vessel coming in the way, I am removing. We have seen this. What I am trying to show is the posterior anatomy of the nerves.
Yes.
Satish, where is the sphenopalatine ganglion?
Now, yes. All this is gone. See now. Here is the median below.
Yes. Yes, sir.
See this? I had already shown that was the median. See this?
Yes, sir.
And this is above is the V2.
Yeah.
Yes.
That is the foramen.
Yes, sir.
See the foramen above.
Yes.
Can you see that foramen? That's the ganglion. Can you see?
Yes.
That's the pterygopalatine ganglion suspended on this nerve.
Maxillary nerve.
And above that would be the maxillary
See that?
strut.
Yes, sir. Is it the lateral recess, sir?
And this is the V2 coming out of this foramen rotundum. That is the foramen rotundum. See there?
Yes.
Sir.
Yeah.
So foramen rotundum lies in the floor of the middle cranial fossa. We had seen in the morning.
Yes, sir.
I had shown you.
Yes.
So that is the V2 lying in the floor of the middle cranial fossa. This is median. This median is formed from behind, crossing the carotid artery, the GSP, and form the median. Here. See this?
Yes.
Yes, sir.
In between, this is the pterygoid process.
Sir,
Now,
is
here
there
is the
lateral
medial
recess,
pterygoid
sir?
plate, and here this is the lateral pterygoid plate.
Yes.
So now, the muscle which is attached on the lateral wall of the lateral pterygoid plate. See this? I am elevating.
Yes.
See this? What is this? Lateral pterygoid muscle.
Yes.
This is the lateral pterygoid plate.
Yes.
This is lateral pterygoid muscle.
Yes.
This is the infratemporal fossa, and here from medial to here is the pterygopalatine fossa.
Yes. Sir.
Yes.
Infratemporal fossa starts here at the pterygomaxillary feature, pterygoid and the
Yes.
maxillary wall. And this is infratemporal fossa. Okay? Now this was your VDN now. Oh, sorry, V2. Why
The
I
V2.
said this runs in the floor of the middle canal fossa. See this now?
Yes. Yes.
If I drill above, what will be there?
Temporal lobe. Temporal lobe.
Temporal lobe of the brain. Because what is there in the above the floor of the middle canal fossa will be the temporal lobe.
Yes, sir.
This is the direct access to address the lesions of the temporal bone from here. This is a paramedian highway. Give me a drill to show you. Pardon?
Can you show cavernous sinus?
Yeah, we'll go. See, the cavernous sinus is behind. We are very close. What happened? See, this is the V2. This is the V2, and now I am going above the level of the V2. No section. Find out. See, that is the level of the V2. This is the level of the V2. And I have gone above here. That is the level of temporal lobe of the brain. So this is one of the most direct access, I would say. This is the temporal lobe of the brain. See this brain tissue?
Yeah.
That is the temporal lobe. So this V2 runs in the floor. This is very important to understand. Here is the V2. This is the V2. And this is the temporal lobe of the brain. Now, let me show you V2 better. See, this is the V2. I hope it is very clear.
Yes, sir.
Yes.
Very clear.
Now, important anatomy. V2 is never something which passes through the cavernous sinus. Never.
Yes.
V2 runs below the cavernous sinus. क्या हो गया? See, this is the V2.
Yes.
Going in this foramen rotundum. Our temporal lobe is here. I had shown you. Now this V2 is out of the cavernous sinus. And what is there above the level of the V2?
Maxillary
Is the superior orbital fissure. Superior orbital fissure is what? The anterior continuation of the cavernous sinus.
What is maxillary strut, sir? Strut.
Garrison?
Hello.
See this? See, this is the carotid artery.
Yes, sir.
Which is in the cavernous sinus, and see this area anterior to that. This is all superior orbital fissure. And this is above the level of the V2. Can you see this relationship? This superior orbital fissure is basically the anterior continuation of the cavernous sinus, through which all the neurovascular structures enter the cavernous from the cavernous sinus into the orbit. So this acts as a conduit. If I open this superior orbital fissure, you will see all the structures coming from the cavernous sinus. So this is very important. This region of 1 square inch is very, very crucial for the ENT and skull-based surgeons. This region.
Maxillary strut.
See the superior orbital fissure? This area belongs to the superior orbital fissure.
Yes.
Does the superior orbital fissure form the anterior boundary of the cavernous sinus?
Yes. And continuation, sir.
Yeah.
So now what I am doing, I am uncovering the superior orbital fissure. See this? Hello?
Yes, yes.
Yes, sir.
Superior orbital fissure is below. यार इसमें लगा हुआ है धागा, ये खराब कर रहा है. Scissors से काट, science से काट. See, this is the region of the superior orbital fissure.
Yes.
The optic nerve is above, superior orbital fissure is below, and the V2 is even below. See this V2 here?
Yes, sir.
And they are separated differently by different bones. Let me show you.
Maxillary
Periosteum. See this supraorbital fissure? This is the medial periosteum I am removing. See this? Medial periosteum of the supraorbital fissure I am removing. This bone, medial wall. This bone, this is a thick bone which separates the superior orbital fissure. This thick bone separating from the optic nerve is optic strut. Can you see this?
Yes.
And this superior orbital fissure is separated below. See this?
Yes.
Below from the V2 here.
Sir, if this part is
V2 by the maxillary strut.
If this part is
Yeah.
pneumatized, it's lateral recess, no, sir?
Which one?
If this part pneumatizes.
No. That is in
No,
the sphenoid sinus.
Spinners.
No, the
Not here.
pneumatized pterygoid
See, this
process,
is
it
superior
opens
orbital
up
fissure.
into lateral
Yes, sir.
recess. Yeah.
All this periosteum is of superior orbital fissure. See this?
Yes, sir.
And behind in continuity, that is the cavernous sinus.
Cavernous sinus.
Let me remove this bone to enter into it. See this? This is all superior orbital fissure bone. Now, and this below is the, give me the section. Are you oriented? This is superior orbital fissure.
Yes, sir.
Behind is
Yes,
the
boss.
carotid, that is cavernous sinus, and above is the optic nerve.
Yes, sir.
And below here is the V2. The writer. So now, once I open the superior orbital fissure, we'll go head on into the cavernous sinus.
Ah. Satish. Satish. Satish.
See what I'm trying to show you, how they are separated. These are the avenues for the tumor to spread, and some bones which are resistant to prevent the tumor spread. That's why it is important. See this bone? This is the maxillary strut. This is the foramen rotundum here. This is the maxillary strut. And this is the superior orbital fissure. See this bone? This is the V2 here in the foramen rotundum. This is the maxillary strut. This is superior orbital fissure. That bone is the optic strut, and this is the optic nerve. So now let me open the chisel hammer. Give me chisel hammer to remove this bone. Quick. some part of the sphenoid bone I am going to take down so that I can focus on this anatomy a bit. It's a very, very important region. Tumors in this region at the orbital apex are challenging. See how close proximity is there between the various compartments.
Hello.
Yes. See now my area is pretty clear?
Yes,
Yes,
yes.
sir.
So fast with the chisel and hammer. I'm now. Now focus in the, forget the lumen of the sphenoid now. This is the periosteum which is opening. See now?
Yes, yes.
Yes,
I
sir.
am opening the periosteum of the superior orbital fissure. This one. Give me scissors or something. Knife, है? Scissors, है? Scissors. See, I'm opening this periosteum, opening this periosteum of the superior orbital fissure. Now see, one by one, you'll see a lot of structures. In the superior orbital fissure. Give me the rider to remove this. See
Hello.
the important anatomy of the cavernous sinus now. See, I remove the periosteum of the superior orbital fissure. Now see, can you see some structures there?
Yes, sir.
Number one, the carotid artery.
Yes.
Can you see this?
Yes, yes.
Yes, sir.
This is the tortuous course of the carotid. See this?
Yeah.
Yes, sir.
This is the first JNU. That's the carotid artery. And lateral to that, this is cavernous sinus. Can you see?
Yes, yes, sir.
Now there are various structures coming. Can you see the nerves?
Yeah, yeah.
Above this is clinoid process. See this? An immediate relationship of the clinoid is, what is this? Third nerve, oculomotor.
Bulky.
Now, immediately deep to this, below this and deeper. Can you see the slender now?
Fourth. Yeah, fourth one.
What is this? Fourth trochlear.
Trochlear nerve.
What is this? Quite medially close to the carotid.
Six.
Six now, it passes truly through the cavernous.
Abducent.
Rest are in the lateral
Abducent.
wall. And see
Yeah.
lateral to the sixth. Lateral to the sixth here. Yeah, that is V1.
Yes.
That is lateral to the sixth. See, third, fourth, sixth, and V1. This is V1. This is V1. So this is how the lateral wall of the cavernous sinus is related to various nerves. Can you see?
Yes.
Yes. Yes. This is the periosteal layer of the cavernous sinus. If I incise this periosteum, I am laterally will be going in the temporal lobe again. See this?
Yes.
Lateral anatomy is what? See this? Again, temporal lobe of the brain. So this cavernous wall is in relationship to the temporal lobe again. So this is how the cavernous sinus and the important structure in relationship to, this is the middle cranial fossa, heavy harboring the temporal lobe of the brain. See here. This is temporal lobe. So now all the nerve, this is the abducent. They now ascend through this superior orbital fissure into the orbit and supply the respective muscles and the various parts. Now, the course of carotid artery you wanted to see. This carotid, this ascends from here at the foramen lacerum. From here, it goes back behind as a horizontal petrous you had seen in the lateral skull base. So here it ascends, has a vertical course, then horizontal, and then it is the genu. This is the genu of the carotid artery. So, and above is the optic now, and this is the opticocarotid recess. And from here, this carotid artery ascends into the subarachnoid space. See this carotid? See this carotid going in the subarachnoid space? That's the optic now. That's the optic now. And it has given this retrograde branch. See this retrograde branch, which goes along with the optic nerve behind in the optic canal. So this first retrograde branch, see this branch? This is ophthalmic artery.
Yes, yes.
So carotid has given ophthalmic artery. Now, this is your sella. This is your cavernous sinus. And if I remove this bone, I have not removed the bone on the contralateral side. This is how the chiasma is formed.
Yes.
See, that is the chiasma. That is the chiasma. That's a very important structure. And if I don't know the status of the brain inside. We saw in the lateral skull base, it was all autolyzed. Hello, see you. Oh. See, this is the sella. Can you see?
Yes, yes.
This is the sella. On either side, it is related to the cavernous sinus.
Yes, yes.
See this blue sinus. That is the cavernous sinus. See this blue sinus, cavernous sinus.
Intercavernous.
This is the true cavernous sinus lateral to the carotid artery. Can you see?
Yes, yes.
So there are various parts of this cavernous sinus, anteromedial, superior, lateral, around the carotid artery. And this is the sella. All midline structure is the sella, which is related to the cavernous sinus laterally and the carotid. This is the sella. I have not removed this bone just to show one side anatomy of this region. See this 1 square inch area. The tumor arising in this region of the sphenoid,
yes,
or the cavernous sinus or the orbital apex tend to infiltrate into different compartments, and looking at the various neurovascular structures traversing through this makes the surgeon's life challenging, frightening.
yes.
One can give damage to the cranial nerves, one can damage the carotid artery, cavernous sinus, bleeding, so many issues in this 1 square inch area. We must be well versed with the anatomy of this 1 square inch area to carry out the work safely in this region. Okay?
Yes.
This is a very, very critical area, and every pathology in every region is treatable, provided your approach, selection and approach is proper. Cavernous sinus can be addressed by various means. Can be addressed for the lateral pathologies differently, for the medial pathologies through the sella. See here the pituitary tumors. This is pituitary. Enter into the various cavernous compartments from the medial side. The lateral pathologies are different, can be removed separately by the lateral approaches, mobilizing the carotid artery medially. Then this nerve is V1. See this V1? It is coming from the maxillary. This is the petrous apex. This behind is the petrous apex, where the 5th nerve is crossing the apex and coming here anteriorly. So this is one of the approach to the petrous apex. This is quadrangular space. Quadrangular space is what? Between, see the carotid artery is below, above the carotid artery and below the abducent nerve and below the V2. You see this space. Can you see this big space?
Yes, yes.
This is to address the petrous apex lesion. This is quadrangular space. This is quadrangular space. So all, even the trigeminal tumors can be removed through this quadrant. See, this is quadrangular space.
Yeah.
Right, that bone is the petrous apex. See this carefully.
Yeah.
In the depth. So the problem here in addressing the petrous apex lesions is, as compared to the lateral skull base, the petrous apex lesions are lying lateral to the carotid artery. So this artery poses a big challenge. In a well-pneumatized sphenoid sinus, sometimes you may not be going to too laterally to address that, and in those favorable situations, one can address the petrous apex from here. Now,
Michel's cave?
Michel's cave is here, right at the petrous apex. Michel's cave is situated here on the petrous apex, from where this V1 is emerging. This V1 is coming.
Yes, yes, yes.
So it is coming from the trigeminal ganglion, V1 going up in the supraorbital fissure, V2 coming here, and V3 behind. V3 behind in the infratemporal fossa. This is the infratemporal fossa. And if you follow that, you know, the lateral pterygoid muscle. See this, the pterygoid plate, lateral pterygoid plate. If I follow this lateral pterygoid plate, see this? This is the lateral pterygoid plate behind. If I follow, go above, and we will find the V3 there behind. So V1, V2, V3, all three structures diverging from each other. If I remove this, I can reach easily to V3. Give me the divider. So, sit. This is how this pterygoid process is the key for all this neurovascular structure. All this anatomy revolves around pterygoid process. This pterygoid process is the key. Let me divide some part of this muscle to go a little inside. I am in the infratemporal fossa. See this? It collapses. See, what you see is the lateral pterygoid plate. Can you see?
Yeah.
And if you follow it behind and up, the V3 would be there. So V1 going here medially, V2 here laterally, and V3 far laterally, like this. It comes from above and behind. We have seen that is the V3. That now is V3. See that?
Yeah.
That is V3. So all the three structures are diverging from each other. JNAs are common tumors. We had seen in the middle cranial fossa floor V1, V2, V3 foramina. JNAs from here enter into the temporal lobe of the brain, where between this V1 and V2 by eroding this bone, or by between V2 and V3 by eroding this bone. And they prolapse in the middle cranial fossa above. Above this all is the temporal lobe or the middle cranial fossa of the brain.
Okay.
See that?
Yeah.
So this is all the greater wing of the sphenoid. Above, anywhere above this you go, anywhere above you go in the middle cranial fossa. So the JNAs tend to go frequently into the middle cranial fossa between these. See this V1 and V2. This is the anterolateral space triangle, and this V2 and V3, this is lateral triangle. By eroding this bone, they tend to prolapse in the middle cranial fossa. And the approach is same for them. Expose them. Wherever it has gone inside, you have to pull them out. It is always extradural. It never invades the dura. So all those JNAs you can pull down from here or from here easily into the nasal cavity. So this is about the anatomy in this region. What time is now? How much time left? 7. So any questions? Anything you want me to show further? Appa?
Perfect.
Anybody from the auditorium? No, boss, superb.
Hello?
The ventral skull base is fastest.
Okay.
Hello?
So, so anything you want me to show further? It's already 7.
Fantastic.
See
You
here.
have done everything.
Anything in your mind to be shown?
Really nothing, because you have shown us the call.
This is the first olfactory neuron, cribriform beginning. This is the
Satish,
yes.
Clivus just
Clivus is here. See this here. Give me the section. Below the sella between the two carotids is the clivus. See this? You have seen on the skull module. The clivus behind is related to the posterior cranial fossa, and all midline lesions can be, treated from here. Extradural midline lesions. See, this is clivus. This is clivus. Below the level of the sella, this is paraclavial carotid in this side and the paraclavial carotid on the opposite side. In between these two, this is clival recess. So clivus for convenience divided into various parts. This is middle clivus, this is upper clivus where the sella is, and the lower clivus where behind the nasopharynx. Address between the eustachian tube. See the eustachian tube here? Eustachian tube opposite side, and in between these two is the lower clivus to address the foramen magnum. This is the pterygoid, and see this pterygoid process. The posterior limit of pterygoid is just up to the anterior to the eustachian tube. See this. This is the pterygoid ending. This is the pterygoid process. See this?
Yeah.
This is ending just before the eustachian tube.
Yes.
Then is the eustachian tube. From the posterior edge of the pterygoids, the carotid artery is further more than 2 centimeters behind.
Okay.
That's a great landmark. See these nasopharyngeal soft tissues? The carotid artery is 1 centimeter behind the soft tissues, and that too far laterally behind the eustachian tube in this space that is fossa of Rosenmuller. So carotid artery is 1 centimeter behind and far laterally. From here it is 2 centimeters behind, so we don't need to frighten every time with the carotid artery. That's the eustachian tube orifice. So eustachian tube here again protects the carotid artery like mother's lap, everywhere anterior to it. Everywhere in the ear, the eustachian tube is lateral to the carotid, protect it. So everywhere eustachian tube protects. Yes.
Hello.
Yes.
Satish.
Yes. Yes, sir.
I think you have completed most of it.
Sir, as you
Probably
order.
you didn't show us only the chorda tympani nerve in the nose.
Chorda tympani now. Oh,
You show it usually near
shown in the
the
lateral
V3.
part, on the opposite side, the lateral part. But for the information here, the chorda tympani which comes underneath the TM joint from the middle ear, here this V3 divides into 2 divisions.
Yes.
The posterior division gives the posterior branch, the lower branch that is lingual now.
Lingual
and here
nerve,
in the infratemporal fossa, lower down in the infratemporal fossa, the chorda tympani joins the lingual nerve. That is the site.
Correct.
See, if I remove this bone, remove this entire pterygoid process, and go 2 centimeters behind the pterygoid is going to be the parapharyngeal carotid artery. So far behind. It's so well protected in the center of the head.
Yeah.
Anything more?
As you said, eustachian tube is a very good landmark.
Yes,
And
it's a great
this
landmark
carotid
for the
is at least
carotid.
1 centimeter behind. Yeah.
Yes.
No, I think excellent demonstration, Satish. We'll wind up. There's a dinner waiting for you.
Thank you, sir.
Aparna, I want you to felicitate Satish.
Oh, come on.
It's a great honor for me, not him.
Yes.
Pleasure coming here,
No,
sir.
because
all felicitation should go to Deepak, sir. Because
no. You should be felicitated by the future president of AOI.
Future president.
Of AOI. That is Apparao. Yeah.
Sir, thank you, sir. Thank you very much, sir. Dr. Satish Jain garu, wonderful demonstration.
Thank you, Nageshwar Rao garu.
Thank you, Dr.
for
Deepak,
moderating till
Deepak,
the
sir.
end.
Sir, thank you, sir.
I tell
Thank you
you,
very much.
Yeah. Aparna.
Sir,
for your excellent arrangement, sir.
Sir, I thank all the... Hello, sir.
Sir.
Deepak, sir.
Yes.
I thank you for arranging such a beautiful academic feast, not only for Bengaloreans, all across the India, So many people have benefited from this beautiful dissection, and I pray God to help to do more such programs in the day.
Still, and you know, JP Reddy, still 1,500 people watching on the YouTube.
Yes, and I also congratulate the Grandmaster, Dr. Satish Jain,
Yes.
for a wonderful show. Thank you very much, sir, for
Yes.
being a part of this program.
Now, I must give huge credit to Sushin Dutt and
Nothing to
Vishwas
speak about our
Yes, sir,
great
yes.
for staying till the end.
scientific ENT surgeon, and it's very, very friendly and very accommodative. Wherever he goes to, in and around the India and abroad, every delegate feels that they owns Satish. I know Satish. I know very well. I know very well. Everybody claims that because he is reachable and is accessible in his committed personality to improve our knowledge and our fraternity. Thanks a lot, Satish, for your kind contribution today.
Bhaskar, get everything ready. Felicitation should happen. It was my dream, Apparao, that Satish demonstrates in Trustwell one full day on a color-coded cadaver. Special thanks to Komal Chand Tetwa also, who is always there with Satish. Tetwa boss, आपका काम कैसे भी हम लोग करेंगे, छोड़ेंगे नहीं, आप चिंता मत करो.
You have to appreciate his assistant.
Yes.
The phenomenal guy. He does almost all the surgeries.
Yes. Yeah, Appa, please do the honors.
Let's give a big round of applause.
Yes. Peta.
Hey, come on. Sure, come.
Vishwas sir.
Hey,
Vishwas, Dhanraj sir. Sir, Dhanraj sir.
Vishwas and Sushin, both of you.
Sir, Dhanraj sir is here. We're just calling him, sir.
Yes. The biggest thing is Dhanraj sir is here till 7 o'clock. Kumar Anna, please hand over this. Sharnu, Jyotirmai. Last 24 hours, two of the best things happened. India won the World Cup T20.
Thank you, sir.
And Satish did a full day demonstration in Trustwell.
Goddess Saraswati, sir. Because you represent what she really teaches. I know 10 hours is not enough because you have so much of knowledge. Thank you, sir. And your timing was apt. Exactly at 18:59, you're saying, okay, shall we end the program?
Yes.
Even AOI con, sir, we remember.
Yes,
Exactly
yes.
3.5 hours you did and you closed.
No, not even 3.5 hours. He started late but finished on time.
Yes.
Angel Farna. And with a new camera, unbranded camera.
Yes, sir.
Yeah.
One. Thank you, sir.
Aparna, we have a fantastic faculty dinner. Bhaskar, tell everybody about the faculty dinner arranged today evening.
Yes, sir.
For 15 people.
Yes, sir.
Jyotirmai, Sharnu, Sushin, Dhanraj, Kumarana, Vishwas, Apparao.
Yeah, we'll finish. ಹೆಸರು ಕೊಡಿ ನಾನು ಹೇಳ್ತೀನಿ ಸುಶೀಲ್
Sir, Deepak sir.
Yes.
Hello.
Yes, tell me, sir.
Sir. Thank you very much, sir, for such a wonderful arrangements, including the excellent cadaver. And
Thank you, sir.
very much. Thank you.
We would
you
now
and your team
request
very
and
good,
felicitate
very good
our
audio-visual
nursing
very
staff
good, yes.
and our housekeeping staff who work for us.
Yes.
And we are expecting many more workshops like this from you, sir.
I would like
Many
to
more will
request
happen, definitely.
Mr. Ramesh Kumar Bhairav to come on stage. He is more than a surgeon for all of us. I remember in 2010 when I went to Sir's hospital, he taught me how to handle the superior laryngeal nerve and the interlay technique. He's been a teacher for me as well. Thank you,
Tetwa.
Ramesh. Tetwa, yes, sir. Thank you.
Tetwa ko jai ho.
Miss Ashwini from the nursing team. Ashwini. Mrs. Uma. Mrs. Rani. Mr. They're here. Mr. John. Okay, Mr. Raghavendra is here. He is our maintenance person who manages everything in the hall, from the hall. Mrs. Uma, please come. I think it's Miss Uma. Miss.
When did
Sorry,
she
my
become
apologies.
Mrs. Sir?
Miss Uma. Thank you, Uma.
I thought Vishwas knows something that I don't know.
Miss Rani. Mask down.
Photo Barbeko.
Yes, sir. Mr. John. Miss Ashwini. Mask down, sister. Mr. Raghavendra. Mr. Abdul from housekeeping. And Miss Bhagyama.
Miss Bhagyamma. And we also have Ali from Medtronic. Ali. Mr. Ali. Ali, ಬನ್ನಿ. Ali, Ali from Medtronic. Mr. Ali from Medtronic. Thank you.
ಇದ್ದಾರಾ ಇದ್ರೆ ಕರೀರಿ ಮೈಕ್ರೋಸ್ಕೋಪ್ ಕೊಟ್ಟಿದ್ದಾರೆ ಅವನು ನಿವಾನಿಕ್ಸ್ ಕೊಟ್ಟಿದ್ದಾರಾ ನಾವು ಕೊಡಿ ನೆಕ್ಸ್ಟ್ ನಾವು ವೋಟ್ ಆಫ್ ಥ್ಯಾಂಕ್ಸ್ ಹೇಳ್ಬೋದು ಅಲ್ವಾ ಸರ್ No, I'm booking. So to call it a day, it's been a great day of learning for us. In fact, the learning never ends here and it's a lifelong process. And I'm sure we will ask Satish Jain sir to teach us continuously. But this program has been a astounding success with close to 2,000 people listening to sir, learning from him in various formats. And bringing it today in front of you was the Microlabs EROS division, headed by Mr. Durga Prasad and his second in command, Mr. Bhaskar, and his entire team, who really put the energy and effort behind this mammoth experience. I think the first time in India, wherein you have brought together 4 to 5 centers along with 8 to 10 centers where it is being transmitted live and an online platform. thank you so much. And I'm sure the experiment and the experience went well with all of us. And we leave here with a great memory of understanding skull-based surgery from Sir's perspective. I hope we have all learned the valuable tips and tricks. I'd like to thank you for making this workshop possible
And
via,
Bhaskar,
yes, and Mr.
Durga
Bhaskar.
Prasad and Bhaskar. Yeah.
Thank you so much.
They both handled it very well.
And Mr.
The team
Romesh
heroes.
Soni
Yeah.
for taking care of all the people and the hospitality.
Yeah. Thank you.
Thank you so much. And we call it a day, and we hope we can attract the same kind of crowd in the next format that Deepak sir is planning. We will let you know in
Yeah.
advance. And thanks to everybody on and off the stage who have been part of the program. A special thanks to Dinesh
Hello.
Pal, audiovisual
Hello.
team. Yes.
And
Hello.
also thanks to
Raghunath Shanbhag here.
Are Raghu.
Raghunath
Hi.
Shanbhag. Yeah, watching
Yes, sir.
from
Raghunath
9
Shanbhag.
a.m.
Yes.
Yeah, I was online from 9 a.m. to 7 p.m.
Yes.
Yes,
Yes.
sir.
And
Still
Pradeep
there.
Osmani.
Really,
Yes.
really enjoyed, sir. And
Yes.
I'll also enjoy a little bit of the dinner online.
Yeah.
So with the kind of
Thank you
capacity
very much,
Micro
sir.
Heroes has, they will ship food for you elsewhere. So
No,
thank you to all the.
Special thanks to Raghunath Shanbhag.
Yes,
Hey,
sir.
sir,
Despite all the
nine
health
ಮಾಡಿದ್ದೀನಿ.
issues, he has
And
actively
Pradeep
participated.
Osmani sir also who's joined us online. Thank you for all the
Yeah.
moderators who were here in the Taj MG Road and who joined us online for making the interaction so fruitful. And a
And
special
also
thanks to.
special thanks to Sharanam Mani Patil and Apparao, who came from their place all the way here.
Yes, sir.
We had given them the option of online, but they said no, they'll be physically present. So that makes
Yes,
it special. Yeah.
yes, sir.
Vishwas, I
Pradeep,
want to express something.
yes, sir.
Uh, Words are not enough to actually, extend our gratitude to Dr. Deepak Haldipur for arranging this. And all of you, the team, it is really amazing the whole day, the amount of learning we had. And if you observed, not a single word other than the subject was spoken. That is what an academic actual event should be. And that's how it is. The quality of the cadaver, the instruments, and I say the man behind the instrument and mind behind the event. Thank you very much, sir, Deepak sir.
That's okay. It's a part of
Sir,
the game. I know.
just before this, I was talking to Apparao sir, and I told him that there's some great qualities of sir. Even if we adopt a little bit, we will reach somewhere. One of the great qualities was he has broken the barriers between all of us here, and we are all working for each other and help each other. That's the biggest thing that has happened in this workshop. Maybe yesterday, when we saw the World Cup happening, we saw that every team member delivered, whether it was the catch by Surya Kumar or the bowling by Jasprit Bumrah. So today it's the same. Everyone is a superhero here. Everybody has worked especially well for this
Yeah.
workshop, and I thank everybody. And the source of inspiration is Deepak sir, who's always behind us and helping us achieve our best. Thank you all, and thank you. Yes, sir. Just a minute.
Before concluding, we have to acknowledge the two people, Dr. Vishwas and Dr.
Yes. Yes.
Prasad,
Sushil
because
yes.
for the
Very much.
relentless work and hard work they put behind to make this
Yeah.
event, and their team also. So
Yes.
big round
Yes.
of applause to them. Yeah, please.
Yes.
Photo, Margaret. Can we have a group photo on stage, please? We just have a group photo and we'll disperse. Everybody.
And Vishwa, bring everybody for dinner.
Yes, sir.
Don't
Yes,
miss.
sir.
Yeah.
Yes, sir. Cheers.